I think some query is there in the WhatsApp.
Forget about it, man. Good morning, everyone. And today we are going to start our second session of FARA. And today we have another 4 sessions. We will start off with chest wall blocks, then abdominal blocks, then anesthesia for TKR, and anesthesia for hip arthroplasties. So very good sessions, something which you will all enjoy. I'm going to hand over to Divesh, who will be taking you through the whole of the FARA. I mean, he is the master of ceremony today. Well, he was yesterday as well, so today as well. Over to you, Divesh.
Good morning, ladies and gentlemen. Thank you, sir. Today we are beginning our first session for day 2, that is regional anesthesia options we have for chest wall surgeries. This will be moderated by Dr. Gurunath Murthy. He needs no introduction. He's a senior consultant as well as head of the unit anesthesia perioperative medicine at Modbury Hospital, Adelaide. He's a founder at RADAP, which I've personally used, and his special interests include medical education, quality improvement through technology, regional anesthesia, and ambulatory anesthesia. Over to you, Dr. Gurunath Murthy, to take us through the proceedings for RA for chest wall surgery.
Thank you, Divesh. Thank you, Shiv and Divesh, for organizing this wonderful e-conference and e-education session, particularly in a targeting procedure-specific regional anesthesia technique. Now, coming to regional options for chest wall surgery is the main topic here. And I guess this is one which has generated very high level of interest among regional anesthesia enthusiasts. We have moved variably, coming from central neuraxial blocks, or even before that, GA alone, going with the CNBs down to GAs with PNBs or PNBs alone. So varied levels of success and failures and efficacy have been noted. And we will go through this with the help of these expert panelists. And Shiv doesn't need any introduction, and he'll be talking about innovation on the chest wall. Dr. Divesh Arora, again, he's the Associate Director and Head of Unit of Anesthesia and OT Services at Faridabad. He is the main organizer of these FARA conferences, and hopefully with his guidance, we'll be able to do face-to-face workshop sometime very soon, probably early 2022, I guess. He'll be talking on regional analgesia options for thoracic surgeries and sternotomies. Anshuman Mishra is a consultant at Apollo Hospitals in Lucknow. His special interests include transplant anesthesia, onco and orthopedic anesthesia, and particularly regional anesthesia. We've been having regular chats with Anshuman about various kinds of blocks that he has achieved and wonderful outcomes. So I'm very delighted to introduce Anshuman to talk on rib fractures, scapular fractures, and clavicle fracture surgery. I think this might be one of the most difficult topics to cover today. And finally, again, our main lady of interest, who doesn't disappoint anyone in any of the conferences or workshops. She's very eloquent, confident, and I think I would call her as a freelance academic anesthetist. It's a rare found, and I'm quite delighted to have her in this panel, and she'll talk on anesthesia and analgesia for breast surgeries, and we'll briefly touch upon reconstructive procedures. Over to you, Shiv.
Yep. Thank you, Guru.
Yeah. Sorry, give me one second. All right.
Yeah, no problem.
Okay, you can start sharing now.
I thought I had already shared, but it doesn't look like. Interestingly, okay. Right. So I'll be talking about chest wall anatomy. Anatomy is always a boring subject for most people, so I'll keep it very simple. So we will start off with the basic spinal nerve, and you know that you have anterior root, posterior root, then it gives out a anterior rami and the posterior rami, and then it moves on, and you get a little cutaneous branch, anterior cutaneous branch. Okay. And it's very important because when we're talking about chest wall, we're not just talking about anterior chest wall, we're also talking about the posterior part as well. And the landmarks are important to know, especially if you're talking about doing some of the blocks near to the spine. So the spine C7 vertebrae, or the vertebrae prominence, that is easily felt. And then you have the spine of the scapula, which is actually at T3, and the inferior angle of scapula is at T7. So these important landmarks for knowing where you're going to give the block. So we'll start from the back of the back. We take out the skin. We get the trapezius, the latissimus dorsi. You take out the trapezius, you can see rhomboides major and the latissimus dorsi, and you actually see a window between that. Okay, so there is a space where the erector spinae muscle can be seen directly onto the trapezius. Okay, and then you take out the latissimus dorsi. You can actually see the on the top, you see serratus posterior superior, rhomboides minor, and you see at the bottom, you see serratus posterior inferior. So looking at schematically, if you look at between T2 to T5, you have three muscle layers. So you have trapezius, rhomboides major, and erector spinae. Between T6 and T7, there are just two muscles. So there is just the erector spinae is lying just under the trapezius. And then at T7, T12, there's three muscles again. So your latissimus dorsi comes between the trapezius and erector spinae. And lower down level, T11 to L2, again, three muscles. We have serratus posterior inferior coming between them. So these are the three erector spinae muscles. Actually, that is three muscles which forms the erector spinae. So you have iliocostalis, longissimus thoracis, spinalis thoracis, and spinalis cervicalis. Okay. So it also say that it's just iliocostalis, longissimus, and spinalis. Then again, spinalis is again divided thoracis and cervicalis. And then if you take out these muscles, we are straight onto the bones, that is the spine and that area of interest. So here we can actually see the lung. I've not shown the pleura, and then you actually see the ventral and dorsal ramus, and you see the costotransverse ligament. So when we actually pierce the costotransverse ligament and deposit local anesthetic, that's where you do your paravertebral block. And the local anesthetic is deposited over the endothoracic fascia, and it is seen that if you actually deposit local anesthetic lower down into the beyond the endothoracic fascia, then the local anesthetic can spread to the lumbar area as well. So it is usually, if you want to restrict to the thoracic area, then you have to have local anesthetic outside the endothoracic fascia. When you deposit local anesthetic under the erector spinae muscle over the transverse process, that is the erector spinae block. So all of us know this. This is how it was done. You actually mark the your spine level, 3 centimeters, 2.5 to 3 centimeters lateral to the spine process. You hit the transverse process, and then you angle it caudally or ventrally, whatever you want, and you pierce the your costotransverse ligament and deposit local anesthetic. So it was around 1.5 centimeters or so. So when you don't pierce or you don't move the needle in, you just hit the transverse process and deposit local anesthetic, that is erector spinae block. Okay. So this is like one of the figures, and here you can actually see the transverse process being marked, and you can see the white needle coming in, and you deposit local anesthetic under the So let me actually get a pointer on. Okay, so that's your transverse processes. That muscle is erector spinae. Okay, that's the costotransverse ligament. You got the pleura. So when you hit the transverse process at 11 o'clock position, deposit local anesthetic, it actually will spread to the under the erector spinae. Okay. But when you actually pierce the costotransverse ligament, that's the costotransverse ligament, and deposit local anesthetic there, that is your paravertebral block. Okay. This is just taken up from one of the publications. So that is the capillary end, caudal end. Okay, that's a medial end. And you see that's a costotransverse foramen. So when you deposit local anesthetic around this area, it will actually seep through the costotransverse foramen and go into the your paravertebral space. So you basically get paravertebral block by depositing local anesthetic outside this space. Okay, so just under the erector spinae muscle. Then we actually we go slightly more anterior. So from the back, we go, you can give intercostal blocks. It has gone out of favor because if you want to actually use intercostal block, it need to be a little posteriorly. And you need to make sure that you have deposit local anesthetic at each level. So if it's for individual rib fracture, it will probably work. So if you have one rib fracture, you block the intercostal nerve, you will get that. But the absorption of local anesthetic is pretty high in this area. So we move in a little bit more anteriorly, looking at the anterior chest wall. And here we have innervation not only from the intercostal nerves, we also get this, top of your skin or just below the clavicle is supplied by supraclavicular nerves, which are coming from cervical plexus. We discussed about them yesterday, and we actually showed how they can be blocked. But that's only important if your incision is going to extend into that area. And there are other nerves which are actually involved. So you also have the lateral pectoral nerves, medial pectoral nerves coming from brachial plexus, which supply the muscles, that is the pectoralis major and minor. And those are actually involved in the surgeries for breast. So that will be discussed. There's another block, which is where we deposit local anesthetic under or over the serratus anterior plane block. And the serratus anterior is actually, it's kind of originating from the ribs and then get inserted into the medial border of the, scapulae. So it's got multiple interdigitations, and there are 8 of them. So there is actually initially serratus anterior block was described as depositing local anesthetic at the 5th rib level. Okay, mid-axillary line above the serratus anterior. But when it was compared to giving local anesthetic under the serratus anterior, the analgesia was considered to be better. So it's an anterior serratus anterior and posterior serratus anterior blocks, but posterior serratus anterior block probably better. So just go at the midpoint of the 5th rib and the mid-axillary line, and that's where you are actually going to deposit the local anesthetic. You also have to remember that there is nerve to serratus anterior long thoracic nerve of Bell also going along that. So that can also be stimulated or will also be blocked with local anesthetic, which is actually given above the serratus anterior. That's just more of the, magnified image of the same again. Then coming anteriorly, we have pectoralis major and minor. And the pec block 1 and pec block 2. So here we're looking at the lateral pectoral nerve and medial pectoral nerve blocks. So they are arising from the lateral cord and the medial cord. So this is the infraclavicular area. You can see on the right side on schematically. So you see that the lateral pectoral nerve coming lateral cord, the medial pectoral coming from medial. And there is also a communication between the two. So depositing local anesthetic near to each should block both of them, but that was not the idea of pectoral nerve blocks. So you can actually see in this diagram, you can actually see that there is the your pectoral nerve, lateral pectoral nerve, and the medial pectoral nerve. Medial pectoral nerve supplies both a pectoralis minor and major. So these are important when you have surgery which are involving this, or if say there is also implants being put in, which cause stretching of this muscle and pain can come from that, then you need to actually block them. So PEC 1 was basically depositing local anesthetic under the pectoralis major, but then the analgesia wasn't perfect. and then PEC 2 was described. Now, PEC 2 is basically PEC 1 and PEC 2. So you will have to do a local anesthetic deposition under the pectoralis major, as well as local anesthetic deposition under the pectoralis minor. So it is actually a 2 blocks. It's not a single block, PEC 2. PEC 2 is a 2 blocks. Yeah. So these are all used for, the breast surgeries. And then came the transverse thoracic block, or some call it parasternal intercostal block. So the anterocutaneous nerve, they supply the sternum. So they were looking for anesthesia or analgesia for the sternotomy in cardiothoracic surgeries. And that block came into view. Then again, there is anterior and posterior PIP or parasternal intercostal block. And in this diagram, you can see E is the sternum. Okay, and there you can actually see the internal thoracic artery and vein, and you can see the anterior cutaneous branches coming out. So they are very close to the blood vessels. So when you're doing these blocks, you have to be careful and make sure you always aspirate before you inject. Okay. This is more looking from inside. So local anesthetic can be deposited over or under the transverse thoracic muscle. So it is also called transverse thoracic block. And either way, so you can see the nerve actually pierces. They pierce the transverse thoracic muscle before they supply the cutaneous nerve supplying the skin on and the sternum. So you can deposit local anesthetic under or above, whichever it is. So there are 2 blocks. Okay. This slide, which Guru actually has shared with all of us, actually shows all the blocks. So you can start from the rectospinal block, paraorbital block, the intercostal blocks, then the serratus anterior block, which can be deep or superficial. Then you have PEC block 1, PEC block 2. And anteriorly, you have PIP, that is the parasternal intercostal block, which can be again deep or can be superficial. And I think that's the relevant anatomy. So you can actually block the nerves, know what is surgical anatomy is, and accordingly, you can actually block the nerves wherever you actually feel comfortable with. Over to you, Guru.
Thank you very much, Shiv. And I think if somebody wants to learn to teach anatomy, or more appropriately, applied anatomy, this is what it should highlight, because applied anatomy is more important aspect, that you simultaneously learn the implications of doing the block. And then we've got other experts in the team today who will talk about how to do the blocks and the choice of blocks and things. So just to summarize what Shiv again said, you need to remember the contributions from superficial cervical plexus, the brachial plexus, and the intercostal brachial nerves. And then this is the same slide that Shiv told at that moment. So in total, the intercostal nerves can be blocked in 3 aspects: the anterolateral chest wall blocks, which could include the superficial and deep serratus plane blocks, and the PEC 1 and PEC 2 blocks. The anteromedial chest wall blocks. There are multiple types of anteromedial chest wall blocks. And again, don't be flustered by the nomenclature that comes up here, because there is PIPs, there is TAPs, TTPs. Who knows what APs and PPs will come up in the near future. Looking through the literature, at least there are about 10 descriptions of various kinds of blocks for an intercostal nerve block. And among these 10, basically, they are small variations in your ultrasound placement, the probe direction, and needle direction. So essentially, it's a tissue plane block. And if you deposit local anesthetic somewhere over here or here, it doesn't matter. It spreads across. But people are very keen to put their names and things like that. And finally, there is posterolateral chest wall blocks. So there is retrolaminar blocks, there is erector spinae blocks, there is paraspinal intercostal nerve blocks. And if you want me to go on, I can name 10 other names that have been given around this area. So we won't go in detail about all these things, but what's important to learn is the anatomy, or more appropriately, the applied anatomy. So next, we will go to Divesh Arora, who will present on analgesia for chest wall, thoracic surgeries, and sternotomies. Okay, so just over to you, Divesh. Thank you.
Thank you, Dr. Guru. So, is my screen visible to everyone?
Yes, Divesh.
Okay. Good afternoon, everyone. At the outset, I bring greetings from Asian Institute of Medical Sciences, where I've been working for past 11 years. So my topic is regional anesthesia options for thoracic as well as midline sternotomies. So we all know that thoracic surgeries are one of the most painful incisions, and the pain which occurs is multifactorial. It has got a nociceptive, neuropathic, as well as rapid pain component. And even if you are giving regional anesthesia, one technique may not be enough to cover each and every aspect. And if pain is not treated properly, at the end of around 6 months, we might have 47% of the patients experiencing chronic pain. So we need to have some form of multimodal anesthesia, and with RA being the cornerstone. So you must be wondering why I'm showing you this food court kind of a thing. We have all been to food courts and it gives us autonomy. I like to have Chinese, my wife likes to have South Indian, my daughter likes to have Subway. So what I'll be presenting is the food court approach to regional anesthesia techniques in the context of thoracic surgeries. So this slide is the key. We have to understand that it's the intercostal nerve which needs to be blocked for providing effective analgesia. Guru has already shown you in some different formats. So I'll be covering not each and every block, but set of blocks which are most important in context of thoracic wall surgery. So what are the options we have? Starting from posterior, we have epidural, then moving slightly away from the midline is paravertebral, then we have host of blocks. For example, the paraspinal, the posterolateral chest wall block, the enterolateral and enteromedial. I'm not here to confuse you. I'll be presenting the best of the blocks and the evidence in favor for analgesia options for chest wall surgery. So if I address them as a big RA family, then I would like to call the epidural as the father of the RA family, paravertebrals as the mother of the RA family, and all these blocks listed below as the children. And we know in our Indian context as well as around the world that it is the mother or our wife who's managing the home well. So starting with the so-called gold standard around 15 to 20 years back for pain management, but its role is diminishing. First of all, it has got bilateral effects. Patient may have bilateral sensory numbness or bilateral pain relief, which may not be desirable to patient who has had a right kind of a surgery and his left side is also getting blocked. And we have used epidurals, thoracic ones, and we know hypotension sometimes can be intractable and it requires intensive care monitoring. But in last 20 years, a lot has changed. So what we are seeing is many regional anesthesia options available to us, better understanding of the RA anatomy and availability of the ultrasound machine. So I describe first the thoracic paravertebral block. Dr. Shiv has already given an overview. My job has become much easier. Paravertebral block basically is the injection of local anesthetic into the paravertebral space, and it results in the ipsilateral somatosensory and sympathetic blockade. And it has been called as the gold standard for hemithoracic anesthesia. So let's look at the anatomy. It's a wedge-shaped space located by the side of the vertebral body. So its medial boundary is the vertebral body as well as the intervertebral foramen. Enterolaterally, we have the pleura. Posteriorly, we have the costotransverse ligament. So it contains the adipose tissue, the dorsal ramus, the ventral ramus, the sympathetic chain, as well as the rami primitanch. And the beauty of this block is that it medially this space communicates with the epidural space, laterally with the intercostal space. So Technically, it spreads medially as well as laterally and cranially forward. So there are various approaches, ultrasound guided approaches, which have been described in literature. One is the transverse imaging, another is the longitudinal parasagittal imaging, and further subdivisions being in-plane and out-of-plane techniques. So what I'll describe is a parasagittal imaging with an in-plane approach first. The beauty of this block is that it can be done in a lateral, sitting, or a prone position. It's a superficial kind of a block, so we need a high frequency linear probe. As you can see in this image, the probe is placed in a parasagittal paramedian orientation. And approach is generally, I prefer a caudal to cranial direction, and drug is generally around 20 ml of ropivacaine 0.375% or bupivacaine 0.25%. Catheters can also be thread in this plane very easily. The end point which we are looking for, which I'll be showing you in the video, is the anterior displacement of the pleura, or sometimes it is called as a pleural drop. So this is a small video which I'll be showing. We first always scan from around 7 centimeters away from the midline. First, we appreciate the ribs, which are roundish. Then we start moving towards the midline, where we actually appreciate the transition of contour from the ribs to the transverse process, which requires squarish appearance, and then the muscle appears underneath the borders. If you are in the first 5 cases, that is the case. So I'll take you to the scanning video first. So as you can see the round structures, these are ribs. As we start moving medially, a muscle comes into view, that is the erector spinae muscle. And there is a change in the contour which is happening. You can see there is a square kind of a appearance. This is the transverse process. So once you see that, a slight outward rotation, as recommended by Dr. Karmakar, helps in getting a better view of the anatomy of the paravertebral space. Now you can see a much better paravertebral space. Now I've turned the probe a little outward. You can see the pleura as well as you can see the superior costal transverse ligament. So now I'll be showing you one thing. I'll be showing you the video of the same in-plane approach parasagittal imaging. One second, there is some glitch in plane. Just give me a time. Sorry for this glitch.
It's okay, Divesh. If it's not playing, it is playing now. Yeah,
it's playing now.
Yeah.
So we see the needle coming from the caudal side. Transverse processes are seen, and we give a test injection whether we are in the right plane. Initial test injection, as you can see, is in the intertransverse tissue complex. So I go a little more, like a millimeter or so, then give another test injection. It's also in the wrong place. So I go a little more, and now I'll be successful because I have got a sensation of piercing the superior costotransverse ligament. And what I can see is the anterior displacement of the pleura, or the pleural drop, it has been called by some of the authors. So the final drug can be injected and it can be easily seen to spread in a cranio-caudal direction. So if we actually see the needle trajectory in the in-plane approach is quite steep. So at times we may find difficult approaching the paravertebral space. So another approach that has been described is the outer plane approach. Here the needle entry is almost flush to the probe, and the angle of needle entry has to be less than 5 degrees to the probe. Otherwise, the needle shadow which we will be visualizing would be of the shaft, not of the tip. So I'll play the video. So we see the needle entering through the midpoint between the two transverse processes. So first test injection is made between the erector spinae and the intertransverse ligament, and subsequently we see the pleural drop. So some of the authors have described the transverse imaging and in-plane needling, but there are certain disadvantages because we are moving in a lateral to medial direction and we are very close to the neuraxis. So a large volume of the drug, if deposited in this place, can lead to inadvertent spread to epidural or intrathecal injection. That is why generally majority of the authors do not recommend this kind of imaging. So what are the side effects and the complications? First, I like to quote from 1995 article. It was like incidence was 1.1% of pleural puncture, pneumothorax 0.6%. But over the years, in 2017, a review had been carried out for 1,000 cases, and the incidence has dropped. Please bear in mind, these blocks were performed by the people who were experienced. So it's experience level of block which has to be performed, not by beginners. So what is the efficacy? We have to compare it with the so-called gold standard, that is the thoracic epidural. So in a meta-analysis in 2014, the visual analog scale at rest as well as coughing were similar in both the groups. In Cochrane meta-analysis in 2016, again, paravertebral was in comparison with the thoracic epidural. So coming on to the next block, the erectospinal plane block, one of my favorites. Dr. Shiv has already given an overview. This makes my job much easier. It was first described by FARA and colleagues in 2016. Is essentially a paraspinal musculofacial plane block where the LA is deposited deep to the erectospinal and superficial to transverse process, and it targets the ipsilateral spinal nerves. So what is the probable mechanism of action? So this has been given as a narrative review in 2021 in Canadian Journal of Anesthesia. So whenever we deposit a drug deep to the erectospinae, superficial to the transverse process, the drug spreads in 4 directions. Number 1 is inside the paravertebral space to the costotransverse foramen. Next, it goes underneath the erectospinae as shown by figure number 2, posterior to the dorsal ramus as shown by number 3, and laterally to number 4. However, the lateral spread is restricted by the thoracolumbar fascia attachment. So majority of the cadaveric studies, if we have gone through, they will show that it certainly blocks dorsal ramus, but ventral ramus is occasionally blocked. So, but in live patients, we have been using this block since almost 4 years. We have got wonderful results. So what is the difference between a cadaveric as patient or as well as a live patient? So what is happening is the active muscle contraction is happening. The erectospinal muscles are contracting, whereby they push the local anesthetic inside the paravertebral space. And second mechanism which has been cited is the negative intrathoracic pressure, which actually pulls the local anesthetic towards the paravertebral space. So how do we actually do it? It's almost similar to paravertebral, except for the fact we do not go up till the costotransverse ligament. We deposit the drug on top surface of the transverse process. So it can be done in a similar fashion. What I'll describe you initially is the in-plane approach. The idea is to deposit the drug on the top surface of the transverse process. So this is a small video. The needle is coming from the caudal direction. We try to aim for the bony surface of the transverse process. Initial test injection is given. It was not in a good place. The subsequent injection was given, and it was found that it is lifting the ESP off the surface of transverse process. Then the remaining volume of the drug is injected, and you can very well see the ESP is lifted off the top surface of the transverse process. So we started this block in 2017, and we were doing exclusively for breast surgeries at that time. We found that the needle trajectory at times was very steep. So what we described was the out of plane approach, almost similar to paravertebral, and this was published in Anesthesia, Pain and Intensive Care in 2020. It's almost similar to the out of plane approach for paravertebral. Needle is almost flush to the, as you can see in the left side image, needle is flush to the probe, and needle shadow can be appreciated. And once we reach the transverse process, the drug can be injected. So the big question comes, where to inject? Various authors initially had described, the initial author had described to inject on the top surface, of the transverse process. But we know the exact mechanism is, drug has to seep into the paravertebral space, which is located here. It is a proxy paravertebral block. So the best target would be at the end point of the transverse process or anywhere between the erectospinal plane muscle as well as the intertransverse ligament. This is the intertransverse ligament. And believe me, I've tried a couple of times. We get a distinctive pop once we are there in the space, and rest of the procedure can follow as usual. The drug volume is around 20 ml of 0.375% ropivacaine or bupivacaine 0.25%, and it generally covers 2 to 3 segments cranially and 2 to 3 segments caudally. So all of us who have given that in-plane approach have realized that sometimes we are inside the muscle and we get some kind of muscle laminations. So there are 3 approaches, transverse approaches, which have been suggested, one by Rashka, one by Madan Narayanan, one by Santosh Kumar Sharma and colleagues. So the advantage this side is, like, if you are using a transverse approach, then the intramuscular injections can be better identified. So I leave it to you whether you want to go for this approach or not. So how does it compare to the gold standard for hemithoracic anesthesia, that is the thoracic paravertebral? So it was similar for the pain score at rest as well as for during coughing, and it is a recently published randomized controlled trial. So if we come do the meta-analysis for breast as well as thoracic surgery, in comparison to no block, it was superior, and in comparison to thoracic paravertebral for thoracic surgery, there was no difference in pain scores. So it can be compared to thoracic paravertebral. So to summarize for ESP, it's a technically easy to perform, easy to teach, can be used in patients with anticoagulation. We have inserted catheters, and it can be used in previous spinal surgery, although we do not have any experience, and theoretically is safe, because if you compare with epidural analgesia or with pleural punctures, theoretically it is safe. So another block which has already been described by Dr. Shiv, it is a serratus anterior plane block. It was described by Rafi Blanco and colleagues in 2013. Both targets are there, superficial and deep. If we do a deep target, then thoracodorsal and long thoracic nerve, we do not block. So how do we actually do it? It can be done in lateral and supine position, and better in lateral position in context of thoracic surgeries and supine in context of breast surgeries. So the needle comes, generally my preference is from anterior to posterior, although it can be done in a coronal plane also. The 2 targets, superficial or the deep. So I'll show you a small video. So the needle is coming from anterior to posterior. We can see the pulsating thoracodorsal artery. This is a good identifying mark that we are in the right plane between latissimus dorsi and the serratus anterior. Once we unzip this plane, then our needle can be taken forward in the lens of the local anesthetic created, so thereby blocking the lateral cutaneous branches of the intercostal nerves. So how does it compare in thoracic surgery? When we do it, when we compare it with the systemic analgesia, it is superior. And I cite from Saudi Journal of Anesthesia 2018 RCT, where for first 12 hours, it was almost comparable to paravertebral. And if we compare it with paravertebrals for bats, it was almost non-inferior. So how does serratus anterior compare with erector spinae? Although it's a retrospective study, but erector spinae at all points for VAS score, for post-operative morphine consumption, scores better. So to summarize, it's also an easy block. It doesn't cause sympathetic block, and catheters can be inserted, and you have to view the thoracic thoracodorsal artery. It's a good landmark as there is a structure to avoid. So PEX2, it has also been, Dr. Shiv has given an overview. Dr. Rafael Blanco first described PEX1 in 2011, then subsequently in 2012, he described PEX2, which is actually a combination of 2 blocks. So the technique of PEX2 is very simple. We first place the probe in the lateral intraclavicular fossa as if we are doing the intraclavicular block. Then we visualize axillary artery and the vein, and then subsequently we move the probe along the deltopectoral groove and in the intromedial direction, reach the 3rd or the 4th rib and do a 2-phase injection. First in between the pec minor and the serratus anterior, and then subsequently between pec major and minor. I'll show you the scanning video first and then the video. So This is the axillary artery and the vein, intraclavicular position of the probe, and we see the slight medial tail. We get to see the second rib coming underneath the vessels. Then we move along the deltopectoral groove in the introlateral direction, and we see pec major, pec minor, and the serratus anterior coming into our view. There is the third rib, and we reach almost there. We realize pec major, minor, and the serratus anterior. So this is generally the target for our PEX 2 and the PEX 1. So now I'll show you the video. Needle coming from supromedial to introlateral direction, pec major, minor, and the serratus anterior. So once we give a test injection, we are confident that we are in the right plane, and subsequently the whole of the block can be done. So serratus anterior, in response to serratus anterior plane described by Rafael Blanco in 2013 in Anesthesia Journal, I wrote a correspondence that you will not be able to cover the medial portion of the breast unless and until you block the anterior cutaneous branches. In 2013, I didn't have that much of knowledge, but I coined this as pectoralis major plane block. But somehow this got unnoticed or ignored by the who's and who of the regional anesthesia. So how does it compare with the other blocks? So this is a randomized control trial published in 2013. They compared the serratus anterior, PEC 2, and intercostal nerve blocks for post-thoracotomy pain after pediatric cardiac surgery, and serratus anterior as well as PEX 2 fared better in comparison to intercostal nerve blocks. So this is another randomized control trial from AIMS, the Apex Institute of our country, and they compared serratus anterior, pectoral nerves, and intercostal nerves for analgesia in adult cardiac surgeries, and they found that serratus anterior had the highest time to first rescue analgesic requirement. So friends, my idea was not to confuse you, but to give you an overview that which blocks can be used for thoracic surgery. So choice of block will certainly depend on the hospital setting, the surgical incision plan, which we need to discuss with our surgeon in advance, our expertise as an anesthetist, and whether the facilities for acute pain services are available or not. We are all familiar with the prospect guidelines. For thoracic surgery, these guidelines were published in 2015. I think we are due for revision. As per their recommendations, paravertebral block with or without continuous infusion was rated as the first choice. Thoracic epidural was rated as the second choice. So in the initial comments I made, I mentioned that epidurals are the father of the RA family and the paravertebrals are the mother of the RA family. But we all know that the mothers manage the house pretty well and our wives too. So it's ultimately the paravertebral block which wins. But we have children in the RA family, that is the ESP and the serratus anterior. As more and more evidence grows, that means our children keep going. Maybe in the next guidelines, we might find ESP scoring as a topmost position. So coming on to the RA techniques for midline sternotomies, the anatomy has already been covered. Close to the midline, the intercostal nerve gives rise to the anterior cutaneous branch, which pierces the internal intercostal as well as the external intercostal aponeurosis and gives rise to a medial and the lateral branch. The lateral branch is particularly important for analgesia up till mid-clavicular line. So this is the rationale for blocking these nerves for midline sternotomies or for covering the medial half of the breast surgeries. So two blocks have been described. One is the pecto-intercostal facial plane block, similar to the block which I described, that is the pectoral major plane block. It was described in 2014 by Patricia and Luke. It's a musculofacial investigative plane block. It specifically targets the anterior cutaneous branches, where the LA is deposited deep to the pec major and superficial to the intercostals. So how do we do this block? The patient position is to find a high frequency linear probe can be taken and place the probe 2 to 3 centimeters lateral to the sternum in plane approach is preferred, order to plane direction, and generally 15 mm of probe to the plane or half length to the plane. So this is the Soma anatomy. These are the costal cartilages. This is the pec major. This is the internal intercostal, and a high frequency band which you see underneath is the transverse muscle, which Dr. Shiv has already shown. So our target for this PIFE block is between pec major and the internal intercostal. So I'll take you through a small video. So the needle, as you can see, is coming from the caudal direction. This is the pec major. This is the internal intercostal. As we pierce, we get a distinctive pop, and we can do a test injection, and following that, the rest of the drug can be injected in this plane. This provides good analgesia for midline sternotomies as well as for coverage of medial half of the breast surgery. So another block which was described subsequently in the subsequent year by Ushima and colleagues was a transversus thoracic muscle plane block. This actually is nothing but one level deep between the internal intercostal and the transverse thoracic muscle. Dr. Shiv has already shared the nuances of this. The internal thoracic artery or the internal mammary artery lies in this plane, and the needle inadvertently can go into this artery and can lead to catastrophe. So this requires considerable degree of expertise. I normally do not do this, so I cannot show you a video of this. The idea is the needle will come in a similar fashion. Let me use the pointer. So needle will come in a similar fashion. Instead of this first plane, we'll pierce the internal intercostal, and this hypoechoic muscle is transverse thoracic. But in this kind of a view, it can be the internal thoracic artery also. So the experienced people have, what they have advised is turn the probe in the transverse direction also to get a cross-sectional view of these arteries and then decide the final injection point. So that's all from my side. I hope I have been concise. Thank you very much.
Wonderful, Divesh. Wonderful family talk. If you have to give any family talks, like parental guidance is not required here. It is for everyone in the family. Like beautiful descriptions.
Overshot the time, I think.
No, that's fine. Don't worry. It was very engrossing and beautiful descriptions and beautiful videos. Thank you very much. Just one quick question for you in relation to this blog. Now, somebody asked online saying that, look, if you have to go to Delhi or if you have to go to Noida or Faridabad, should I just drop this person at Delhi and let them walk to Noida or Faridabad? So by the time they reach there, either they will be exhausted or very little of them will be alive. So this is in analogy for TPVB versus erector spinae block. Do you agree with that statement?
So I think it all depends on the expertise and the structures which are there in the plane, what we are going to encounter with our needle. For example, transverse thoracic, I've been trying to study for the past, I think, 1 month or so. I find it a little difficult. ESP I've been doing for last 4 years. So my tilt would be certainly for ESP. Maybe after the next 6 months, I might like to change my statement if I start giving PTV. And
no, I'm asking for ESP versus thoracic paravertebral.
Okay,
so
I misunderstood.
So you drop in Delhi, let them walk to Noida or let them walk to Faridabad, right? So ESP is dropping in Delhi, whereas dropping them straight to your house is TPVB. So what do you think of this analogy?
My apologies, I misunderstood TPVB as transverse thoracic.
Yeah, so that's the problem with all these nomenclatures here. Yeah.
Okay. So my take is very simple. I would prefer ESP. The reason being, I work in a department where I have consultants with different levels of experience. So ESP is much easier to teach, and it is easily reproducible. And plus, it offers analgesia almost similar.
Okay.
I won't say superior. At times, it can be inferior also. Plus, I am much away from the pleura as well as from the neuraxis. So the incidence of side effects is almost negligible. And as the team leader, I can have peaceful nights.
So the trade-off is the trade-off from efficacy is safety. Shiv has got something to say. Yeah, no, absolutely agree. Shiv, no, can you unmute yourself?
So the analogy is actually pretty wrong. It's about
Okay.
like traveling. Yeah, it's like traveling from one city to another city, whether you take a flight or you take a train.
Right.
Okay. Yeah, so
Okay.
it's about time you're going to actually reach there. It's not about that you're going to get exhausted. It's
Yeah.
about the
Or very
time.
little of you is left in there, because there is a possibility of systemic absorption. When you deposit in an erector spinae plane, some of the local anesthetic gets, before it can translocate through different tissues. But
Yeah.
I think I got the answer from Divesh, which was excellent, and
Safety
an
is
excellent
like,
trade-off. Yeah. We'll move on to the next topic. A difficult one from Anshuman Mishra is about analgesia for rib fractures and scapular fractures and clavicle fractures. So hopefully we'll run on time, and over to you, Divesh. Sorry, Anshuman. Can you unmute yourself, Anshuman, please?
Yeah, can you hear me now?
yeah. Go ahead, Anshuman.
After such a lovely discussion of anesthesia and anatomy, two deadly combinations from two great persons, actually I have to speak of something which is not very fanciful, because after going through so many things and the timing, Indian time right now in a Sunday afternoon, afternoon post lunch, I am going for a topic which is not very good. And problem is that even if you search for that, the topic that I'm saying is ribs, scapula, and clavicle. If you search the whole anesthetic space for a scapular fracture, only Dr. Kala, who is also a panelist in this discussion, she only has a scapular presentation, which she has done in a regional anesthesia part. So that shows how difficult and how many cases we were usually doing and we're posting. So my topic, so that's why I have put it very simply, chest wall blocks for not so fancy fractures. So basically, these are not fractures people are very aware of or they see day in and day out. But the problem arises when you have a fracture like this, what you do. So rather than doing it from ribs, scapula, and clavicle, I thought, why not go start with the clavicle? It's the beauty bone. It's the one everyone is fascinated with, and it's probably slightly easier to start the topic. So now the first question is why clavicle fracture is important. Number one is that it's extremely common. So if I have any trauma into the anterior chest wall, shoulder joints, or something like that, you are bound to get a clavicle fracture. Usually the management is, as you have heard and have learned from the MBBS time, it's an immobilization with a type 8 bandage. That is what is necessary. But the question arises now, we are seeing a lot of patients who are, we have to go in for a clavicle fixation. And we need to understand why clavicle fixation is difficult and what needs to be done. When we do read about this clavicle and we start finding out what are the ways of doing it, we see there is a term which keeps on coming quite frequently, and that is a clavipectoral fossa. So what is important is why it is important and what we should be, why we should be knowing about this clavipectoral fossa. So usually when you see a clavicle fracture, it shows that the medial 1/3 are the least affected. Most commonly, you see a fracture in the middle and lateral are rest 15%. Probably reason being that the middle part has got a slightly more, they're not connected to any other supporting parts, and that's why they are more easily fractured. Interestingly, when you go for an gender-based thing, somehow I found while I reading this thing, I found out that in the males, I mean, the right side scapula is thicker and stronger than the left side. This is something I learned when I was reading up through clavicle. I don't know, but this is something interesting. Now, why clavipectoral fossa is important and what we should be knowing of this. So this is a very beautiful diagram. If you can see, if this is the lateral side and this is the the medial side, if we start seeing the nerve supply, this is basically clavipectoral fossa is a tight fossa which completely surrounds the clavicle. So what happens is that when this, if you see all the nerve supply, I'm not going to name all those nerve supply, but what I'm trying to see. I'm very poor in anatomy, so I'm trying to go help you out with those persons who are like me. So we have some cranial nerves are also involved. And then you have all from C3, C4, 5, 6, 7. All these nerves are involved. So if we can do something to deposit the local anesthetic inside the clavipectoral fossa, there are benefits. Benefits like you can block all these things at the end part. Number two, clavipectoral fossa is a very tough structure. So when you deposit the local anesthetic, they won't seep out. So they will be in contact with the exposed nerve endings there, and the quality of block will be very good. Now, again, we come again back to the question, why brachial plexus and what is its role? So if we see the brachial plexus, again, we're after the yesterday's that the shoulder joint thing, and brachial plexus is very important in whatever we do in clavicle, scapula, and also ribs some part. If you see, these are the four nerves that are very important in clavicle fracture. Nerve to subclavius, suprascapular nerve, lateral pectoral, and axillary nerve. Now, when the question arises now, if you have a clavicle fracture, usually it is associated with other fractures like scapular fracture or some fracture on the other end, if they a shoulder joint fracture. So this is a very good table that shows what needs to be done. Suppose we have a, let me run you through this one. Suppose you have a clavicle fracture without a scapular fracture. Then our first choice could be just a clavipectoral facial plane block. But the problem arises that piercing a clavipectoral facial plane block, if you're doing it in a regional anesthesia part only per se, it's very difficult. And it's a very tough structure to pierce, and it is very painful. So if it is in choice, then I would definitely rotate it with, collate it with GA and add it, and then we'll do. Second choice is definitely the selective supraclavicular nerve block and the selective upper trunk block. Then if it has also with a scapular fracture, then my first choice would be interscalene block, because scapula, when we follow scapula, we'll again see interscalene block will take care of most part of scapula and almost all part of the clavicle. So that can be done very well. And suppose, but the problem with that, suppose there is a revision surgery, or there is an implant removal, or there is a non-union or malunion of surgery, then the problem arises, the clavipectoral fascia is not that well distinguished. So we go for something like a selective supraclavicular block and a selective upper trunk block. Now, clavipectoral fascia blocks are not, it's very simple to do. You just need to do an high frequency linear probe for this one. And as you can see from this, so this is the medial side, and this is the capillate, and this is the caudal region. So this we see, this is the clavicle, this is the pec, this is the subclavius, this is the intercostal muscle. So we see the needle will be coming from this side. The fascia is a very tough structure just below this. So you need to pierce the fascia, deposit here somewhere around here, so that this thing opens up, and that will stay. So I'm just showing a small video of a clavipectoral fascia block. So if you can see, appreciate, the needle is piercing here, and it is slowly start to deposit over here. Just worried about one thing, that if you are in the periosteum, you cannot inject. So you just need to come out a millimeter or so, and then you can slowly, if you can appreciate, either the local anesthetic is being deposited in this clavipectoral fascia. So this clavipectoral fascia, this deposit will be there for a longer duration, and the quality of block that you get is a much better block for a longer duration. Now, how do I do it? So if we are going for a sole RA, my choice would be specifically upper trunk block with a selective supraclavicular nerve block. My only point is that what we do is that we give a xylo ADR of 1% only, both 5 ml. So what it does is that it preferentially blocks the upper trunk and the supraclavicular nerve. And once we do that, prior to surgery, we just inject the 0.375% ropivacaine, 10 ml in clavipectoral fascia, both medial and lateral. So it takes care of both sides of the fracture, because if the clavicle is fractured in the center, you have got two exposed surfaces and nerves are crossing. So you have to deposit 10 mils in each side of both medial and the lateral side. But if it's only with general anesthetic and plus regional anesthesia, then I would go for a GA and direct with clavipectoral fascia block. If you are trying to put just to do it under a clavipectoral fascia block, it's very difficult for the patient also, because when you're piercing, it is tough for you to pierce, and when you're piercing, the patient gets a lot of pain. My call is going in for a sole RA if that's the combination. Now, question, I just say, how do we do a lateral supraclavicular? I mean, how do we do a supraclavicular nerve? So I've taken this picture from the Google. So the thing is that if you see, the supraclavicular nerve comes out this, and then it divides to lateral, intermediate, and medial part. So when you see, put the probe in the interscalene level, and we see the C5, C6, and C7, and we slowly slide the probe down in the superficial cervical plexus area, you get the supraclavicular nerve region. You can see the nerve also beautiful. Hold on for a second. So this is basically, this approach is in plane from lateral to medial side. So it will enter from, we'll be entering from one side and deposit. So this is the supraclavicular nerve, and the needle is coming from in frame from lateral to medial. So needle is coming from this side and it is depositing over here. You need only small volume of LA to perform selective block. The reason I use a 1% ligno ADR, so that it just gives me that much of time, so that I get sufficient time to pierce the clavipectoral fascia and deposit the block roping. And once the surgery starts, it is taken care of by the roping. And this is the article I looked into. This is a very good article. It's a beautiful article, and they have discussed a lot of things and how to do the surgery in for this fractured clavicle. Now, coming to the next difficult part is the scapular fracture. It is an extremely uncommon fracture. It is only 1% of all, and it's usually secondary to a high velocity automobile accidents or something like that. It is usually associated with a fracture of clavicle, ribs, and shoulder joint. Now, there are different techniques explained. Let me read you through that. Cervical epidural, selective dorsal scapular, erector spinae, interscalene, suprascapular, serratus, thoracic, rhomboid intercostal block. Now, the question arises, why you are having so many numbers? Why so many different techniques are explained? That's because that we will be explaining when you go what we want to look into when you are doing a scapular surgery. So when you must, this is a beautiful table. Let me run you through this one. When you do a small, simple incision, that is the skin from the tip of the acromion to the tip of the scapula, we are seeing the nerves we are running from C3 till T5. So there are some supraclavicular nerves, some lateral cutaneous nerves, some dorsal rami nerves also. Then you do the skin incision, then you come into the superficial dissection. You are getting deltoid and the teres. There you are getting again C5-6, then deep dissection. You have the capsules, again C5-6. Then when you go to the joint axis, then you're going to C5-6, again C6, C5-6, C5-6, something. Reduction and plating, again you have C5-6, because these are the nerves that is being used. I'm not going through all these things, it will take a lot of time. My only idea is that when we see a dissection for a scapula, the amount of surface involved is huge. So you need to take a lot of area. Skin incision will take from C3 to T1 or T5 even, depending on how much it is applied. But rest of the things are only from the C5 to C6 and C7. So the skin incision is different, the rest of the dissection is different. That's what, when we saw the anatomy slide, that was how the layer by that we are seeing that. Now, this is another bigger table. So the whole point of me putting this table was not to terrorize you. The whole idea was that if you follow the Hilton law, you know that all the muscles that are attached to that or originating from that bone, that needs to be blocked when you are doing in regional anesthesia and for the complete anesthesia. So for that, forget about the nerves, just count the number of muscles. It's 5, then 9, that is 14, then 12, that is 16, that is 1. So there are 17 muscles to block. So if you want to block 17 muscles and the nerve supply to them, it is a tough task. So again, the brachial plexus and the rule comes in. So what happens is that everything is originating and going like that. So if we block somewhere around here in the root part, most of the things will be taken care of. Then we can find out, we can decide what we want to do and what we want to leave. So we can start with the blocking something of like roots. We can also try something like trunks. Other than the nerve to subclavius, rest all the nerves supply scapula. So you cannot leave anything other than the end, that like median and all those things. Most of the nerves are supplying scapula. We cannot leave these, skip these things. So how I do it? Now let me explain it. So I have got 4 options. Number 1 is that, as Dr. Divesh told, it is very important about your own capacity, which block you can do, which block you are proficient in, which block you are comfortable in, and which block you are reproducible. So what happens is that my first choice is always the interscalene block, because everybody knows that everyone is fascinated by the traffic sign thing. Everyone can see, you can put the thing, and you do just a simple erector spinal plane block. You block, deposit the local anesthetic at erector spinal plane, and then you also do an interscalene block at C567 and do an erector spinae at the T2 level. So it will take care of most of the things. Suppose you are not very proficient in either of it, or you are thinking you are better than that, then you can selectively go for a C5-6 nerve root block. So if I go back again, the most of the supply that you get from there in the first table that we saw, let me go back again. If you see this table, most of the supplies are from C5-6, 5-6, 5-6. So if you block these things, most of the things are taken care of. So now second option would be C5-6 nerve root block plus posterior cord block, which I'll be doing in infraclavicular. Reason being, again, sparing the phrenic nerve. Number 2, that option is also there. If you're good at it, you can do it. Number 3, you can do is a superior trunk block and do a normal brachial plexus block so that it takes care of the below nerves. And number 4 option is the erector spinal plane block at both cervical and thoracic level. And then you need to look into the number of the volumes that you're giving and the toxicity level. So these all 4 are, that's what I can think of. These all 4 options are available for scapular fracture. But given me a choice, I do not think most of the scapular fracture patients are always with some or other traumatic tissue, something like rib fracture, clavicle fracture, lung contusion, maybe an pneumothorax, something like that. So if in that is a condition, it's better you just put in general anesthetic, put an supraglottic airway device, let them to stay in a spontaneous respiration, give a good block, and that will be taken care. See, if the surgeon is comfortable, the surgeon is only comfortable when the patient is comfortable. And when the patient is comfortable, you are also comfortable. So my take would be, you have all the bouquet based on one's expertise. You can choose whatever you want to do. How we do it, we choose usually this C5-6 nerve root block, post posterior cord block, but always with GA. That is, I think, the safest combination trade-off between the quality of block, quality of analgesia, and the safety, both the things. Now, these are a few, this is another article that I got, and this is a very good blog. So this is a very good article, and they tell you how to do a scapular fracture surgery, and they have said something around the scapular block. So they have done a combination of things of what needs to be done. The only problem with scapula is that you need to do a number of pricks. So doing in an awake patient is slightly difficult. Then this is another thing. They have done this proximal shoulder surgery, and this is then done under erector spinal plane block. Just to give an insight, the same nerves supply the proximal shoulder are also, most of them are also supplying the scapula. So they can be done under erector spinal plane blocks, but it also needs about an expertise, where you deposit the thing, and in a trade-off between the safety and all those things. Now coming to the rib fracture, so only rib fracture are very rare. Actually, I've chosen it the last because it's the smallest thing, and it's mostly associated with other fractures. It could be single or multiple ribs, or a segments, like you can get a flail chest, and in a flail chest, the oxygenation takes a hit. So these are very difficult patients to treat. They're usually managed conservatively. If there is a single rib fracture, if there is a multiple rib fracture, there needs to be surgically operated upon. Sole RA or GA or RA can be used, and depends on the location of fractures, where the fracture is. So the location of fracture will be depending, it could be anterior, or it could be postchondral junction, or it could be more posterior. So based on the available options, one can go for an anterior fracture, that is in serratus anterior plane block, that Divesh has explained and shown very beautifully. And there is a posterior fracture. For a posterior fracture, you can go for a thoracic epidural, paravertebral, erector spinae, or even an intercostal nerve block. So even if, as most of the things have been discussed before, I will just be telling a little bit about the intercostal nerve blocks. Dr. Shiv has already explained that beautifully. So basically what we see is that we put just, I'm just showing the ultrasound imaging and same thing together. So you can just take a mark, something around 5 to 7 centimeters from the midline, feel the rib. Just remember that the rib falls down, drops down. So if you want to block this level, the block will be somewhere around here. So you need to inject, when you're injecting the needle, be sure about that. Just feel the rib. And when you put an ultrasound probe, it looks something like this. You have the serratus posterior, the rhomboid, the ribs. You need to deposit below this part, rib. So this is the caudal part. This is the cephalad part. I have a better picture of this one. So this is how the rib will be. This is the cephalad and this is the caudal. You come from below and deposit it here, and the single nerve is blocked. The one good aspect thing of this nerve is that this usually in a rib fracture patient with an hemothorax or a pneumothorax, they're usually put in with an drain, chest drain. And intercostal nerve block acts beautiful in this. And suppose there is only one rib fracture, or only there is only one there is hemothorax or pneumothorax, you just need to put an intercostal drain. ICD is 2 units with inserted. You just put an intercostal nerve block and then you are done with it. If there are multiple fractures are there, you go for an erector spinae or a multiple level thoracic paravertebral blocks or an epidural based on whatever you are comfortable with and under expertise. Thank you. So this is a quick summary of what has happened. My only suggestion is that whenever you do a block, start doing blocks, start learning, start seeing the anatomy, do the blocks. And once you feel, yes, you're comfortable with some block, try to go to a higher level in that blocks, try to understand the block, why we are doing such a block, what is necessary, and do that. It's always better to have someone who can always guide you, and the anesthetist group is fantastic in that matter. You can post the thing, post the query, post the picture, and find out whether we are doing anything wrong or it is good. Thank you.
Thank you very much, Anshuman. Thank you very much. Sorry, we have to rush through now. Finally, we'll go to the mother of all freelance anesthetists, or we're talking family here. So I think Kala Eswaran will present on analgesia and anesthesia for breast surgeries. You have seen some perspective for ultrasound guided techniques. Now she will also show some perspective of her practice in. No matter where you are, you can always achieve good analgesia for your patient. So over to you, Kala. Thank you.
I think we will skip the theoretical part of this. I think we have gone into pretty details. I think it'll be better to just go through what you do, Kala. Yeah. Your mic is off, Kala. Kala, your mic, yeah.
Can you unmute yourself, Kala? Unmute.
Fine.
Yeah.
Can you hear me? Yeah. Yeah, I'll just try to quickly go. Coming directly to the case. This was a 88-year-old female patient for left mastectomy. She had huge fungating breast mass, and the relatives came to know only because the mass started stinking at the home. No? That's why they got the patient to see what was wrong. And then she had pulmonary metastasis. The 2D echo showed a liver ejection fraction of 25%. She had dyspnea on exertion, diabetes mellitus, hypertension, and she was not on any anticoagulants. So I was asked to do under sole regional anesthesia because I am a private practitioner. I did not have an access to sonography machine. So my plan of action, sole regional anesthesia, I decided upon ipsilateral thoracic paravertebral block because we needed to block the spinal nerves from T1 to T6. So, and multi-level injections was planned because it gives the 100% action, better action than the single level. The patient and the relatives were explained the need for multiple injections, and I had done the pre-op counseling, and EMLA cream for skin prick was applied half an hour prior. All the resuscitative equipments in the personnel were ready. Now, this is the landmarks for you feel for the superior aspect of the transverse process, and exactly lateral, that is 2 to 3 centimeters, is your point of needle entry. You have to remember that the spinous process is in line with the transverse process of the vertebra 1 below. Okay? So if I have to target T1 to T6, I have to feel for the C7 spinous process and go lateral to that. Okay. So this is a video showing how I did the surface marking. I have fast forwarded the video. Once you feel for the superior aspect of the transverse process of C7, then the rest is easy. I used a 25 gauge spinal needle going perpendicular to all the tissue. See, I hit the transverse process and then walked off caudally to pierce the superior costotransverse ligament and entered the paravertebral space. At each level, I'm giving around 3 ml of LA mixture, that is ropivacaine or bupivacaine, along with adrenaline xylocaine. And this was done up to T6 or T7 level. After supine, I infiltrated along the infraclavicular region and the parasternal region to cover the branches from the superficial cervical plexus and your parasternal anterior cutaneous branch. Now the same thing, I started doing PNS guided. You can see this is the intercostal muscle contraction at the axilla. Transverse process is hit. Walked off caudally. You can see the intercostal muscle contraction. This is another case where the patient was for axillary lymph node biopsy. You can see she had huge mediastinal mass and all lymph nodes all over the neck and axilla. And the easiest for biopsy was at the axillary level. Here I had decided to give single level paravertebral block at T12 to get the intercostobrachial nerve. You can see the contractions of the shoulder and axilla very well.
Play it again, Tala.
Can you all appreciate the contractions?
Yeah, that's pretty good. I think a lot of people had this question. So you've almost answered some of the audience questions here through all these case-based scenarios. Keep going, Tala.
Yeah. Now, this is a 58-year-old female for cancer breast surgery. She was hypertensive on medications. She needed breast reconstruction She was pretty young, and there was a possibility of an LD flap for her. So what was my plan of action? I gave general anesthesia with supraglottic airway device, and relaxance was needed here. But I had to block, and I used I blocked the patient before the relaxation, kept her on spontaneous for some time, and then gave the muscle relaxants because I was using a PNS machine. Anterolateral chest wall blocks, either PECs and SAP or both. So this was a landmark for the PECs and SAP, the sternal notch, the angle of Louis, go bang lateral. This is the anterior axillary line, medial axillary line, and the posterior axillary line. At the third rib is your entry point for the pectorals, or you can attempt at fourth rib also, but the fifth I did was for the serratus anterior plane block. This is an LOR video for pecs. I go lateral at the anterior axillary line at the third rib. When bang perpendicular, you pierce the prepectoral fascia, and the second pop, you get two pops. That the first is the prepectoral fascia, and the second is the fascia in between the pectoral muscle, major and minor. And you just inject there around 15 to 20 mils. This is the PNS guided video for the same. And similarly, I felt for the sternal notch, the angle of Louis went down. You can feel a dip in between the pectoral major and the minor at the anterior axillary line. Go bang perpendicular, hit the third rib. So you can see me hitting the rib, and adjust the needle few millimeters, and you will get the contraction of the pectoral muscle, that is the lateral pectoral nerve. You can see the contraction. Slowly I reduce the current, and I get the contraction even at 0.43 milliamperes at the nerve stimulator. And here I inject around 10 to 15 ml of my LA mixture. Now coming to the serratus anterior plane block, PNS guided. The markings was done. I came to the fifth rib, again bang perpendicular. I used it, I can do it with a 5 centimeter needle, but here I had used a 10 centimeter PNS Stimuplex needle. After hitting the bone, I adjusted it few millimeters, and I can see the serratus muscle contraction. Little manipulation shows the muscle contractions very well, and around 10 ml of the LA mixture was infiltrated here, and then I checked with the USG, which I could see the spread in the superior aspect of the serratus anterior muscle. Now just trying to show the volume which which is required for each. This may be an important point. Which block will you be giving? For a paravertebral, you just need around 3 to 10 ml at the single level. If you're doing multiple injections, you go for 3 ml at each level, or if you're going single or 2 level for a breast surgeries, you can go for 10 ml. For erector spinae, you may need 20 to 30 ml of the drug for good spread into the paravertebral space and along the length of the erector spinae muscle. So you cannot, and PEX 1, you need 10 to 15, PEX 2, around 15 to 20, and a serratus anterior plain block, you will need around 10 to 15. So you have to be very careful about how much volume you're using. No? And accordingly select, because once I give one block and then it is incomplete and then go back, you will not be able to cover all the blocks. This is from my studies using 2-level paravertebral block along with a supraclavicular nerve block. I use this for ASA grade 3 and 4 patients, and you can see the comorbid conditions. Most of the patients are CABG, COPD, they have low ejection fractions and bronchiectasis and severe obesity with low ejection fractions. And all these cases I have done under sole block using 2-level PNS guided paravertebral block at T12 and T5, 6 levels, along with a brachial plexus block at the supraclavicular level, where I use just 5 to 8 ml of solutions at each level. This intraoperatively, while doing sole regional anesthesia, after giving these blocks, I needed just a few milligrams of midazolam, around 1 to 2, fentanyl if available, 50 mics, or I have used dextromid around 20 to 30 mics. Okay, paracetamol was given for all these patients. The duration of analgesia was around 36 hours or so, actually till the patient were discharged. The need for ICU was not because of the surgery or something, it was because of the comorbid conditions. As a precautionary measure, they were put in the ICU, and most of them were discharged within 2 to 3 days. Now, these are other blocks shown in the multimodal analgesia.
Hello, we can skip that
this.
part.
Yes, sir.
Yeah,
And
this is not required.
There is one article showing only pectoral nerve block. They have used for breast conservation surgery without giving any other, only and without GA also. And they have compared paravertebral blocks with alone and with the thoracic wall blocks. The thoracic wall blocks along with paravertebral gives better analgesia. And I got very few articles as sole regional anesthesia for breast surgeries. One is where they used a thoracic epidural anesthesia with intercalene block. This was a paravertebral cases which I have published. And this is one with paravertebral with interscaling and superficial cervical plexus both. Thank you, sir. I hope I try to finish faster.
Very
Really
well done.
very well done. As I said, you justified your position as mother. Thank you very much. So what we'll do is we'll quickly wrap up this session. I just want to quickly go through a summary, and I don't think so we got enough time. Maybe 2 more minutes is when we go through all these things. Basically, this couple of slides are part of what I say is what the audience questions were. You know, why have we moved from thoracic epidural? Is basically because of the existence of critical anatomical structures and the simplicity and safety of these kits. As Divesh said, you know, these blocks are simple and safe and can be performed by lesser trained people. And just be wary of when you make the choice of the block, whether you want to anesthetize the whole hemithorax or just part of the anterior hemithorax and things like that. And just be wary of wound dressings and drains and what is the patient positioning going to be, how you can efficiently manage a list. You don't have to make the patient supine, GA, turn lateral, do the block, put them back again in supine. Just eat up some time. One another summary issue is don't go looking for any loss of sensation because often these cases are pure sensory analgesia. So just analgesic benefit is the best outcome. And sometimes there could be a little bit of failures. Just remember, there could be contralateral nerve supply overflowing into your side, and some overlapping innervations. And don't forget the contributions from superficial cervical plexus and brachial plexus. And never ever forget the use of multimodal analgesia. These at best as a opioid reduction techniques, and catheters and adjuvants is another topic. We won't go through some of the surgical caveats, and there are some things that you need to be wary of when you choose a correct block. Overall, just another summary of: make sure you check the correct side block, and make sure that you choose the specific technique for that specific procedure. And we always talk about first do no harm and KISS principles. Beware of neurovascular injury, and these facial plane blocks include large volumes of local anesthetic, especially if you're doing bilateral surgery. So be wary of local anesthetic volumes. And when you go low on concentration, you may not achieve the anesthetic or desired anesthetic depth. You may get an analgesic depth, and make sure you follow patients and things like that. I'll go through one question which may interest people. There was one question is bilateral MRM if to be done under sole RA. What's the choice of technique? Can I ask Kala to answer this?
Yes, for bilateral, though the paravertebral is the mother of the block, it's the epidural finally holds better, because it's the father, as Divesh said. I mean, I will definitely go for epidural because I can do it under small doses. Paravertebral will be too much blocking bilateral, and I can combine it with either bilateral SAP or bilateral simple interscalene or supraclav block, depending upon the patient condition.
Yeah, just quickly, next question to Shiv. This is from one of the audience. Surgeon complains about PEX block regarding LA interfering with their dissection. What solution do you offer for this question?
That's actually very valid, a question, because they have seen that if you actually deposit local anesthetic in the plane where they're going to use cautery, it actually interferes with it. They require much higher current to actually dissect. And that's why they always say that please don't do blocks, PEG blocks. So the answer to that is you go for erectospine. So you go more proximal to the spine. So either go for paravertebral or for erectospinal block.
Or in order to cover the medial and lateral pectoral nerve block, so probably as Kala suggested, you combine erector spinae or a paravertebral with supraclavicular brachial plexus block with a low volume.
You can do that, and to be frank, I mean, when you're looking at when they're going to dissect the muscles, that's only going to be something like radical mastectomy.
Yes, that is for MRMs, which is actually quite rare nowadays.
Yes.
It's most often simple mastectomy with reconstruction, but a lot of patients in subcontinent undergo modified radical mastectomy, and I think the solution there is to stay away from the PEX area and block those nerves at their origin.
Yeah, I mean, these nerves are actually coming, like I showed in my diagram, they're coming from medial and lateral cord. So even if you deposit local anesthetic around medial and lateral cord, you're going to block both of them.
Yeah. So that's probably an infraclavicular brachial plexus or a supraclavicular brachial plexus.
Yeah. The patient is not going to use their arm after the surgery. So it's, I think, ridiculous to actually say that you can't be doing that because the arm will be blocked. I think Divesh wanted to actually say something.
So we can go one plane deeper to this. For example, in serratus inferior, we can do a deep serratus inferior.
Yeah.
They will not be able to visualize the local anesthetic injected deep to serratus inferior muscle. And for PEX 2, one can inject below the serratus inferior at the third rib.
You don't get
but you won't be able to cover the medial pectoral and lateral pectoral.
Yeah, we do not get that. But for PEX 1, we have to give between PEX major and minor. We can go more closer to the midline for that because their dissection will not come down. this place. We
No,
can
my
inject anywhere from this place to this
No.
place for pec 1. Anywhere between pec major and minor, anywhere from this place to this place, you can inject 10 ml will diffuse.
No.
No,
If
no,
not,
but
we need to catch the nerves. You need to actually catch the nerves in the pack blocks. Right. That's the only way to actually reduce the volume and not actually cause, because that's why the difference between the interfacial plane block. So the whole idea is that there is local anesthetic in that plane, and when surgeon actually is trying to use a cautery, they're not able to use it. They require much higher current, and they get a little bit perturbed by that because they're requiring, you say, it's not working as well. The cautery is not working as well, and that's the problem. So it's not about where you're going to deposit, medial or lateral or there. It's the presence of the local anesthetic in that plane. And the only way to reduce that is by actually going and blocking the individual nerves, which are coming from the medial and lateral cords.
okay.
You don't even have to go supraclavicular. You can just go infraclavicular, deposit local anesthetic around the cords.
Yeah, just one more question. Surgeons complain about spread of malignancy because of PECs and SAB blocks. Myth or fact? Kala?
Problem. Who's answering that? Sorry.
no.
Kala.
Sir, my surgeons do not allow to go anywhere near the breast because they say ki I can smell the LA. So even if I try to give it before they come in. So
We don't have perfumed one, huh? Yeah, we're not getting perfumed LA, are we?
yeah, they know when I'm there, I'll try to needle something. So I have to be very careful. Either that's why I always go for any incomplete
More
surgery. If the
posterior
patient,
block.
more posterior, or I go for a supraclav or an interscalene. And I have finished almost more than 200 cases doing giving supraclav for it's fabulous, sir. And I'm not needing somehow the patients the branches from the superficial cervical. I do not need to block them. Somehow the paravertebral covers that also. But if a paravertebral and a supraclav, the combination is very good.
The incision Kala is not in the supraclavicular area nerves in most of the surgeries. If you look at it, it doesn't actually get to that.
Yeah.
It needs to be in the very radical surgeries where you might need to block the supraclavicular nerves. Otherwise, in most of them, modified dissections actually does not cover that area, I think.
There is a lot of skin sparing and tissue nipple sparing surgeries nowadays. So they are getting less and less invasive. I think we've almost run out of time. I think in summary for breast surgery, finishing off what Kala said was, if you want to stay away from the PEX plane or the SAP plane, go more posterior, ESP or TPBB, and combine with the supraclavicular or infraclavicular brachial plexus with a small volume local anesthetic. I think patients should not be denied of beautiful analgesia that you can provide just because of the surgeon's possibly myth, or maybe it is true, maybe whatever, we need to work around them and with them. So have other alternatives. And thank you very much for everyone. Thank you for listening to Shiv, Divesh, and Kala and Anshuman. Thank you very much. Okay, have a nice time. I hope you all enjoy the rest of the conference.
Thank you, Dr. Guru. Actually, we have already overshot by time, but we'd like to cover up for the rest of the sessions. Our next session is on abdominal surgeries, and this will be moderated by Dr. Pallavi. She's a specialty doctor at Essex and editor-in-chief of Journal of Anesthesia and Critical Care, as well as founder-director of Anesthesia TV. And she has got special interest in obstetrics, regional anesthesia, and quality and safety. So over to you, Dr. Pallavi, for the session on which block for abdominal surgery.
Thank you, Dr. Divesh. Thank you for the introduction, Dr. Divesh. And let me kickstart this session for Prospera for abdominal surgeries with the introduction of my stellar faculty members. We have Sunil, Jennyl, Shiv sir, and Soma with us. So Jennyl has been probably my latest discovery as an anatomist and a dissectionist. He works as a consultant anesthetist in the government hospital in Kanyakumari district. And I have learned a lot from his videos as well. Moving on to Soma. Soma is an associate professor at Sri Ramchandra Medical College. He is a regular contributor on the group, and his area of interest are pain, airway, obstetric anesthesia, and simulation. I've done a simulation session with him as a faculty, and he was excellent. Sunil works as a consultant anesthetist, and he's the head of the urology and transplant section. He's done part of his training in the Republic of Ireland, and he's probably the best person to speak on the renal transplant and robotics. Shiv sir, as usual, needs no introduction. All of us know him too well, so I would not belittle by talking about him, and that's myself. So that's the the outline of our program today. We're going to talk about the overview of the abdominal wall anatomy and innervation, because you cannot perform any blocks without knowing the anatomy. Then we will be having short video demonstrations by each of them, followed by the panel discussion. And if time permits, we will take the questions from the audience. So Jennyl, over to you. I will stop sharing my screen. Jennyl is going to talk about the anatomy of abdominal wall and its innervation.
Thanks, ma'am. Abdominal wall, anatomy, I'll be very crisp. As we all know, we have the four muscles in the anterior abdominal wall. We have your external oblique, the internal oblique, and the external oblique, the internal oblique, and the transverse abdominis. And anterior side, you have the rectus muscle. Posterior side, you have your psoas muscle and the quadratus lumborum and the erector spine at the back. What we need to know is you have your spinal nerves, which arises spinal nerves which supply the anterior abdominal wall from T6 to L1, and you have your nerves arising from it, and it runs a short distance on the quadratus lumborum, and sometimes it divides at this plane, giving off the lateral cutaneous nerve and the anterior cutaneous nerve. Anterior cutaneous nerve runs along the neurovascular plane, that's a tap plane, and it pierces the rectus muscle and divides into anterior cutaneous branches to supply the anterior abdominal wall. Whereas the lateral cutaneous branches, it also divides, and sometimes it divides a bit lateral in the mid-axillary line, where it supplies a lateral abdominal wall. As you see here, you can see the lateral cutaneous nerves, which supplies the lateral abdominal wall. You can see the anterior cutaneous branches, which supplies the anterior abdominal wall, facing the rectus muscle. And the L1 nerve supplies just below the umbilicus, which is divides into two, which is the iliohypogastric and the iliointernal nerve. The vascular relations you need to know, because you have when you place your probe, there's a spino-umbilical line while performing a iliointernal nerve and iliohypogastric nerve. You have your deep circumflex iliac artery over there. And when you perform the subcostal tap block, you have the superior epigastric artery coming over there, and you have your when you perform the rectus block, you have your inferior epigastric arteries coming over there. So a bit of quadratus lumborum muscle, you can see here, that is a psoas muscle and the iliacus muscle. When you remove this, you will see the quadratus lumborum. And the quadratus lumborum muscle, which originates from the 12th rib, and also take twigs from the transverse process of L1, L2, L3, L4, and L5, and gets inserted into the posterior border of the iliac crest. You have a bit of thoracolumbar fascia. You have the anterior layer, middle layer, and the posterior layer. The thoracolumbar fascia is formed from the aponeurotic fibers of the transverse abdominis and internal oblique, and it divides into anterior, middle, and posterior. The anterior and middle are inserted into the transverse process of the lumbar vertebra, whereas the posterior layer is inserted into the spinous process of lumbar vertebra. The blocks that quadratus lumborum block, you have your quadratus lumborum 1, which you deposit the dirt at the cornu of the transverse abdominis and the quadratus lumborum. The QL2 is performed posterior to the quadratus lumborum muscle. What favors of all the three blocks is the transmuscular quadratus lumborum, that is a QL3, which is the drug is deposited by piercing the erector spinae, the quadratus lumborum anterior to the quadratus lumborum muscle. So you have a good spread into the paravertebral space. So the zona anatomy that you need to know is, when you keep your probe in the just below the Shetty sternum, you will see the linea alba and both the rectus muscle. As you move slowly laterally, you will see the rectus muscle in the between the tram lines. You have your anterior rectus sheath and the posterior rectus sheath. As you move further laterally, you will see the tapering end of the rectus muscle. That's the tapering end of the rectus muscle. And as you further move laterally, where you will see the Spigerian line, which is not that, which is the Spigerian line, or the linea semilunaris. You have your external oblique and their internal oblique and a transverse abdominis. Of the three muscles, which is the bulky muscles, the internal oblique. Of the three, the internal oblique appears a bit hypoechoic. And if you further move laterally, that is the lateral tap. Further you move laterally, I'm moving the probe laterally, you can see the three muscles again. And you can see here the tapering end of the transverse abdominis, and you will see the neurovascular bundle over here. That's the neurovascular bundle. So let's see a short video of about the anterior wrap, which is nothing but the ilioinguinal and iliohypogastric nerve block. So the probe is placed in the spino-umbilical line just above the ASIS. You will see the anterior superior iliac spine. You will see the external oblique, internal oblique, the transverse abdominis, and the tap plane, where you will see the neurovascular structures. And the needle will come from medial to lateral. You can see here the ilioinguinal and the iliohypogastric nerve with the deep circumflex iliac artery. You have to deposit the drug in this plane. These are facial planes. Facial plane nerve blocks. You have a pop there. Sometimes you go into the transverse abdominis. If you get just a linear spread like that, that is a good block on top of the transverse abdominis muscle. So you deposited around 20 ml of 0.25% bupivacaine or 0.2% ropivacaine. Along with this, if you want to do an inguinal hernia, you can supplement the spermatic cord block. That will suffice the for the anesthetic purpose. For about lateral tap block, the probe is placed in. This is the costal margin. You have your iliac crest. The probe is placed in the mid-axillary line. The needle will enter from anterior to posterior, where you will see these again the three structures. You can see here the probe is placed lateral. Let's see a short video of that. You can see the external oblique, the bulky muscle, internal oblique, and the transverse abdominis. And the needle comes from here, and you will deposit the drug here. Again, you should see a linear spread. So the needle comes into the plane, slowly hydrodissect with 0.5 ml, even though if you don't see the needle, so you will get a linear spread. Then you then you give the rest of the drug. Don't keep on injecting. Just give 0.5 mils to see whether you are in the plane. See, now I am in the right. You are getting a plane there. So you put your needle there and then you inject 20 ml of 0.2% ropivacaine. You can add adjuvant, either dexamethasone. I prefer the dexamethasone. Let's see about posterior tap. So posterior tap, most of the LSES patients are obese. Either you can't shift them. You have a long list, so you can't shift them each and every time. You can't shift them in a lateral position. For that thing, you can keep a sandbag on the buttock, and then you place the probe bit laterally. You will see the tapering end of the transverse abdominis muscle. So the needle should come in this point to deposit the drug. Let's see a short video of that. You can see the external oblique there, internal oblique there, and the transverse abdominis there. The needle should come there, but I have not reached that exact point. But the right place to give this the drug is in this point. Never do this. So see the drug, this always happens. The drug goes into the internal oblique. So 0.5 ml of drug is there. Still you're not getting the correct plane. Just pull out the needle, get into this plane. When you get a linear spread there, you're not seeing the needle as the patient breathes. The transverse abdominis moves left and right. So you can see a good spreads there on top of the transverse abdominis. So then you push your needle further and you can give the rest of the drug. Just about the subcostal tap, you can see obese patients, you will see a subcutaneous tissue there. This is the rectus muscle and this is a tapering end of the transverse abdominis muscle. So the drug should come here. So the probe is held, you can see here, the needle is coming from medial to lateral. So you give 0.5 ml, the drug is bulking into the muscle. You pierce the posterior rectus sheath and then you pierce wait for it, and then you pierce the posterior rectus sheath and give the drug slowly. And you see the wait and see for the rise of the rectus muscle and the linear spread of the drug. That confirms the correct plane. Rather than getting into the muscle or getting under the rectus muscle is not the right plane. Now you will see, now again, now scout scan, you can see the transverse abdominis, you can see the spread of the drug there in a linear manner. So the tips and tricks, as I told you, placing a sandbag under the buttock is one thing. When you have obese patients, you always need an assistant. You can, my left hand is holding the probe, my right hand is holding the needle, and an assistant is stretching the skin, so that stretching the abdominal wall, so that the needle goes from anterior to posterior. Thank you.
Jennyl, can you please stop sharing the screen?
Yeah. Stop it now.
Yeah. So Jennyl has covered the anatomy of abdominal wall and its innervation along with the video demonstration of the different tap plane block approaches. Another tip I would like to add, apart from placing the sandbag, is what we used to do is the patient is usually strapped to the bed, so you can just tilt the bed away from the performer. So even that also helps. Moving on to the demonstration of QL blocks by Sunil.
Yeah, Dr. Pallavi. So I'll share my screen.
Yeah.
So I won't be covering a much of an anatomy detail as it is already covered by Jennyl. So this is how the patient is placed for a quadratus lumborum block. So the most common type of quadratus lumborum we do is quadratus lumborum 3. And in most of the renal nephrectomy, donor patients and renal surgery patients, this is the position which is already done when the surgeon finishes the job. So it is very convenient to do this block in most of the renal surgeries. So the needle is inserted posterior to anterior, and this is how it goes. So this is a typical shamrock sign. You can see a quadratus lumborum muscle, and anterior to it is a psoas muscle, and then posterior medially is the erector spinae muscle. So this is a typical sign what we look for to start the quadratus lumborum block. And this is another landmark. This is a thumbs up sign. The thumb denotes the transverse process, and the lower part is the vertebral body. And the top of the thumb, there is a quadratus lumborum muscle. So needle is coming from posterior to anterior. That's a quadratus lumborum muscle. And this is also known as the transmuscular block. So now we are just anterior to the quadratus lumborum. So this is also known as the anterior quadratus lumborum block. So the drug is getting infiltrated anterior to the quadratus lumborum. So as Jennyl mentioned, there is a QL1, QL2, and QL3. But recently, what I am aware of is like American Society and European. Both have a consensus, and they agreed on the part that 1, 2, 3 is not a good idea to name it. So they are calling better it as a anterior, posterior, and the lateral block. So this is an anterior QL block, and the lateral is a QL1, which is more or less similar to a posterior tab block. So there is not much of an advantage of doing a QL1 if you know very well about the posterior tab block. So this is how now the drug will be infiltrated, the local anesthetic will be infiltrated. And we can see that the psoas is getting pressed down, and there is a space created due to the local anesthetic infiltration between the QL and psoas. So in this block, roughly a 20 ml of local anesthetic is injected, or you can take it as 0.25 to 0.3 ml per kg. So the drug, you can even see that the drug is going to the lateral part of the QL. So it is not just limited to the anterior part. If you are giving an adequate volume, it is going to the lateral part as well. And you always try to keep a kidney in focus while doing this block. That is always a safer thing. And especially on the right side, it is very easy to see a kidney while doing a QL3 block. So this is the area where the local anesthetic is infiltrated. And there is just a white nerve-like structure near the needle. In this case, it was noted earlier. We thought like this is just a air was pushed, so that was white, but it is staying. So some white structure was there. So probably it was a component of a L1 nerve. Yeah, that white structure still there. So we did a Doppler also in this one. So there is a lumbar artery over the vertebral body was seen. So that was a QL3 block, which is most commonly done. And QL2, that is a posterior QL block, is not done in most of the countries, but still very few people are doing that, and they are using it for a cesarean section. But practically, I found that there is not much of advantage of doing a QL2 block. But with QL3, we need to keep in mind that if we go much deeper into a psoas muscle, there may be a infiltration into a lumbar plexus, which may cause a lower limb weakness. So that is all from my side. Just a picture credit to Nisora. Video was all mine. Just a picture from the Nisora. Thanks. This is all done. And I'll stop my screen.
Thank you so much, Sunil, for the beautiful demonstration and clearing the jargon and the confusion over the various kinds of QL approaches, because that is very essential. I think new blocks do keep coming, but the essence has been explained very well by you. Next, we have Soma, who will be demonstrating a easy-looking difficult block. That's what I call, because rectus sheath is an easy-looking difficult block. So over to you, Soma, for a demonstration of this block. I will stop sharing.
Rectus sheath block is it's a very easy looking difficult, as Pallavi rightly told. It has got minimal side effects with relatively very few contraindications to per se. But again, it has got low failure rates also. So I think the anatomy part has been taken care by Jennyl. I'll go how to do a rectus sheath block. So classically, we keep the transducer at the linea semilunaris, at the lateral margin of the rectus abdominis, at the level of umbilicus, and we can either use an transverse.
Some of your slides, yes. Soma, we can't see your slide. You're not gone into the slideshow.
1 second, sir. I'll just stop it and then reshare it again.
Yeah.
Is it visible, sir, now?
Yeah, that's it. Yeah.
So this is the transducer position for the rectus sheath block at the level of umbilicus. We keep the transducer in a transverse plane at the level of linea semilunaris. That's the lateral border of the rectus abdominis. And once we can either do this in a transverse plane or in a longitudinal plane. Especially if we place in a catheter, we can use the longitudinal plane to administer this block. So as we scan at that level, we can see that there's an anterior rectus sheath, below which is going to be the rectus abdominis muscle, and below the rectus abdominis muscle is going to be the posterior rectus sheath. We have the classical, the tram-like appearance. Below the posterior rectus sheath is the peritoneum, the fascia transversalis, followed by the peritoneum. We can see in a live scan the peritoneal contents. It's bowel. The bowel movements can be appreciated very clearly. So if we go above as a subcostal tap, we can see the transversus abdominis muscle below the rectus muscle. So this I'll touch upon in a while. It's a small video. Yeah, so this is the subcutaneous fat. This is the anterior rectus sheath. This is the rectus muscle. We can see the needle coming from lateral to medial. As we puncture as we go through the rectus abdominis muscle, then here I'm injecting a few mLs of saline for hydrodissection so that I can separate the muscle. And once I'm sure that I have passed beyond the muscle and above the posterior rectus sheath, I'm injecting in volume 20 ml of around 0.25% bupivacaine. So we can very clearly appreciate that the rectus abdominal muscle is lifted above completely from the posterior rectus sheath, so that the plane is filled with local anesthetic solution. One trick I use is to rotate after injecting the drug, I'll rotate the probe in the longitudinal plane and see the spread of the local anesthetic across the above the posterior rectus sheath below the rectus abdominis muscle. For an extensive laparotomy, then I would like to place a 4-point injection of rectus block at just immediately below the umbilical level, and one at the midway or upper 1/3 area between this xiphoid and umbilicus, so that we can get a complete analgesia for an anterior abdominal wall at the surgical insertion site on bilaterally. But if it's going to be in surgical surgeries in and around the umbilicus, like umbilical hernia repair or a single incision laparoscopic surgery where only there's going to be an umbilical port, then bilateral rectus sheath block at the level of umbilicus is going to be very easy. Intraoperatively, we can place the rectus sheath block catheter. We can ask the surgeon to put in a 2E needle, and we can palpate the needle through into the abdomen, and then we can ask the surgeon to place the catheter above the rectus sheath. The surgeons I work with, they don't even allow us to keep the catheters ultrasound guided. Forget about intraoperative rectus sheath block catheters placed by them. The couple of tips that I would like to say is obviously for a good analgesia, it has to be given bilaterally, and we need to rotate the probe to 90 degrees and see the longitudinally and see the spread of the local anesthetic above the rectus sheath. And we need to be mindful of the vessels, that the epigastric vessels, superior and inferior epigastric vessels, if we are giving blocks in the upper third or in the lower third above the arcuate ligament. So we can put in a Doppler, and we can make sure that the vessels are not injured. Otherwise, we can land up in rectus sheath hematoma and an exploration later on. There are tendinous intersections that the sixth pack that we see externally. It's not present posteriorly in the rectus abdominis muscle. So there will be a smooth distribution of the local anesthetic solutions that we can appreciate when we keep the probe in the longitudinal plane after injecting the drug. And we can keep the catheters in the lower midline for and lower abdominal incisions and the midline vertical laparotomies. And especially in the paramedian, if the surgery is going to be in the midline vertical incision, then we can give a preoperative rectus sheath block. But if the surgery is going to be a paramedian incision, then we can give the block post-operatively so that the analgesia works better. The local anesthetic I usually use is around 0.25% bupivacaine. Somewhere around between 0.3 to 0.6 ml per kg body weight on either side, depending upon the weight of the patient, build, and other parameters that we take into consideration. I have given rectus sheath blocks in children for umbilical hernia repair. So there I have used around 0.1 ml per kg per side of 0.25% bupivacaine. In neonates and children, it's a very effective block. The postoperative pain relief is quite good. And if the incision is going to be very large, then we can increase the volume even up to 0.8 ml per kg body weight. And it has got a very good opioid sparing effect. And many times we may not need to administer supplemental or rescue analgesics for this rectus sheath block. Thank you. Over to you, Pallavi.
Yeah. Thank you, Soma, for this wonderful tips and tricks you have given. What is your point of insertion for the needle? Do you go as far as where the transversus starts arising?
If I give at the level of umbilicus, it's the classical rectus sheath block at the linea semilunaris level. But if the incision is going to be a very huge one, I would prefer more of a subcostal tap sort of in the upper third of between the xiphoid and the umbilicus. So at that level, I would like to give the block. That it gives a better margin of safety because you have a transverse abdominis muscle below the rectus sheath.
Yeah,
so,
exactly. Yeah.
So we will not be puncturing the viscera and the deeper structures. So
exactly.
That's one advantage of.
Yeah, and also the lateral nerves. That's the point of the piercing and coming up.
Yes.
Yeah. Okay.
Can I just ask once again?
Sorry?
Soma, you actually are putting the probe transversely and then looking putting it parasagittally and looking for a spread. So why are you not doing it, just doing parasagittally? Put the probe parasagittally and go inject local anesthetic.
Yes, we can do that. Yes, we can do that. Yes, sir.
No, so why this different way of doing? You're just moving a probe. Just keep it in parasagittally and give wherever you want to actually give, because that's what I would do if I were doing. But that's what I do it, especially if I have to actually do for a kind of a midline incision. But if I'm going to do it for a paraumbilical area, just like for example for a port for lap chole, then I would do it the way you're saying it. I don't need to see the spread up and down. I'm looking on the local spread.
Okay, okay.
I think it's just a matter of practice that we started doing rectus sheath blocks in the manner which he described, and then for a midline longitudinal one incision, you will have to rotate the probe. So I think it's just probably a learning curve. Yeah. Shiv sir, we have had an lengthy discussion about ESB and PVB, but we will talk about its extension and its application for abdominal surgeries. So you'll be probably taking us through that.
Yeah. Okay.
Stop sharing my
We
screen.
can. Yeah. So, I mean, I have already discussed about the anatomy of the paravertebral and the rectus spinae area. So, what differentiates between the rectus spinae and the paravertebral is that whether you pierce the costotransverse ligament and deposit local anesthetic, below it or above it. Okay. And this image, again, same thing, showing where you go for paravertebral blocks and how it is done. I think that's been very nicely covered in the previous sections. And this is the images you would actually see. So if you actually, I'm just going to put my pointer in there. So if you look at it, so you got the transverse process. Okay, that's your the epimysium of the rectus spinae. You got the costotransverse ligament, and then you got the pleura. Okay, so if you actually go, that's, I mean, it was discussed by Divesh, or where do you hit it? Do you on the top, you on the side? What I have actually seen and I was been actually teaching is that you need to actually go at 11 o'clock position to the transverse process, and you will actually see a better spread of the local anesthetic. And if you then, this is if you pierce the costotransverse ligament and you actually go into it and deposit local anesthetic, that's your paravertebral block. Okay. So this is how actually is done. This is actually old videos from 2013. So you put it in the midline longitudinally, and you can actually then see the spinous process and move it laterally. Till you actually see the your transverse processes. You can actually see on the thing, it's a 2013 video, long before a lot of things were published. And then you actually turn it obliquely. Okay, so this is not a parasagittal, but it's a oblique parasagittal approach that I've been teaching. And you will actually see that the costotransverse ligament is actually well visualized if you actually use this position. Okay. I will actually show you again in the video. You can actually see even here, see it here, that that's a costotransverse ligament. You can see the pleura. All you need to do is actually then pierce the costotransverse ligament. Okay. So that's the video. This is actually, I have zoomed it a bit, and you can see the needle coming in. That is your transverse process. That's the costotransverse ligament here. And I will actually show you a recent one as well. This is the one from 2013, which was linked to the video I've actually shown. So if you don't pierce the costotransverse ligament, the local anesthetic will actually spread outside it. That's it, it's outside. Okay, so you actually have done a erectus spinae block here, isn't it? That's the erectus spinae block been done. Okay, you need to actually pierce the costotransverse ligament to actually get the actual thing. Okay, so there, okay, you go in and you need to see the pushing down of the thing. Okay, it's not happening that well in this video. Okay, so we'll actually go into this, yeah. So here what we're doing is actually trying to actually show the anatomy. So you actually come from laterally. So you see the ribs, you see the pleura. Okay, ribs look very rounded. So the ribs are very rounded. You need to move laterally, so go medially till you're able to see the transverse process and a costotransverse ligament. So you can actually see the costotransverse ligament in here in a minute. Okay. You can see the needle coming in, and in this case, you're actually going to see the pushing down of the pleura. Okay, as you inject, if you have pierced the costotransverse ligament, you will actually see. You can see the thing. You will actually see it better in a minute. Okay, you can actually see some amount of local actually seeping out here. Okay, so part of the hub, probably the bevel is not properly in. What's happened here? Yeah. So this is actually erector spinal block here again. So hit the transverse process at around 11 o'clock position, and you actually will likely see a better deposition or a spread of the local anesthetic under the erector spinae muscle. You can actually see that just with 20 mL, it does spread to almost 2 to 3 segments above and below the below the erector spinae. So you actually get that. I think this is just another. I will leave that one. Okay, now this is. I'll stop sharing a minute. I have actually posted a video of how to do the erector spinae block. Now this is very important. It's what position do you actually have the patient in for erector spinae block? So if you have awake patient, obviously you can have them sitting up. But if the patient is anesthetized, you actually have the patient actually, if you're right-handed. So if you're right-handed, you have the patient who is actually lying facing the right side. So it is your right lateral patient. Right. The reason being that it doesn't matter whether you're doing a right-sided block or a left-sided block, right? You are actually going to come from the top. I actually do have a video of that. Might actually share it in a minute. This is going back to that. I think I'll just talk through it. I think you will understand what actually I mean though. So if you're actually having a patient, lying on the right side and you're right-handed, you actually hold the probe and you're coming from the top. So you're coming from the cranial end and you're going downwards, right? So all you will need to do if you're doing the left side, you're on the top. So left side is up, you're coming in there. Okay. If you want to do the right side, you just need to move below and you can actually do it from below. So you will actually get the absolutely beautiful images. But imagine doing the other way around. So it doesn't matter if you're right-handed, then you put the patient in the right lateral. Easy to remember, right-handed, right, put it right, be at the back of the patient, and you can do all you need to be sure of that you're doing the right side block. Okay. So if you have the patient in that way and you are actually going to do a right-sided block, you need to go below the spine to actually do it. So actually mark it down. You don't want to be doing a wrong-sided block in that. Okay. Okay, I think that's it about that. And the reason, okay, now coming to, can these blocks be done for abdominal surgeries? Yes, it can be. You look at the the landmarks. Now your Ziffy is around T6 level. I'm like it's T10. Your inguinal ligament L1, right? And you're doing a thoracic level, isn't it? So if you do a erector spinae block at T10, T9, T10, it is going to spread up to almost T6, T7, and down to almost T12, L1. So if you inject 20 mLs of the local anesthetic at that level, you will actually get a good block. But saying that, I would actually suggest to actually do at 2 levels, because even though we see that the spread is good with going up and down, it's better to always do 2 levels. So just select your position. So say you are going to do you want to cover T6 to L1. In that case, I would probably go around T8 and then go around probably T12. Okay, do 2 levels and you will actually see a good spread. You have to do obviously bilateral blocks because you're doing a midline incision. So what is the advantage of doing erector spinae block over the say abdominal blocks? Abdomen, always. Abdominal thoracic area, you need both somatic as well as visceral pain relief. And that's what the paravertebral blocks do, and that's what erector spinae block do. You also will cover the visceral pain. You're going to cover both the somatic as well as visceral pain. And that's why it's better than actually just putting rectus sheath catheters, whether the surgeons want to do or not. I mean, there is a craze about putting rectus sheath catheters in UK at the moment. It's only thing they're realizing the complication. We've had patients who needed to come back to theater because they tied off the rectus sheath catheter. Okay, so patient journey is increased, complication increase, anesthesia again. We've had patients who have actually had snipped catheters when they're trying to remove it, and the patient has to come back to theaters. Okay, so these are not been reported yet, but this is what are going to happen with that. But again, it can provide. It does actually have seen that it can provide decent analgesia, but not visceral pain relief. You will still, so patient go on catheters. So they have two pumps, one for the rectus sheath catheter and one for PCA. So what's the point? Okay, you're still using morphine. So the complications are not reduced. So I think it's just that putting erector spinae catheters requires skills. Okay, requires time, require that surgeons are going to do. So if you're lazy, you're not going to actually put the erector spinae catheters. Okay, I think I've covered that.
Okay, thank you, Shiv sir, for this excellent, creating a beautiful mental picture of doing a bilateral two-level block and covering the incision site. Next, we will talk about procedure-specific regional anesthesia. That is what all we are here for. So Jennyl is going to talk us through the analgesia for the bread and butter surgery, the LSCS, with the typical fan and steel incision. So Jennyl.
Yeah.
Yeah, Jennyl, so which blocks do you prefer to perform for the post-op analgesia for the LSCS patients?
LSCS patients, what preferred best and the EC block when you have a long list is posterior tap. I would like to prefer with multimodal analgesia. Patients are comfortable for more than 36 to 48 hours. I give 0.2 percentage, 25% bupropion, 20 ml on both sides with dexamethasone.
So you say you add dexamethasone to your LA mixture?
Yeah. Okay. But either give IV or mixture, both results are the same. That's what the evidence.
Have you compared both in your own practice?
No, madam. I just mix it and give it.
All right. Right. So why do you prefer this particular block? Why not a classical tap?
Yeah. Can you just?
I will stop sharing. Yes.
This is the point here. Like sometimes you have your nerves arising from the spinal nerves, ventral rami arises here, and sometimes it divides in the lateral border and gives rise to the lateral cutaneous nerves, where you perform the classical tap here. When the nerves arises and divides at this point where there's a posterior tap is being performed, where you will cover the lateral cutaneous and the anterior cutaneous branches. So that's why the posterior tap is being preferred over classical tap. And moreover, when you give 20 ml of local anesthetic, the posterior tap acts like a QL1. And there have been studies, cadaveric studies, they say the drug spreads into the paravertebral space also. So you have chances of covering the somatic and the visceral pain. Most of the patients are comfortable with the somatic pain, and the patient will say, I'm having a numb from the T10 to L1 level. But patients will say, yes, still I have pain. That is nothing but the visceral pain. That's why this is the tap. and this is a quadratus lumborum drug spread. That is why they prefer the transmuscular quadratus lumborum block, where you have your anterior spread and the drug spreads into the paravertebral space, which with 20 ml of local anesthetic, 0.2% ropivacaine or 0.25% bupivacaine, you cover both of the somatic and the visceral pain, which gives you more advantage.
Thank you, Jennyl. Also, time and again, we have discussed on the group that why a classical tap, how it will lead to sparing of your L1, and how it is, Shiv sir has always described giving a tap which catches the ilioinguinal and iliohypogastric nerve, the L1 branches. What's your experience with QL blocks, Jennyl, for cesarean sections? You're muted. Jennyl, you're muted.
Yeah, better patients with QL 3 blocks when performed in cesarean sessions with the fan steel or subumbilical incisions, the QL block works very well. The QL 3 works very well. I have some experience. So I think Sunil sir can suffice his experience too.
Yeah, but do you not need to turn the patient on? If you're doing the quadratus lumborum, like for example, for kidney, I can understand patient is already on lateral position.
Yeah.
But you can't give quadratus lumborum 3 without actually having to turn the patient,
Yes,
and you'll
sir.
have to turn either side.
Yes, sir.
Yes. Isn't
So
it?
you'll be essentially doing a QL1 or a 2 if you don't turn the patient lateral, because you obviously the ergonomics is not going to help you.
Yeah,
So,
there's no actually advantage if you look at the amount of opioid consumption, even
Yeah.
without blocks in patients with cesarean section, it's actually minuscule.
So
The
it-
studies done from the women's hospital here, they used to give that, and they found that there was no point in actually giving them PCAs. It is not as painful as this lower abdominal incision,
so
and even infiltration. Yeah.
Uh,
at our center also, so we did a study. DNB thesis was there around 4 years back.
Yeah.
And that was like we started with a QL3 and a tab block. So that was done in the literature as well. We found like QL3 is better. So people were turning lateral and the QL3 was found better. But my question to them was like either like whether they are doing a posterior tap or a lateral tap. So I found they were doing initially a lateral tap.
Yeah.
So I was included in a study and I found like my posterior tap were like totally comparable with the QL3. There was no advantage of QL3 in those patients. Like in spite of a discomfort, making a lateral and more time consuming. So posterior tap was equally good with no disadvantages.
Absolutely. I think you also have to understand that in theaters, every minute actually is around 15 pounds worth of time, and you're going to turn left, right, here, there, and if the analgesia is not actually as good, as far as I remember, the QL2 was useless for these blocks. It was failing to actually provide much of analgesia. And the lateral tap or the posterior tap, okay, there is actually a controversy, or rather there's always a fight between Rafa Blanco and Peter Hubbard, because Peter Hubbard actually described it as transversalis fascia block. Okay, the QL1 is nothing but transversalis fascia block, wherein you are actually going to pierce this transversalis fascia and deposit local anesthetic. Very long ago, there is a video on which I have seen. It's a ultrasound block, but I have attached a needle, and I have shown that you can actually stimulate the nerves. You can actually look at the nerves being stimulated at that point. Okay. And their spread is actually equally good. So, and again, you don't require more than the L1, T12 L1 for the incision. So ilioinguinal, iliohypogastric nerve blocks work equally well.
Yeah, I think, Shiv sir, I think the difference between the opioid consumption in UK and probably elsewhere is probably because here we add spinal diamorphine, the preservative spinal diamorphine. That's a
You don't
standard
need
practice.
then there's no point. If you're actually already doing the spinal diamorphine, then I would say there's no point in actually
No
giving
point.
any block at all.
Yeah.
It is only
Yeah.
for patients who are actually having GA, in which blocks would actually help in reducing the amount of opioid requirement. But if you're already adding diamorphine, then it's a waste of time to actually be giving blocks to these patients. You just need a simple analgesia to maintain, throughout. Their requirement is actually not.
Yeah. So in summary, I think ilioinguinal, iliohypogastric block and the tap plane in that will work wonders, do the job. Okay. So Soma, the next question is for you. So we're talking about laparotomy with a midline and a paramedian incision. Can you please enumerate what is your preferred modality for post-op analgesia for these patients?
Yeah. It depends upon how is the incision going to be, like an extensive laparotomy or a lower midline incision, or an incision from the xiphisternum to the pubic symphysis, and the associated, whether the patient is, if I take a patient for an emergency laparotomy with coagulopathy or sick laparotomy, something like that. So depending upon the patient situation, the surgical factors, I'll take into consideration. So if it's going to be an elective laparotomy with a midline incision, probably my first modality for post-op analgesia would be an intrathecal morphine. That's what we have in India. And or an epidural analgesia for post-operative pain relief. We have very good experience with that. And then whatever be the number of blocks we add, the visceral component of pain is going to be extensive. We do a lot of surgical oncology cases for laparotomies. So the visceral component of pain is going to be much higher. So if feasible, that will be my first line of modality for post-op analgesia. If I'm not able to put an intrathecal morphine or an epidural, then the posterior tap, along with, if it's going to be in lower midline incision, a posterior tap bilaterally will be a better choice. If the incision is going to be extending till the xiphisternum, then it will be combining with an subcostal tap or an rectus sheath, bilateral rectus sheath block at the upper third quadrant in the upper, above the umbilicus. That will be an excellent choice of analgesia. I would like to recollect a patient where we had a laparotomy. We couldn't cite an epidural or give an intrathecal morphine, and sent the patient for elective ventilation. The patient could not be weaned off ventilator, and then in the ICU we gave an bilateral rectus sheath blocks. Actually, we placed in a catheter, and then we could, after an infusion has been started, 6 hours later, we could beautifully wean the patient and extubate the patient off ventilator. So that's also a fantastic modality. If the one good thing about this midline incision laparotomy is, if the patient is going to have, if the patient is extubated and in the PACU, if the patient is going to have a breakthrough pain or something, we can do an rectus sheath block, because the rectus muscle, it's not just seen, what is not seen externally, but then it extends much laterally than what is seen in the abdomen. So we can put in an rectus sheath block as a rescue analgesic in PACU after extubation, so that we can supplement with other intravenous analgesic techniques or multimodal analgesic techniques. Hope I have answered your question.
Yeah, thank you, Soma, for sharing the case where you had to do the rectus sheath block in the ITU to wean the patient off. I mean, that's a good learning point. I think we have discussed this extensively, whether you perform single shot rectus sheath blocks or use rectus sheath catheters. You say that your surgeons don't let you touch, and they'd like to do themselves. So,
yes,
and also we
I
have
rarely practice rectus sheath catheters.
Yeah. And Shiv sir has also enumerated that obviously it's not in the literature so far, but the complications with rectus sheath catheters can be actually something which we need to look forward for. Okay. So how has your experience with posterior tap or QLB been for these extensive laparotomies?
My experience with QLB for laparotomies is limited. I have given posterior tap with very good results, very good analgesia, but then the visceral component of pain has to be taken care of. So we use in multimodal analgesic techniques, and I always use an intraoperative magnesium or xylocard infusion and paracetamol, and so with the multimodal analgesic technique and along with posterior tap, the patient outcomes have been better in terms of pain and even otherwise. So, yeah.
Thank you, Soma. Thank you so much for your experience. Next question is for Sunil, who obviously is an expert dealing with nephrectomies every single day. So, Sunil, could you please tell us which blocks do you prefer for nephrectomy patients?
Yeah, Dr. Pallavi, like on the one hand, like I was discussing a QL block today, but I'm a big fan of posterior tap and erector spinal block in most of the patient wherever it is, it can be done. So in nephrectomy, like as we were discussing earlier, like the position is already there for a QL block. So it makes it very easy to do a QL3 block in these patients. But as you showed the figure just right now, like that was an open nephrectomy. The concern is there, like the incision is at the same place. And even with the QL blocks, like we are very near to the kidney. So whenever I have a concern, like, like some angial myelopoma or a partial nephrectomy, these kind of procedures are done. So I would not like to interfere with the surgical field. So then the erector spinae plane block becomes a gold standard in these kind of cases. So that is what I'm doing these days.
Thank you, Sunil.
Yes. What level are you doing that, Sunil? I think that you now told us the audience.
Yeah, that was his next question.
Yeah. Okay, okay.
So,
like, what level for the ESP? Is it what level ESP you are asking?
Yes, Sunil.
So it's in majority of the cases like T10 or T11 will suffice the job. So I never required to do a ESP below T12 in none of the cases. Like even as you were saying, like 2-level ESP is like one of my favorite again. I avoid giving a ESP with the larger volumes because I did a few cases of contrast also in PCNL cases. That was very easy for me to do the contrast studies. I found like the spread was not very uniform, and like sometimes it is going down quarterly or cephalic. So, but it was certain to a level of 2-3 levels. Like so, beyond that, I was not very convinced. So, whenever it is required more than 3 or 4 level block, so I will always do or prefer a 2-level block. Like so, a big midline laparotomy, I always prefer to do a block at T7 ESP and then again at a T11. So
okay. Yeah, so Sunil, you're a strong proponent of ESP. That's good. And what complications? I mean, you also do a lot of QLBs as well. So, have you seen any complications with QLB?
QLB, I'll say like not much of a significant complications, but yes, as the literature also says, there are chances of lumbar plexus involvement causing a lower limb weakness, a quadriceps weakness. So whenever I'm doing a QL3 block, it is my job to to make it sure that the patient is not mobilized on the same day. So I like to follow up the patient and clear that patient from my side, and whether or on the other hand it will be mobilized on the next day at least. So that is the main thing I like to convey, to be careful, that quadriceps weakness.
And which approach is it?
Yeah,
common?
QL3 or better we call it as an anterior quadratus lumborum. Yeah.
I've done QLB for a consultant colleague's wife. She had a TLH, and she had a numb patch for 24 hours just above her iliac crest, only on one side. So obviously it was the block. So something very uncommon I've seen, but yes. Okay.
Yeah.
Moving
I mean,
on.
QL3, sorry, Paul. QL3 is a transmuscular block, right? And you actually see all the nerves, different nerves. So you can, like I say, you can kebab any kind of nerve if you're not, any branches. I think Sunil showed that there was actually a nerve when he was injecting local anesthetic. It's quite possible, like injuries can happen.
Yeah, and especially if the
Yes.
volume is high, it can track down
Yeah,
and it can cause.
yeah.
So, to summarize, would you like to summarize the indications for QLB, Sunil?
Yeah, like commonly, as you mentioned here, like the large bowel resections or open or laparoscopic appendicectomies, cholecystectomies. I will say like I'll add up a subcostal tab block in that, cesarean sections, TH. Then one of my favorites, like open prostatectomy, I have not seen in the last, I think, 7-8 years in my career now. All are going towards a robotic prostatectomies. So posterior tab block is doing one of the great job in that. Renal transplant surgeries, both laparoscopic and open, nephrectomies, abdominoplasty. Iliac crest bone graft, I'll say like QL1 will also do a job in this one. We'll cover a lateral cutaneous branch there. And then ileostomy, exploratory laparotomy, a big list is there. Yeah, I can.
The list is extensive. It's quite a versatile block. Yeah.
Yeah, if you have a time, okay.
Sorry?
I was like, if you have a time, I can talk a little about transplant surgeries, like whatever we have done in the last maybe 10-15 years. So how we started with and now what we are doing with the blocks like.
Okay.
So there is a very limited data in the literature regarding the transplant surgeries.
Yeah, sure. We will come back to that, Sunil.
Sure.
Let us first cover what we need to, and we will definitely come back to it towards the end.
Sure.
Most of the people do not prefer blocks for laparoscopic surgeries, but I think Shiv sir is a very strong advocate of doing blocks for laparoscopic surgeries. So he will talk to us through what he does exactly for the laparoscopic appendicectomies, cholecystectomies, or the bariatric surgeries as well. So Shiv sir, over to you. Sir, you mute.
Yeah. Thank you. So, yes, for lap colis, I don't actually do this too many of them because my area is mainly vascular and orthopedics. But I do actually have some sessions where I do actually do this as flexible sessions. Lap colis, I've been actually doing blocks for them for a very long time. Actually, if you look at the literature, the first use of tab block for these was actually described by me and my regional anesthesia fellow long ago, and ultrasound guided tab block. Okay, and it has been again one of the neglected. We actually did, I think it was some case series way back in somewhere in I think 2010 or 11 or maybe early. It was published in BJA. So what blocks do we do? So you need to know where your ports are going to be.
Both sides.
Yeah, and if you look at the literature, the main pain comes from the the main port, which is supraumbilical in most cases. In gas sleeve, it might be infraumbilical. Okay, so you need to actually look at, and if you're doing lap appendectomy or you're doing, let's say, like lap hernias, you need to know where your ports are. Okay. So if you're looking at lap chole, you know that the ports are going to be at the main port, which is umbilical, paraumbilical area, so paraumbilical rectus sheath block. Then the next port is going to be in the xiphisternal area, so you're next from there. And there is nothing actually on the left side. Until this is a bariatric patient, then again, there is actually different variations. So you need to know that in bariatric cases, they might actually have a port coming from the left side. So in that case, you require bilateral tap blocks. Okay. But if it's a standard lap chole, I actually do rectus sheath blocks at the paraumbilical area and xiphisternal area. And then I actually do a block under the subcostal margin in the mid axillary line. So this is not a subcostal tap. This is actually a tap in the subcostal area. Okay. So you do that with 20 mL of local anesthetic. So it's like a posterior tap, but it is under the subcostal margin, just under the subcostal margin. And I can tell you with 100% guarantee that we have actually had patients who discharged within 2 hours, and none of these patients actually had any opioids.
Wonderful.
Okay, just simple multimodal analgesia, and they actually maintain that.
I still remember the post on which we had a discussion about this, and the discussion
Yeah.
between you and Guru. I still remember. I think
Yeah.
it's a 5-year-old post.
Yeah. We always had a good discussions. I
Yeah.
think Guru has mellowed down now. So yes, so lots of the blocks can be actually done for that, but just understand the anatomy, surgical anatomy.
Yeah.
Like for example, if I'm actually doing say lap hernias, then I need to actually cover the lower end, the inguinal. So I will actually do bilateral lower taps, the one I describe as the Eisenmenger point, those ones, lower taps, because that I need to cover those. And then the ports are actually above the at the rectus sheath level, so I do that. So you need to cover that. Now there is other group of people who have actually done like 4-quadrant tap blocks. So they're basically doing tap blocks below the subcostal margin and above the iliac crest. That also covers the whole abdomen. So that is another way of doing them.
Okay. Perfect. So let's move on to the next question is for Jennyl. Jennyl, what's your to-go block for the hernia repairs? I know most of the surgeons now like to do minimally invasive procedures, but we may encounter sometimes when it's done open, a open repair is done. So what are the nerves targeted and what blocks would you perform?
Yeah, actually, in my government hospital, most of the cases are open hernia repairs. Rarely they do the mesh. So what I do is the iliohypogastric nerve block, supplement with the spermatic few ml into the spermatic cords, and when they take bite from when you keep the mesh, when they take a bite from the pubic tubercle, sometimes the surgeons might have to infiltrate that point. Otherwise, these patients are much comfortable. I have done many cases under open, local. Patients come with morbid cases, low ejection fractions, elderly individuals, COPD patients. Always you can do a hernia block much easier. Laparoscopic, both sides are different. You need to go for a bilateral lower tap and lower rectus block.
Perfect. Thanks, Jennyl. Also, I think many a times we are again faced with situations where a lap could need to be converted into an open procedure. So, what is your to-go block for an open appendicectomy and an open cholecystectomy?
Open appendicectomy, to be very funny, actually I have done a open appendicectomy under local. Actually, it is a very young fellow, 23-year-old. So I had a nice chat with them. I told him I'll just give you a local infiltration. The surgeon just said, patient is moving the limbs. I said, sir, you just pick the appendix. Don't pull the appendix. Patient will have a bradycardia and patient will have traction pain. I have given ilioinguinal and iliohypogastric nerve block at the spine umbilical line. And patient had pain while skin infiltration, and then they went down. When they touched the peritoneum, patient had pain. I just gave, he said, I gave some ketamine and some midazolam. That was sufficient, and then patient was sleeping. And then one thing was they have to go one finger and they have to sweep it off. If that appendix comes with one sweep, then you are lucky, or you have to convert to GA. So that the appendix came in one sweep, and then they have to tie it and then put it on, and then they have to close it up. That's open appendicectomy. Open cholecystectomy, we do it under a spinal with subcostal tap.
Yeah, usually these cholecystectomy patients, they are, if they need an open procedure, they are really very sick and they could be septic as well. So I think doing a good block in this scenario would be really helpful for the respiratory recovery as well.
Actually, open cholecystectomy, when you see when senior surgeons, when very senior surgeons do, they put incision like a porthole. That what's the incision they do when they catch hold of the fundus of the gallbladder, then they just peel and go on and then tie it up and come off. The incision won't be very much big. Once I did the open cholecystectomy, the senior surgeon was there sitting and looking at me. I gave epidural and GA. The incision was like just like 1 centimeter or 2 centimeter. I was like, what is this? Then I said, sir, you would have told me, then I would have not given anything. I would have just given you hold my mask. So it is like there are people who does open cholecystectomy with 2 centimeter incisions, and that thing can do just a subcostal tap.
Okay, guys, I think we have exceeded the time by almost 20 minutes. I think we need to wrap it up.
Yeah, so that's the last thing. I think, yes, ESP and PVB also can be done for the complex spine surgery like spine instrumentations. And I think we've discussed the ESB and PVB pretty much in detail. So we won't be going, but just to throw some light that we can do these blocks for spine surgeries as well. And so the take home message is, of course, know your surgeon, how he, what's his approach. Obviously, know your anatomy for any kind of block, and then choose the right block for giving the patient the best experience. I think we've finished well within time. We've taken exactly 1 hour, 15 minutes. And thank you so much, everybody. Thank you, Shiv sir. Thank you, Soma, Jennyl, Sunil. Sunil, we will come back to your experience with the transplant surgeries at a later date. We probably can have a separate session. And thank you very much for giving me the opportunity to conduct this session. Thank you.
Thank you, guys.
Thank you, Dr. Pallavi, Dr. Shiv, Dr. Sunil, Dr. Jennyl, Dr. Soma for this comprehensive discussion on abdominal surgeries. And we learned a lot as regards anatomy, various techniques, and the various blocks for various kind of incisional surgeries. Thank you once again. So our next session is regional anesthesia technique for total hip arthroplasties. This session will be moderated by Dr. Atul. He is a consultant anesthetist at Mishra NHS Trust, and his special interests include innovations as well as in regional anesthesia. So over to Dr. Atul for this session.
Thank you, Divesh. Thank you so much. I was enjoying morning sessions. Were very good, excellent. I really enjoyed. Well done, Pallavi. You are a star. You smashed it. Thank you.
Thank you.
Now, what to say about this panel? We are going to discuss about the total hip arthroplasties, and then there are stalwarts, Divesh, who started this, Shiv Kumar Singh Sahab, who is already well known globally in the world of anesthesia and regional anesthesia. Then we have got Guru, who comes with excellent comments and then has got tremendous knowledge and experience. Then Ravish Shetty, who is a consultant in Liverpool University along with Dr. Shiv Kumar, and his special interest is in orthopedics, regional anesthesia, acute pain management, besides bariatric. So wonderful faculty. And then I'm sure that I'm going to enjoy this session. So like every other session, we should know that what is the anatomy, the relevant anatomy to these incisions or approaches to the hip arthroplasty. I'll request my panel to keep to the time so that we can finish on time. And then we are going to discuss about hip innovation and relevant anatomy in this session, plexus blocks, lumbar plexus, sacral plexus, spinal anesthesia and adjuncts, peripheral nerve blocks like lateral femoral cutaneous nerve, fascia alica and PANG, and then periarticular injections and other analgesic protocols, especially in relevance to Australia. We've got faculty from there, and then miscellaneous topics like revision hip arthroplasties. I request first Dr. Ravish Shetty to let us know a bit about hip innovation and relevant anatomy, please. Ravish, over to you.
Thank you, Atul. I'll be sharing the screen now.
Yeah, you can.
Hope you all can see it now.
Yes,
You need to put it on slideshow, please.
slideshow.
Lovely.
Good morning, everyone. So before jumping onto the blocks and what blocks to do for what surgery and everything, we should know the basics very strong, because without the strong basics, we can't achieve what we need to achieve at the final stage, or whatever we do, the blocks or analgesia, or recovery or enhanced recovery. For everything, the basic is anatomy. So in a nutshell, the one thing which has not changed is the anatomy. Anatomy has not changed, but we day by day, we are coming with microscopic innervation or microscopic advanced study and evidence for the various parts of the innervation of the various parts of the body. Other than that, in a nutshell, the only thing which has not changed over years is the anatomy. Only thing what we have done is the various techniques, how to approach it, how to block the different kinds of nerves and all kind of things. So the innervation of the hip itself can take all day discussion. So what I need to briefly mention is that there is no single nerve which innervates the hip, or there is no single plexus which innervates the hip. Again, it's a group of plexus. We are talking about lumbar plexus and the sacral plexus, these two. So the three main nerves which innervate the hip, what is mentioned in as it is explained in the diagrams, are the femoral nerve, obturator nerve, and the sciatic nerve. So mostly the pain from the hip arthroplasty, whether it is a lateral approach or whether it's a posterior approach, the main pain comes from the joints, and then from the skin and the subcutaneous tissues, which usually it can be handled with local infiltration, other kind of things. So after a thorough microscopic studies with the surgeons, so what they have come to a conclusion after a big study of the anatomy, the anteromedial aspect of the capsule is innervated by the articular branch of the obturator nerve. This is the summary of what I'm going to tell, because there is a lot of discussion about the blocks and how to do that. So the anteromedial part of the capsule is innervated by the articular branch of the obturator nerve. Then coming to the anterior part of the hip capsule is innervated by articular branch of the femoral nerve. And posterior part and posterolateral part, all of the capsule is innervated by sciatic nerve. In fact, the sciatic nerve has got the larger input for the capsular innervation of the hip joint. So in summary, obturator nerve contributes for the anteromedial part, femoral nerve contributes for the anterior part, and the sciatic nerve contributes for the posterior and posterolateral part of the capsule of the hip joint. Then coming to the cutaneous innervation. So in the inguinal area, normally we all know ilioinguinal nerve or L1-2, and on the lateral side it is by the lateral cutaneous nerve of the type. So as any for the trainees or any practitioners, what we need to do is there is no single nerve which innervates the hip. It is mainly the three nerves which will innervate, that is femoral, obturator, sciatic. So if you want to achieve a fantastic nerve block or analgesia, we have to catch all these three nerves. Without that, we can't get 100% analgesia in these patients. So let's carry on with further discussion. So that's the reason I want to keep the anatomy very, very minimum, just to focus on what the blocks are going to be for the analgesia.
You can stop sharing your screen, Ravish.
Yeah, Atul. Atul, you're muted.
You're muted, yeah.
Unmute. Okay, sorry about that. A bit of computer glitch. Okay, now we know that our population is changing day by day. Let me readjust these things and then go on to the PowerPoint slideshow. Our population is changing day by day, and then we are getting more and more hip fractures. we see in our routine practice. And then where we can't give, say, for example, spinal anesthesia or other, can't manage it differently. In such population, with or without GA, what are the options? Would you mind please letting us know, Dr. Shiv Kumar, because you are a huge expert in regional anesthetics, and then we would like to know your experience about managing such patients, please.
Can I please share my screen, please?
Yeah.
Yeah, so I think well, one of the issues, I think we're not just talking about elective total hip arthroplasties, we're also talking about hemiarthroplasties, which is common to the elderly patients coming with trauma hip. And that's a very large population. And sometimes the hip fractures also actually go for total hip replacement. I have seen that the conversion from hemiarthroplasty to total arthroplasty later on, it can cause a lot more morbidity and mortality. And increasing population, because these are elderly patients, we see patients who actually got dementia and they're not able to consent. And so they actually cannot lie, or they cannot understand your instructions. In that case, spinal anesthesia sometimes is not the choice. And we end up actually giving general anesthesia. But at the same time, you also want to provide them absolute analgesia. And now actually having done almost more than 1,000 lumbar sacral plexus blocks, obviously measure of them are in this elderly group of patients, I'm going to talk about these blocks. This Ravish has already has covered that the innovation to the hip comes from all the nerves, that is two major nerves from the lumbar plexus, and that is your femoral nerve and the obturator nerve, and third one is the your sciatic nerve, which come from sacral plexus. So lumbar plexus, just for anatomy wise, so major one is the femoral, L2, L3, L4. Okay, then you got little cutaneous, which might be involved in the incision site. Then the obturator, which actually gives branch to the medial, this anteromedial part of the hip joint. And then there's a branch to lumbosacral trunk, which I will actually talk about. Ilioinguinal, iliohypogastric nerves are not of much of concern here. But what you can actually see, that lumbar plexus, now that's where the lumbar plexus is actually lying. It's lying in the psoas compartment. So you can actually block psoas compartment anteriorly. So those so-called the fascioliaca block, where you use large volume and assume the local anesthetic will extend up. But then that misses off the obturator in most of the cases. And that has been studied extensively. So you can give fascioliaca block, it will block your femoral nerve, lateral cutaneous nerve, but it won't block your obturator nerve. And that's why lumbar plexus actually comes in there. This is an old video. I have actually shared it many times. So you mark the spine, you mark the posterior leg spine. So patient is lying on the side, and you draw a line over the spine, and the second line goes from the posterior leg spine parallel to the first line, and then there's the two-fused line. Okay. And then we divide this line between the spine and the line passing through the posterior leg spine. You divide into medial 2/3 and lateral 1/3. And that's the point you have to go slightly above or below. So 1 centimeter above or below, because what you're looking at is actually interspace. The idea is to actually hit the transverse process. Okay, and then you can see that we've actually gone a centimeter below. And then you're going to walk off the transverse process. Now, the distance from skin to transverse process depends on the build of the patient. So if you have a very big patient, there's a lot of tissues and you might need to use a long needle. But a thin patient, the distance can just be around 4 centimeters or so. And when you walk off the spine, the distance from the spine to the nerve is fixed to 18 to 20 millimeters. Okay. So what you're going to look for is exactly the response you will actually see in the femoral nerve. So you can see the your cordyceps stimulation or the dancing of the patella. And once you actually have gone to the required current, here we go down to around 0.4 millimeters. to 4.5 milliamps, and then you inject the local anesthetic. Now, one of the things which I actually teach to people is that you don't actually connect anything to your side port. So do not connect your syringe to the extension tubing. Leave the side port open to the atmosphere. Because if you're too medial, you can actually go into the dural cuff and you'll see CSF. I've seen 4 cases till now. With the trainees actually doing it, and then we just said, okay, fine, stop. I think your landmarks are wrong. Readjust them, and you're fine with that. Or if there is any blood, that is because it's open to atmosphere, you immediately see the blood. So we're not having done more than 1,000 of them. Now we don't actually see it. We have not seen any complication actually happening. Rather, we have prevented complications from happening in these cases. So coming to the sciatic nerve is a lumbosacral trunk. So you got branches from the lumbar plexus, so L4, L5, and then S1, S2, S3 forms your sciatic nerve, and that's your main nerve. Okay. You also have other nerves like superior gluteal nerve and the inferior gluteal nerve, and I'll tell you the importance of knowing that. And there are other nerves which are not going to be of much significance to us for total hip arthroplasties. Okay. So this is very, very important. Here you can actually see that we actually have got the sciatic nerve, so the back, so they got the piriformis, and you have the superior gluteal nerve, inferior gluteal nerve. And the landmarks which I'm going to actually show is related to this. So you have the posterior leg spine, and you actually have the your ischial tuberosity. You draw this line, and then you actually divide into 1/3 and 2/3. So superior 1/3, 2/3, and you go on there, and you'll be stimulating this area. So that's where the plexus are actually coming from. So not just the sciatic, you see all the branches, and you will stimulating one of them. Okay. So there it's been marked. So you actually have the your posterior sphenic spine, ischial tuberosity, and that's divided into upper 1/3, lower 2/3, and that's the point we actually are going to go for the sciatic plexus or sacral plexus. When you get this point, sometimes, like I said, the importance of knowing about the inferior gluteal nerve and superior gluteal nerves, that when you're going in, you might actually first encounter the inferior gluteal nerve, which causes the stimulation of the gluteus. And you actually start thinking, oh, wow, that's it. Okay. But what you want to look for is actually twitching, as you would see for that. That's it. That's the response you need to see. Okay. It doesn't matter whether it's a plantar flexion or dorsiflexion of the foot. We are not actually, blocking the sciatic nerve here. Once you get this response, you know that you're in right place, reduce the current and deposit local anesthetic. So you tend to use 10 mL for the sciatic nerve, sacral plexus. I use 0.375 levobupivacaine, and 20 mL for lumbar plexus. Okay. And that covers most of it. And you still have to remember that there are other nerves which actually are important. And here I pointed out in this diagram. So there are actually dorsal rami of L1, L2, L3, which actually might extend into the incision site, and that can be deposited. So these are the clunian nerves. You can have either local anesthetic deposited over the iliac crest, or in the end, if that has been a problem, you can ask the surgeon to infiltrate local anesthetic. So as in summary, these are D blocks. You have similar contraindication as to neuroaxial blocks, and these are advanced blocks. You need to have good knowledge of the anatomy. You need to have 3D imagination of the anatomy. And always, you are still going to have a safe practice. Stop before you block is very, very important. IV access, research equipment. And know your landmark. Draw them before you actually do the lumbar and sacral plexus. And for safety of lumbar plexus, do not connect anything to the extension tubing so that you can actually see if you have gone too medial, you will see a CSF. Okay. I think I'll stop sharing now, and this is.
Thank you, Shiv Saab. Thank you very much. I can't leave you so soon. So very well explained, and then especially the importance of leaving the port open so that in case it goes into a vessel or otherwise, you come to know about the which can be a disaster
Yep.
sooner than later. Normally, in my practice, what I've seen, Shiv Saab, that I place my hand like that on patient's back when I take needle in through the skin, and then I can feel the twitches of the erector spinae. And the minute they disappears, I know that I'm through the erector spinae now. My needle tip is through the erector spinae. And that gives me idea that now how much more I need to go in. And another thing is sometimes when I leave my needle in there, when I reach there and see the movement of the needle hub, if it is moving, that means that it has punctured the kidney. Have you come across any?
No.
Have you come across any complete? Because I've seen on ultrasound. Now we do
No,
ultrasound.
nonsense. Absolutely, absolutely. Like I said, that's why I actually say that the landmark for you need to be to hit the transverse process.
Yes.
That's what I teach.
Yes.
Because that distance is variable and depending on the build of the patient. What is not variable is the distance from the transverse process to the nerve. Okay. And if they start going, then obviously it depends on the angulation, the a square by b square square root. No, we're not teaching mathematics here. But yes, approximately once you actually the trainee starts going beyond 2 centimeters, say, I think you got it wrong. Come out, readjust yourself and remark. Okay. So that's very, very important. So if you're not going to go more than 2 centimeters, you can never go into a kidney or anywhere else. You
So
still
you
be
gave
in the
two
muscle.
pulse then. Yeah. So you gave two pulse. A, hit the transverse process, number
Yeah.
one, which is important, and don't go too deep, not
Yeah.
more than 2 or 3 centimeters.
Absolutely.
Have you seen in your clinical life by you or anyone else coming across any case of renal hematoma? Have you heard of it, or have you gone through that?
Not at all. Not at all. Because I was the only person who was actually doing these blocks, and that's what I teach. And what I have actually seen, the 4 cases of which, 3 of which were with my residents, where there was CSF, 1 was with a consultant. Rather, he actually, before joining the becoming a consultant, he came to me to learn that. And the first one he actually had was CSF. First ever block. And he came running. He was across on my theater. He came across. I say, you saved my life. He said, I would have injected local anesthetic. If I didn't know this one, I would have injected 20 mL. I would have got I've seen one of other consultants who didn't follow this, actually had a total spinal.
Yeah. So before
I've
asking
seen that.
Yeah. Before asking you another question, I would like to share my screen just for a second, please.
Yeah.
Okay. And then share. And then, so interestingly, what happened that when registrar was working with me, in those times, probably senior registrar was the position. So I put my ultrasound probe in the subcostal area. It happened in 2007, 2008. And then started watching needle when it goes in. And then I've seen on ultrasound the needle going into the kidney, because the kidney was so lower down into the pelvis that we won't believe that sometimes kidney. So that is very important, which you suggested. Unfortunately, my name is not there in the block, even when we described this in 2008 or so. And then people know it by some other names. But then, yes, we have taken the permission of New Intervention Procedure Advisory Group, because in UK, you can't do anything new so easily. So, so it's very interesting. Please take care that you don't take your needle too deep inside, otherwise that can be a trouble. What about the volume of local anesthetics? How much volume you need for the lumbar plexus block? For sacral plexus, I understand very little volume can do. But what about lumbar plexus?
So I actually use there is actually one more approach which I haven't talked about with lumbar plexus block. That's actually a lumbosacral block where you can actually just deposit single place and get both. And this is sometimes seen in people who actually do lumbar plexus, and they go quarterly, and then they get response. They say, "Oh, I got response of the quadricep as well as the hamstrings." What is that's where you done a lumbosacral, because stimulating both this the lumbar as well as sacral plexus. There 30 mLs will do. But in cases of the lumbar plexus with nerve stimulation, I use 20 mLs of 0.375 for lumbar plexus and 10 mLs for sacral plexus, and that does the job very well for standard size patients. I have reduced the volume if I have a very small patient. I even actually go for around 10 and 5. But for average size patient like a 70 kg or 60 kg patient, I use around 20 mLs and 10 mLs, 30 mLs of 0.375.
Okay, I've heard you describing quadratus lumborum 1 and 2 blocks in previous session, but then what's the difference between the lumbar plexus block and compartment block in terms of lumbar plexus block? Can you please say a few words, please?
So if you look at the thoracolumbar fascia, the way it is divided, psoas compartment is totally different from the quadratus lumborum. So unless you actually breach the fascia and go into the psoas compartment, you shouldn't actually get a kind of a block of the lumbar plexus from the quadratus lumborum.
Okay, great. Great. Any more things you want to share with you, the trick of trade regarding lumbar plexus block or sacral plexus block for the benefit of delegates, please?
So we started actually, when this group was started in 2011, when I actually started talking on lumbar, there was so much of resistance. Even Guru is there. He knows that how they were. And now they have started. There's been now a lot of people actually use the lumbar sacral plexus block. There are lots of, cases which has been published, I mean, on the anesthesia group, where people have also used this as a sole block. And we do hollow block sleep, but in 2018 I was actually invited to BDMC in Howard Medical College hospitals, and I actually did a awake lumbar plexus block for a vascular patient there, and patient tolerated quite well. I think here in UK, at least in our region in Liverpool, they won't allow us to touch patients till they sleep. Ravish know it. He's nodding. Yeah. Thank you.
No, thank you. Thank you very much, Shiv Saab. We'll come back to you again for the benefit of delegates. We'll be asking you many questions, but then probably it's time to move on to another stalwart, who is the brain behind this program today, Divesh. Divesh Arora Saab, let me, my computer is flooded. Devesh Arora Sahab is Associate Director and HOD Anesthesia and OT Services in Asian Hospitals, Faridabad. I met him long back. He's brilliant. He's a huge talent. He has got huge talent and he's a very enthusiastic person. And then his all efforts are about enhancing the standards of anesthesia in everywhere globally. So my question to you, Devesh, is that if there's a old patient, 65 years old patient or so, all right, and then who is on clopidogrel because of any reasons, and then he falls down, and then he's scheduled for hemiarthroplasty. Now, how you will manage such patients, anesthesia, analgesia in perioperative care, because these patients are hugely challenging. They are on blood thinning agents, and then they can be a huge challenge to us. Please share your knowledge.
As the patient, as you said, sir, is on clopidogrel, my choice has to be general anesthesia as far as anesthesia is concerned. Personally, my favorite anesthesia for neck surgeries, human neck or hip arthroplasties is spinal anesthesia. But in this case, as the patient is on clopidogrel, we cannot give spinal anesthesia. So I would like to go for general anesthesia as the main anesthesia technique. But for analgesia purposes, I will like to combine pen block with a lateral cutaneous, above thigh to take care of the cutaneous component. Or another option I have is doing a suprainguinal fascia diaphragm compartment block. And in case it happens to be it's a hemiarthroplasty, if the surgeon wants, we can put in a catheter at both places.
So what does this PANG block provide? How does it help in patients? Can you tell us more about it, please?
Can I start my presentation, sir? If you
yes, please carry on.
So the innovation of the hip has been covered in detail by Dr. Ravish Shetty. I'll not like to go into it again, but I like to stress upon the presence of nociceptors and mechanoceptors which are present in the interior capsule as well as the posterior capsule. If we look at this picture, we realize that the maximum number of nociceptors are located in the interior capsule. So this forms the basis of the PANG block, which was described in 2018 by Dr. Arango and colleagues, which basically targets the articular branches which supplies the anterior capsule, mainly the femoral obturator, and in case accessory obturator nerve is present. So this was described as providing the motor sparing analgesia for hip surgeries. So this is the picture we get when we place a curvilinear ultrasound probe. And what we realize is that between the anterior inferior iliac spine and the iliopubic eminence, the nerves pass through towards the hip capsule. And if we deposit a local anesthetic in this place, we're likely to get a block of articular branches. That's what has been described as a pericapsular nerve group block with the acronym as PEN. So we started in our hospital doing this block in 2019, but we from the very beginning have been using a linear probe. We need to place the patient supine, and we need to draw a line from the anterior superior iliac spine towards the pubic tubercle. And our probe has to follow this line, and we'll get to see the ultrasound image which I have shown you previously. So when we place the probe, as I mentioned previously, from ACEs to pubic tubercle, and we start moving, first structure is ACEs, which is not shown in this sonographic image, then is anterior inferior iliac spine. And as we move a little more medially, we realize that we get to see the iliopubic eminence. And this is what I call it as an inverse Nike check sign kind of arrangement. As a beginner, we need to know the pattern recognition. And as we become experts, then we need to forget all these things. For example, we were taught as cluster of grapes and traffic light signals. So this is a small video which I'd like to share with you. And this is on the basis of lateral to medial orientation of the needle, as well as we are using a linear probe. So you can very well see the anterior inferior iliac spine coming into the picture. The psoas tendon and the inverse Nike check sign is almost seen here. My needle is going to come from the lateral side, and you can see very well the echogenic needle coming from the lateral side. The aim is to hit the bone. Once you hit, you need to withdraw by a millimeter or so that the drug injection becomes easy. First, we give a test injection, and once we see that the psoas tendon is getting lifted off easily, then the remainder portion of the drug is injected. So it's the drug which is injected is around 20 ml, and the initial literature was recommended as 0.375% or 0.25% of bupivacaine. But in our practice, we have found consistent results with 0.2% ropivacaine also. So the volume which has been described in literature is 20 ml. Even with 10 ml, you can achieve, but the duration will be little shorter. So what we have done in our department is we are using 20 ml plus we add dexamethasone, and we get around 18 to 22 hours of analgesia for hip surgeries. So another block I would like to describe is the suprainguinal fascia iliaca compartment block. So it's a USG guided musculofacial plane block, first described by Hubbard and colleagues in 2011. And the LA is deposited deep to fascia iliaca and superficial to iliacus muscle. So there are various variations, first described by Vinny as a 3-in-1 block, which we actually know turned out to be a 2-in-1 block. And then Dellens described the landmark base fascia iliaca in children. Then ultrasound guided was described in 2008 by Dolan, and finally Hubbard in 2011. So if we look at the fascia iliaca shown in as a compartment, it actually covers the iliacus muscle. So if you deposit a drug in this plane, drug is likely to reach, as I will like to repeat, likely to reach various components of the lumbar plexus. So this is how we do it. Again, we draw a line from anterior superior iliac spine to pubic tubercle, divide into two areas like medial 2/3 and lateral 1/3, as we would have done for a landmark base. And we place the probe in almost a parasagittal orientation with the cranial end of the probe pointing towards the umbilicus. And needle is inserted from caudal to cranial direction. So the sonoanatomy, once we place the probe in this fashion, has been compared by some of the authors as a bow tie appearance or the hourglass appearance. So we get to see the anterior inferior iliac spine, and we also see the fascia iliaca covering the the iliacus muscle. On the caudal side, that is on the hip side, we see a muscle which is sartorius. On the cephalad side, that is the abdominal side, we see the internal oblique. We see a pulsating structure, which is the deep circumflex iliac artery, which is consistently situated above the fascia iliaca. That is a good landmark for us. So we have to learn to recognize this pattern, either bow tie or hourglass. So I have a small video which I'll share with you for suprainguinal fascia iliaca compartment block. So the first thing is to recognize the pattern, which we have already done. The needle is coming from the corded end, and we are trying to unzip the fascia from the underlying muscle. Once the test injection is successful, we inject the remaining portion of the drug, and we can very well see that the deep circumflex iliac artery is lying above the fascia iliaca. So that is a useful landmark as well as a structure to avoid. So what is the volume which will cover majority of the nerves for lumbar plexus? So this study showed by up and down method, a 40 ml of ropivacaine is sufficient to cover at least femoral nerve, LFCN, and the obturator. So coming onto the cutaneous analgesia for hip incisions, the majority of the incisions would fall in the territory of the lateral cutaneous nerve of the thigh, but some of them might escape and we might need to do a subcostal nerve block also. So I'll be covering in next two slides about the lateral femoral cutaneous nerve block. It's also a branch of lumbar plexus. Majority of the cases, it passes underneath the inguinal ligament and comes to lie in a triple FT. It's described in the literature as flat fat-filled tunnel, which is situated between sartorius and tensor fascia lata. So if we deposit a local anesthetic in this place, we are likely to get a good block. So the drug volume generally is around 5 to 8 ml of ropivacaine. It's a sensory block. You can use only 0.2% or 0.1 to 5% of ropivacaine. This is the mnemonic which I teach my DNB training, because in the beginning, they are not familiar as to how to organize the entire setup. And this is quite helpful in the beginning. Obviously, once we mature enough, then we don't need all these mnemonics. So how do we place the probe? There has been a technique which has been described by Professor Bernard Morrigan. He says you palpate ASIS and forefinger fetch down. You place the probe in a transverse direction, and this is what we get. We get to see this flat fat-filled tunnel, and in this tunnel we see the lateral femoral cutaneous nerve, and sometimes we see 1 to 3 branches also. So this is a small video which I'll share with you. The needle is going to come from the lateral to the medial side. This is the sartorius, and on top of sartorius, between tensor fascia lata and rectus femoris, we have this small flat fat-filled tunnel. The idea is to deposit 5 to 7 ml of local anesthetic in this place to catch the lateral femoral cutaneous nerve. This is how it is done, and it's just a sensory nerve. You just need a small volume as well as small concentration of the local anesthetic. So last slide, what do the prospect guidelines say for the total hip arthroplasty? So they just recommend the fascia iliaca or any other local infiltration analgesia technique. They say to avoid epidural analgesia as well as femoral nerve block and lumbar plexus as well as gabapentin administration, because the adverse effects certainly outweigh the benefits. But the choice will depend on the expertise of the anesthetist, kind of incision, and kind of hospital which you are working with. Thank you.
Thank you very much. That was wonderful. So that means that if patient is on blood thinning agents, you can very safely have the option of giving peripheral nerve blocks for the pain relief, and then that helps. That has got morphine sparing effect, and then that's how you can manage the patients, and then you can put them to sleep and then achieve very good analgesia as well. Have you done any awake patient with these peripheral nerve blocks? Because they are mostly analgesic blocks only.
Sir, not in my center, although there are certain case reports are there where they have actually done with PENG and lateral cutaneous, but I don't think so they can provide anesthesia because they specifically target the articular branches. So whatever they have described with high concentrations of propofol or a dexmedetomidine, so almost taking the patient to a stage of general anesthesia. So in my opinion, I don't think anesthesia is possible with these.
Yes. Blocks. So it is important for audience to understand that the blocks doesn't mean that anesthesia only. So they can be given for analgesia purpose or they should be combined with GA or sedation as and when required. But then these are relatively safe when patient is on blood thinning agents. Yeah, thank you, Divesh. Thank you very much. We'll come back to you again. And then it's time now to move on to another very good speaker. And then Ravish Shetty Saab. He is also has got very good command on regional anesthetics. He is a consultant in Liverpool University Hospitals. It's a wonderful place to work. I know many famous people working there. And then, would you mind please telling us something about spinal anesthesia and adjuvants required for hip arthroplasties, please?
Thank you, Atul. I'll start sharing my screen. Right. We all agree from the last couple of presentations that there is no single way of blocking any nerve or getting absolute analgesia or anesthesia by catching one, what you call magic nerve or plexus. So the gold standard anesthesia for total arthroplasty of the hip or arthroplasty of the knee, I think it still remains the subarachnoid block or the central neuroaxial blockade. So generally you should classify it as CNBs, okay, central neuroaxial block. But most popularly, now what we use is only spinal anesthesia or the subarachnoid block. The epidural has become an art of slowly extinct in the Western world. I don't know what exactly is happening in the subcontinent, but as far as I have noticed here from the last 10 or 12 years, the epidural has gone completely, it's going like an art of an extinction, unfortunately. But coming to the arthroplasties for the hip, the best anesthesia, analgesia, enhanced recovery, post-operative outcome, length of stay, or if you take all these factors, spinal is the best. So various centers use various types of spinal anesthetic techniques. Nowadays, it's mainly about the low-dose spinal anesthesia and try to mobilize the patient as quickly as we can. So again, it depends upon the duration of operation, type of the surgeon, and other comorbidities with the patient and other factors as well. So with our experience here, so we started using subarachnoid block with intrathecal diamorphine as the adjunct was the main thing. So the dose variating from 150 micrograms to up to 300, and some used to use up to 500 micrograms of diamorphine. So, but as we all know, the diamorphine intrathecally administered is not without any side effects. They all have lots of side effects. So including urinary retention, pruritus, respiratory depression, constipation. And once we introduce intrathecal opioid already, and we lose all the other ways of administration of opioids to this patient, especially like, subcutaneous, orally, or whatever the way people administer, we can't do that because we can't predict. Unpredictable absorption of the opioids will be there in any other kind of routes of administration. And added on with this subarachnoid opioid, there were several incidents, including I had a patient who went into severe respiratory depression and had near cardiac arrest. So if we give intrathecal opioid, all other routes are almost closed except intravenous route under close observation. So we used to send the patients to, if they receive a good dose of intrathecal opioid, they have to go to high dependency unit or a close observational area or the post-operative care unit, what we call POCU in our setup. So there we can administer other routes, even if they get any additional pain. The second drug which gained severe popularity in the Western world or in the places where I started working from Glasgow and then in the Northwest is intrathecal clonidine. So intrathecal clonidine these days, actual clonidine is an antihypertensive medication acting upon the alpha-2 receptors. And it has got an amazing analgesic property and tranquilizing. Literally, the patient will be relaxed when these medications are administered. So intrathecal clonidine acts at the two levels, one at the spinal level, at the and it acts at the roof of the fourth ventricle, what they call locus ceruleus, where all the lateral lemniscus and all the pain pathway pass through and goes to the thalamus, and then so on and so forth. The first place of action is at the substantia gelatinosa in the spinal level, where it acts at the zone 2. So in our practice, what we use is clonidine. It can vary from 15 to 25 micrograms added to the local anesthetic. So people are quite scared because it causes a little bit of hypotension during operation as well as the post-operative period as well. So in a hypertensive patient, it is an added boon. In a normotensive patient, it might trigger a little bit of what patients are hypotensive, especially in the recovery and in the ward area. So only thing you need is to educate the staffs there, like this is expected, anticipated, what is the accepted and allowed mean arterial pressure in particular of the patient, then adequately hydrate the patient, and if required, give some boluses of vasopressors. So in my opinion, as of now, we have got role for only 2 kinds of drugs to be administered intrathecally for arthroplasties, which will reduce the post-operative consumption of the opioids, and it will also reduces the length of stay, and it promotes the enhanced recovery after the arthroplasties. And these patients who receive intrathecal clonidine, they can go straight away onto the physiotherapy within 6 to 8 hours or following morning, definitely. So the new trend in the field of arthroplasties, the day case arthroplasties. So there is no doubt the clonidine with intrathecal local anesthetic, like a short acting, like a prilocaine, will be the future for a day case arthroplasties, where you can administer an anesthetic in the morning with the clonidine acting for next 12 to 18 hours to 24 hours. And then patient can be mobilized on the same day without any motor effect, without any respiratory depression. Patient will be wide awake, but analgesia is well maintained and preserved. So that's my take home message will be intrathecal clonidine is the future, and diamorphine, where we don't have the facility for clonidine and other kind of things. But still, in my view, the clonidine takes a step ahead than the intrathecal diamorphine. I think a lot of senior colleagues are in the panel, so they can always shell out their experiences in this regard.
Yeah, no, thank you very much. And then have you got any experience with the, Ravish was, with the spinal surgery, post-spinal surgery patients, or with spinal deformities who are posted for the arthroplasties?
Yeah, because, in our center, they all try, and the last person they'll ask is, can we ask Ravish or someone just if you can do a spinal or not? Because there is no contraindication for doing a spinal anesthetic in case of spinal surgery. So there are absolute and relative contraindications for subarachnoid block. So any spinal instrumentation or spinal surgeries, they all fall under relative contraindications. So in those scenarios, what we have to do is the risk versus benefit analysis we have to make. What is the best benefit for the patient, or the risk? We have to outweigh the risk versus benefit, then should go. Especially even if they do spinal instrumentation, for example, fusion or anything, still the spaces are kept there, dura is intact, there is nothing in there. The only thing technically it might be difficult when they take out the laminae, especially after laminectomy, you may not feel the same experience of going through the tissues, skin, subcutaneous tissue, then coming to the muscles, then to the dura, and you may not feel the same kind of what you call a feel, because it's a blind procedure. You may not feel the same feel in your hand. That's when you may have to try slightly paramedian approach in the patients with the spinal surgeries, especially with the discectomies and the laminectomies. So I go for paramedian. And up to L1, I have done, to that level, I have done the spinal anesthesia using a very smaller needle. So use a smaller needle, and don't get just carried away with, it's a take-home message for everybody. Don't get carried away, oh, this patient had a spinal surgery, I can't do spinal. No, that is a myth. So myth is spinal surgery patient can have spinal anesthetic. Only technically it might be challenging. In that scenario, you can use ultrasound. That's where the ultrasound will come into picture, like whether you can see the dura intact there when you can see a white line when you scan over the instrumentation. Anyway, the instruments, when they do spinal fusion, it will be on either side. Still in the middle of those two rods, you can put the probe in and you can see when there's a white line is intact, that is the dura. Some people do spinal anesthesia in the real time using real-time ultrasonography, where we can clearly see the needle puncturing the dura. So in a nutshell, yes, you can do spinal anesthetic, but technically might be challenging, but it is possible.
Yes, Ravish, the
And
way
I
you
do
are
a lot of those.
Yes, Ravish, the way you are describing, it looks like you've got huge experience. I've seen often my senior colleagues, they use 0.75% carocaine. And then sometimes when there's a labile blood pressure or hypertension, they use metaraminol infusion, slow and variable, or phenylephrine. Your experience, what do you say about these things? Your take on it.
We all studied from our basic anesthetic training is the duration of the what you call the spinal anesthetic block depends upon the mass of the drug what we are administered rather than the volume of the drug, isn't it? That's what I think. That's what I do remember. The mass of the drug, which determines the level of the block and the duration of the block. So people using 0.75%, I don't think I have got experience using that, but still I use 0.5% levobuprocaine or levobuprocaine with or heavy buprocaine with the dextrose. So there is no harm in using what you call vasopressor infusion during the period of operation, because spinal anesthesia for aortic stenosis was another topic of discussion elsewhere. So initially, we thought that spinal anesthesia was a contraindication for aortic stenosis. That was a question. That's the way we have to answer to pass an examination with an MD or a DNP or anywhere. If it's a spinal anesthesia and aortic stenosis, no, it was not accepted. No, it is not. So we start a metaraminol infusion or a phenylephrine infusion, keep the target mean arterial pressure above a certain level, do an intra-arterial blood pressure monitoring, and still you can do subarachnoid block. So yes,
Right.
just because the hypotension, we should not get scared.
All right. Okay. No, that's great. Shiv Saab, you want to chip in, please?
No, that's actually like I said, it's if your dose is right, then you don't see. There are two things. I think one thing is that the elderly patients are relatively, I think, more dehydrated, or the volume, intravascular volume is already reduced. So you do see. I'm very liberal with my IV fluids for the elderly. Also, I think we have, despite the fact we tell them that they can drink water till 2 hours before the surgery, I don't think they drink as much. So they're relatively, I think, dehydrated, or so you expect some amount of hypotension. But if you actually take care, I mean, I hardly use any vasopressor in most of my cases. I've never used, at least I've not used infusions for my cases, whether it's a vascular patients or for that. Yes, if it is actually, I have done a patient with severe aortic stenosis coming for hip surgeries. In that cases, it's indicated. But in normal patients, I've never used infusions for these cases. You know, the other thing which I will actually also tell, which is actually neglected by most people, elderly patients are always hypocalcemic. So I do use actually calcium gluconate for most of them. I put it in a bag of fluid, at least 30 to 40 mLs of calcium gluconate, or 10 millimoles of calcium chloride into a bag, and run it. And that actually helps in both. You can actually take samples, blood samples, venous samples, and you'll see most patients will be hypocalcemic. Very, very common.
Very wise words. Very wise words. Thank you very much. I was a bit skeptical about using 0.75% carocaine. And then when I was keeping a very close eye on these first 15 patients. And then I found that often the level of block was T4. And then they were but then I started explaining to the patient that you won't be able to cuff very strongly when I put in spinal. And then I started reducing the volume of the local anesthetics, which I'm injecting. And then I found that that is also has got some beautiful advantages, because you can turn the patient, it's hypobaric, it blocks the upper hip, and then it gives some analgesia to lower hip as well. And then it provides very good analgesia for about 12 to 24 hours. And that means that your blocks, they are working very well, and patient, it has got wonderful morphine sparing effect. But then, yes, you need to learn how to, I'm talking to general audience, not to you. You are expert. But then from point of view of general audience, that they need to learn, they need to have some experience of using hypobaric, and then they should start using it. Yes, that's great. I would like to have this opportunity to share a few slides about the use of ultrasound in these patients, as mentioned by you. So often we get patients like this, especially in this part of the world. Sometimes spine is bendy, sometimes it's not possible to put a needle in there. You have to have a courage to stuck the needle inside, and then sometimes they're too obese there. So therefore, in such situation, I found that the use of ultrasound is quite useful. If you can use more, if you can still hear me, then I will just take you through this small clip. The probe can be placed transversely and then longitudinally. I'm not going to go in detail of this. We can have another session about this, but then you need to move your hand sideways. Every now and again, you go into the interspinal space in order to walk your ultrasound wave onto the lamina and dura and ligamentum flavum complex. And then you need to rotate it in transverse scan and then align it so that you can see the posterior ligamentum, posterior complex very well. After that, there is no need to put in a marker using a pen because that is very inconvenient. Instead, you can just apply a little pressure there, have that blanched area, take it off this probe, and then have this blanched area. And right in the center of that blanched area, you can take the back of a blunt needle and apply some pressure. And that gives a triple response, and that stays there for 3, 4, 5 minutes. And then it is good enough for us to carry on the procedures. Here you can see again the transverse scan. We are aligning into the interspinal space, looking at the dura, then putting in the marker. After this, we'll wipe off whole area, apply some antiseptic again, and local anesthetics and do it. When you're doing longitudinal scan, you start from the paramedian to lateral side in order to confirm the sacrum. And then every now and again, when you go into the interspinal space, take care that your hand is resting onto the patient so that you know where is your probe, because you are looking at the screen, you're not looking here. And then once you select a space, then you need to swivel around your probe and go in transverse scan. So these are the methods which help us in identifying the depth, especially depth and trajectory of the spinal trajectory of the needle, so that we can reach to the spinal space easily. And then in single pass, then you can reach to the spinal space. Oh, sorry. So here are a few pictures, ultrasound images of probe placement. When we place probe, if you consider this picture in the corner, if that is the probe which is shining ultrasound waves, then wherever there is a bone, you will see a shadow. And wherever in between these bones, you will see a window. And that's how we describe shadows and windows. So through window we can see, through shadows you can't see. And through this window, we can then identify the dura ligamentum flavum complex. With the help of Shiv Saab and Divesh, we'll have another session to do this, but then it is quite useful modality where even in very obese patients or with difficult spine, you can get into the space very accurately within 5 minutes or so. Our next speaker, I reserved him for the end, is Dr. Gurunath Murthy. You have heard him in the previous session. He was a moderator, and he has got tremendous knowledge, and he keeps spreading many pearls. We're going to ask him about the periarticular injections and other protocols besides our spinal anesthetics or lumbar plexus block or sacral plexus block, and then let us hear from him. So over to Gurunath Murthy Sahab.
Thank you very much, sir. I'm just going to share my screen now. Thank you for the wonderful introduction. I think Divesh has already mentioned about the latest prospect guideline that was released in 2021, which ultimately suggested for possibly an elective total hip arthroplasty. So remember, we're talking about elective total hip arthroplasty here, is that the best option is either a fascia iliaca block or LIA. So I'm going to talk about a general perspective first, and then we can just broach upon the LIA technique, because it is something on the surgeon's perspective. So we're all looking for something new here. Everybody is on the lookout. Every regional anesthesia conference across years, about 10 to 20 happen every year. People are looking out for new and newer techniques. We are going away from the central neuraxis, more towards the periphery, and more as a motor sparing, opioid sparing techniques. But in all that, we lose one perspective, is what's happening to the patient. Are we actually looking at the patient? What do they understand? What are their expectations and all those things? So rather than trying to find one single solution, we actually have a much holistic pathway. So I'm involved with the joint replacement clinic here, where they've got the patient pathway sorted out very neatly. And in that, it's a comprehensive, holistic approach to joint replacement, where patients from preoperative phase till the postoperative phase have all kinds of modules kind of charted up, seeing a physician preoperatively, seeing an anesthetist preoperatively, a physiotherapist, and a nurse. And throughout this, there is continued patient education, not just about analgesia, but also about physiotherapy. And with that is also post-op analgesia management. So to begin with, you always look into, and I work at different places, so it's not necessary I follow one pathway in all the places, because everything is tailored to the patient's requirement, the surgeon's expectations, and all those things. Just look around if there is any clinical pathway. It's fashionable to talk about fast-track arthroplasty, but it is patient population restricted. It is economy restricted pathway. It is insurance dictated pathway. Whether it's actually going to benefit patient discharging on the same day of surgery, that is highly questionable. And even I think the latest evidence suggests that discharging the patient on the same day after a hip or a knee arthroplasty can be more harmful than beneficial. And again, it may not be applicable in all centers and all population levels. Look out for the indication for total hip replacement, from avascular necrosis to severe osteoarthritis to a fracture. Then this is my area of interest, where you really look into what actually happens in real world versus evidence, what is statistically given. It is always fashionable again to say opioid reductions were less, pain scores were significantly less, but were they clinically significant? Is it worthwhile for me to do this procedure on a day-to-day basis? On a usual list of a joint list, I get to around 6 to 8 joints per day in a day list, and 10 to 15 minutes or extra for me is reaching home an hour and a half to 2 hours later. So, but forget about me. Is it worthwhile to the patient? Is there any risk benefit? Think about this. A lot of evidence about all these fashionable opioid sparing blocks do talk about opioid sparing, but if you look into evidence, 10 milligram of morphine equivalents in 24 hours. That is nothing. That is less than half a milligram per hour. And for that, do we need to do this? Statistically significant reduction in pain scores, of what? 1.2, 1.3, anything has to be truly clinical significant, should be an NRS score of at least 2 or more. But that is what is evidence. And people do talk a lot about these nerve blocks more towards evidence. Other aspect that you need to look into pre-existing pain and how the patient is coping and what's the coping mechanisms and all those things. What are the surgeon's expectations? What is the operative technique? Is it a direct anterior? Is it anterolateral approach? Is it posterior approach? what are the patient expectations and what's the resource setting you got. So not every hospital will have ultrasound. Even in Western world, not every hospitals have ultrasound. So if you are focused only doing ultrasound guided blocks, you'll be at a loss. Patient will be at a loss. So have various types of techniques available in your place, and keep all these factors into picture before you can jump onto this thing. As I said, it's a patient pathway and patient-centric approach that we use, and often it starts from preoperative phase where there is prehabilitation that is involved. There is a lot of patient education, so I've developed technologies which shortly will become widespread, which is already applied across in a couple of centers within my area, where we develop automated messaging and education leaflets to patient about pain management, about anesthesia, about surgery and physiotherapy. All the exercises are taught to the patient and how to manage post-operative pain. Then we look into, is there any chance of optimization of any major health problems, including preoperative pain management. And we know from various studies, one of independent risk factors for significant post-operative pain is the preoperative pain. And also one of the other risk factors is acute post-operative pain. So if you manage these two really well, and again, it's a patient-centric approach, and you will achieve better outcomes. Now, I will not delve into any type of anesthesia. It is quite controversial. I do give all kinds of anesthesia, from spinal to combined spinal to epidurals to GA. Again, it depends whether it's a revision surgery or whether it's a complex surgery or patient requirements, GA or not. But irrespective of the type of anesthesia, our aim is to provide optimal analgesia. And that doesn't include just either LIA or blocks. It includes a comprehensive management, having a multimodal analgesia, which include a opioid or a semi-opioid like drugs. Then you look into the role of surgeon. There are many approaches. As I said, direct anterior approach has better in terms of post-operative outcomes and reduced pain. And also what kind of post-op nursing care and physiotherapists you have who can help look after your patients post-operatively. Coming to LIA, I think this is on the other side of the blood-brain barrier that happens, but they always look upon us saying that, oh, Guru, oh, how much LIA kind of thing. So every time probably we dictate the amount of local anesthetic for many reasons. With blocks for many arthroplasties, which include even knee arthroplasty, sometimes we do combine with the block. And they want to know how much volume they can give, which can be tolerable to the patient. So I asked the surgeon, what areas do you infiltrate? And he gave me this list till the skin subcutaneous tissues. So whereas for a knee joint, it is very well structured areas of interest where they infiltrate, beautifully demonstrated by one of the surgeons who developed from US. I've got those slides. But in hip, I think it is relatively less experienced because of patchy evidence until now. But this practice has gained huge impetus because it is completely motor sparing and devoid of a lot of side effects. So inferior joint capsule, acetabular areas, the muscles, all the capsules, ligaments, bursa, iliotibial tract, and skin and subcutaneous tissues. And how much? On an average, it is about 200 mils of 0.2% narrow pin and the adjuvants that are used. This is pretty much standard. And I do ask them to omit adrenaline in patients who got cardiovascular issues, because every now, if you see, there is no tourniquet in hip operations. So, and surgeons often use very thick, big needles for quick infiltrations. So there is quite a bit of vascular absorption that can happen, and I've seen hypertensive responses, although they are transient. So what about the safety and efficacy in total hip replacements? And Divesh already mentioned the prospect. You can go through those latest guidelines that's available online, and also some network meta-analysis that is being published. Overall, if you look at across 35 meta-analysis and about, I think, 2,300 patients, the LEA group had lower post-operative pain score, opioid consumption at 24 hours compared to placebo. Okay. Now, again, how much is less, how much is, but it is still beneficial than doing nothing, right? But when they compared to a peripheral nerve block techniques, they found the outcomes were similar. But what I've observed is compared to a knee replacement, total hip arthroplasty generally have got lower pain scores. And those who've not had LEA, but just multimodal analgesia, they have actually done very well. So it begs the question that do we need to do a risky blocks, time-consuming blocks? Is it worthwhile? Again, you need to choose your patients carefully. Those with chronic pain and those who are opioid tolerant, yes, it is worthwhile. But for a standard patient, I would always think, is it worthwhile? So LEA is beneficial than doing nothing. Blocks is as good as LEA. And even if you don't do anything, you don't have to worry too much as long as you've got a solid multimodal analgesia going. What about LEA? The best part of LEA I love is there is no risk of wrong side block. So I am totally safe of having do the correct side block unless the surgeon have started operating on the wrong side. That's an altogether different picture. But this is what I love about LEA, not in my hand. There is a reduced false risk. Of course, there is no motor block. Just beware of adrenaline. There could be a small risk of delayed local anesthetic toxicity. There is very questionable, very poor evidence of wound healing and infection. But at the end of the day, it's the surgeon who administers the LEA, and how much of responsibility should we take about the implications or outcomes is actually, it's a dual responsibility. We look at patient as a center of our approach, and we all try to achieve the best possible outcome for our patients. Thank you.
Wonderful. Very well said, Guru Saab. And one more thing you revealed, the 6 to 8 joint replacements every day means loads of money, man. All right, so you must be hugely rich.
No,
right.
Look, it doesn't have, I don't do that every day.
All right, okay, now you're correcting yourself. Okay, so now you mentioned 3 very important things: the resources, availability of resources, place of work, and experience. It matters in our day-to-day practice. So therefore, and then also, if we are start putting in block, if we are expert in block, we should not start thinking that they are the only gold standard in the practice of anesthesia. And then we should not lose the touch with other modalities, how to manage. Yesterday, you were talking about intraplexus, periplexus, and then I find myself perplexed most of the time because I see around me hugely talented people, and then I'm preparing ultrasound machine, preparing patient, convincing patient, explaining to surgeons, not nowadays, initially, and then putting in a block, and then taking patient in, and then keeping my fingers crossed all the time. It will work. Okay. And then my senior colleague, they just use 10 or 20 milligrams of morphine and then they go home very quickly. Just relax, a coffee. And then so it is very, very important that what you want to achieve and then what is the cost of that achievement. And at the end of the day, patient should be winner. Can I please request the panel to please chip in as and when, and then whatever you think are the burning issues and you think that our delegates should know, please come with the pearls or trick of trade. May I request you guys, please? Who is starting? Divesh. So Divesh, what do you find most challenging when you are managing hip arthroplasty, please? And then try to give us answer how to circumvent those challenges.
I think it's the elderly population which I deal with, and a lot of comorbidities are there, delirium issues are there, plus the lack of family support after the surgery. So that is the biggest challenge which I'm facing in my practice. And in India, we do not have that kind of like old age homes or kind of thing, and they are generally IC patients who are admitted in ICU and then their relatives do not come even for consent purpose. So that is a huge challenge which I face in this elderly population.
What about availability of morphine in your part of the world?
Sir, morphine is available, but the only hospital which I've seen in Delhi NCR using it extensively as far PCA pumps are concerned is Artemis, where I worked previously. So generally our mainstay opioid is fentanyl or pentazocine. But still we are not using PCA pumps as it is being used in Western countries or UK very often. So we are not using opioids. We have used less of opioids. Tramadol we use extensively along with paracetamols and NSAIDs, and plus regional anesthesia blocks wherever it's possible.
Okay.
Look, I think we should come out of PCA completely in this perspective. Look, I don't think so. PCA, unless of course the patient has got chronic severe pain and is quite opioid tolerant. PCA, the difference between PCA and subcut opioid is nothing. It's only kind of a nursing benefit. But if you see, patients who use PCA end up actually using more opioid for similar analgesic benefit as compared to a subcut opioid technique. Especially in patients whom you want to mobilize early, you want them to get out of the bed. I'm not used PCA in more than 400 patients in the last, no, never. It's no longer indicated, I think.
Yeah, I agree with you, Guru, because my practice is changing every year or so. I've seen a very less use of PCA in my center now because it requires nursing care, and then it requires more attention towards the patient. Patient may suffer more nausea and vomiting. Instead, people are using nowadays, as I mentioned, 0.75% chirocaine spinal and blocks, if possible, or wherever indicated, and oral morphine and injectable morphine in post-op period only, but otherwise in recovery only, otherwise oral morphine with other analgesics. And then it's
not
changing.
To forget the multimodal analgesia.
Yes,
I think I think the center of your pain management should be multimodal analgesia.
Yes,
here.
yes.
And hip arthroplasty are actually surprisingly lot less painful than what we think.
Do you use any, Shiv Saab, do you use any analgesics before operation, pre-operatively? Do you prepare patients?
So we actually have a lower limb protocol in our center, and that was prepared quite a few years ago. So coming to, I think, if you look at what prospect, outcomes or studies actually have neglected, is the fact that a lot of these patients can develop chronic pain. They have not really looked into the fact that it's not just post-op analgesia, it is also about looking at preventing chronic pain. And that is not included in prospect. So we have pregabalin as part of the protocol. If the patients are not contraindicated non-steroidals, they are given non-steroidals. And they also get oxynorm as part of the, preparation for the analgesia, and that's continued. So even if somebody is actually giving just simple spinal anesthesia, this analgesia will be continued into the post-operative period. So that's our lower limb protocol. You actually have to sign a paper. So if there's elderly patient or patients you don't want to give non-steroidal, you just strike off the non-steroidals, and you can have reduced dose for the elderly patient. Yeah, Guru.
Okay.
I would actually strike off gabapentinoids. If you look at the current, but if you look at the current evidence, the gabapentinoids are more likely to cause harm than benefit.
Yeah.
So we had a recent meeting about updating the fast track arthroplasty, blah, blah, blah. We looked into the evidence, and clearly, I think gabapentinoids have been misused and abused over the last few years in the pretext of trying to prevent chronic pain. And there are more side effect profile. The side effect profile is not just acceptable for the pain analgesia benefit they give. lot of UK trained anesthetists who are here are actually contradicting to that view, but probably they are fixated to that, but the evidence is contrary.
No, I have actually the persons who actually put the protocol, I actually send them, because there is also against actually giving opioids in the elderly patients as well. So both pregabalin, and so we're not left with much to give them, rather not give anything. Yeah.
Okay, Ravish wanted to chip in. Please.
I absolutely agree with Guru. It is not just single way of managing. Multimodal takes the priority, multimodal. And in that, again, we have to talk about the patient's education. So I prepared what you call enhanced recovery protocol for our trust and organization before we became one in Liverpool. So in that, we started something called as joint school. So we used to pool like 15 to 20 patients, like, who are undergoing joint arthroplasty in a room, and various multidisciplinary people used to come and talk. Me as an anesthetist, I used to go and talk them what is an ideal anesthetic and what they are expecting, and talk about spinal anesthetic, general anesthetic, analgesia. So mentally prepare them to experience what is an anesthetic, and mentally some of them used to come, no, I went through everything. We used to give them the leaflet. I went through the leaflet, and then I don't want spinal anesthesia. I want to undergo general anesthesia, and I'm happy to bear the pain. This kind of patient education is needed. Second, on physiotherapy involvement, when they come and talk, you will be on your toes immediately, maximum following day. So they are mentally prepared. So as I remember, when I was doing my post-graduation in anesthesia back home in India in 2001, so after the surgery, if the patient is they mentally prepared that I have to stay in the bed for 5 days. I don't know whether it is changed now or not. I have to be taking rest for 5 days, 7 days. I have to be staying in the hospital for longer. That is the psychology of the patient. And prehabilitation is the other thing. I think we have to translate that prehabilitation from the other specialty into the now orthopedics and the arthroplasty as well. We do prehab for including major liver cancers and sarcomas. We put them on intense prehab program for a week or two, where when we do CPET before and after, their anaerobic threshold and VO2, everything would have been improved quite significantly. If we can do that in patients who fit into that category, not elderly 90-year-old patients who can't do, but those who can fit like 60 to 70 years, 75 years old patients who can get into the program of prehabilitation, that is another thing which we need to look into.
Okay, I don't have any. Yes, Shiv Saab, yes, carry on.
No, I just wanted to actually remind that we have already, I think, finished the time. I think we have reached the end.
So then just
shall we just wind up now, please?
Yes, please. Yes, please. Thanks for reminding. The panel is sorry about that. I got carried away.
We can go on and on this. I mean,
good experience, but Ravish, Ravish, before we close, closing words from you. I heard that you got tremendous experience with revision surgeries, because we are having too many arthroplasties or joint surgeries going on all around the world. Now probably it's time to look for the management of pain in revision hip surgeries. Any advice?
I do lots of revision. I do almost every week or something like that we do, and we have got a very high risk revisions as well coming for. So I know we are running short of time. I will just consolidate into a couple of things. In revisions, again, patient's education, multimodal. First one, multimodal preoperative. I prefer to use oxycodone as my preemptive analgesia. And again, pregabalin, gabapentin, I have taken that out of the equation, as Guru mentioned. It causes more confusion and a bad experience to the patient than the positive journey to the patient. So that is inconclusive. So I don't want to make a debatable discussion on that. Second one, celecoxib or COX-2 inhibitors if they can tolerate. That is the best way to start with the preemptive analgesia as well. Then all my revisions, I give them a spinal anesthetic, a good dose like 3.5 mL of plain levobupropion, not the heavy, with clonidine 25 to 35 micrograms, and intraoperatively, and I'll put them off to sleep as well, because most of these patients have to lie down on their side for 3 hours, sometimes 4 hours, depending upon what kind of revisions. It's a Birmingham resurfacing, a total resurfacing, sometimes revision. So it's all surgeon dependent and the procedure dependent. So I always tend to keep the blood pressure at the minimum acceptable limit, may be according to the patient, if they're hypertensive or normotensive, depending on that. So spinal anesthesia, intrathecal clonidine, general anesthesia for the comfort of the patient, multimodal analgesia, adequate hydration throughout, and we have a program called Sip Still We Send. So patients are allowed to drink water until they are called into the theater. That is 60 ml of water every hour. So that keeps their hydration reasonably well, and it reduces the post-operative nausea, vomiting, and all kinds of things. And intraoperatively, in very complex patients, I stick an epidural. Very, very rarely. I can't remember when I used my epidural at the last. But all these patients post-operatively go to our post-operative care unit, or a POC, or a high dependency unit in the simple terms. So normally we give them an oxy PCA for 24 hours to 48 hours, maximum oxycodone PCA, or if patient can tolerate PCA morphine, and immediately we take them off. 24 hours is the maximum. We don't want to keep longer than that. Then ideally step down with a 12 micrograms patch of fentanyl for 3 days, then take it off and give them the regular weaker opioids like codeine, paracetamol, and non-steroidal anti-inflammatory for 5 days. And in some programs, there was pregabalin for 14 to 18 days. So we have taken that out of the equation. So standard spinal, GA, post-op PCA for 24 hours, then maybe fentanyl a step down, then weaker opioids.
Excellent. Thank you very much. And then thank you, Shiv Saab and Guru and Ravish, for saying a few words about gabapentin-related complications, which are mainly sedation, dizziness, and visual disturbances, which can delay the ambulation in such patients, which is of utmost importance nowadays. Thank you all, panelists. I'm very happy that we could discuss a few things which might be of some help to our attending delegates. And thank you very much. Please allow me to conclude this session. Thank you.
Thank you, Atul. Thank you, whole team and everyone.
Thank you very much.
Thank you, Dr. Atul, for that wonderful session. Now we come to the last part of today's session, that is for total knee replacements and anterior cruciate ligament reconstruction. This session is going to be moderated by myself, and we have esteemed panelists for this session, Dr. Atul Gaur, who needs no introduction. Dr. Anshuman Mishra is consultant at Apollo Lucknow and a dear friend of mine. Dr. Mayank works at Medanta Hospital, Indore. His areas of interest include orthopedics and neuroanesthesia. And last but not the least, Dr. Ravish Shetty is a consultant anesthetist at Liverpool University Hospital, and his special interest includes orthopedics, regional anesthesia, acute pain management, pediatric anesthesia. So I'll give you a brief overview as to how I plan to conduct this panel discussion with my panelists. First of all, there are going to be short PowerPoint presentations. First will be for innovation of knee joint, including capsule by Dr. Mayank. Then Dr. Anshuman is going to enlighten us on femoral nerve block, some tricks. Adductor canal block as well as femoral triangle block will be covered by Dr. Atul Gaur. And how to tackle posterior nape pain will be covered by Dr. Ravish Shetty. Finally, we'll have some question and answers and then take home message by Dr. Ravish Shetty. So over to Dr. Mayank for his presentation on innervation of knee joint. Dr. Mayank, kindly unmute yourself.
Am I audible?
Yeah, you are audible.
Yeah, just a minute. I'm going to start my meeting. Yeah. Slides visible?
Yeah, slides are visible.
Thank you so much, Shiv sir, for giving me this opportunity, and Divesh, Arora sir. It is an esteemed pleasure for me to present in front of you all. We know that, first of all, we come to the basic anatomy of the knee joint, because total knee replacements are one of the most common surgeries that are being performed nowadays as a cosmetic surgeries. Now, regarding the frontal view of the right knee joint, if you correctly see over here, there is a trochlea, that is the patellofemoral groove. Just below that, there is a posterior cruciate ligament, and inferior of this is anterior cruciate ligament. Now, the technique that is currently prevalent in order to reduce the knee pain is to preserve the stability of the knee joint is the posterior cruciate ligament sparing surgeries. And in order to protect it, there is a lateral femoral condyle, and in order to protect it, there is a lateral collateral ligament, then there is a medial collateral ligament, there is a medial meniscus, there is a lateral meniscus, and a small tibial plateau. And there is a tibial tuberosity. Now, coming to the lateral view of it, the things that are important for us in this lateral view is the quadraceps femoris tendon, which is just sticking over here on the patella. In order to again avoid the pain from the surgeon's side, is that they nowadays take an approach which is just not cutting the quadraceps femoris tendon and going besides it in order to have a complete, they just pull over the patella in order to reduce the pain. There is a synovial membrane in order to protect the friction over here. There is an infrapatellar fat body. There is a patellar ligament over here. Subcutaneous infrapatellar bursa is another important structure that is responsible for pain. Deep subtendinous infrapatellar bursa, another pain structure. Now, there is a bursa which is present at the lateral head of the gastrocnemius muscle, which gives pain in the posterior part as well. Now, coming to the basic, another view of the knee joint in the anterior portion. There is a quadraceps femoris muscle. Then there is a tendon of the quadraceps femoris muscle just overlapping the patella. There is a fibular collateral ligament, and there is a patellar ligament. Coming to the nerve supply. Anterior view. Now there are three important nerves, genicular branches from which they arise. There is nerve to vastus medialis, nerve to vastus intermedius, and nerve to vastus lateralis. There is another nerve that is a division of the sciatic nerve from here via the common peroneal nerve, that is superolateral genicular nerve, which arises from the sciatic nerve. Then there is an inferolateral genicular nerve from the common peroneal nerve. There is a saphenous nerve on the medial side of it, and there is a superomedial genicular nerve, which is again a branch from the sciatic nerve. Recurrent fibular nerve, again a branch from the common peroneal nerve. So the knee joint is actually getting the nerve supply from three compartments. The anterior compartment, where the femoral nerve is there, which divides into three parts. Then there is a medial compartment where the obturator nerve divides. And then there is a posterior compartment where there is a sciatic nerve that divides into the tibial nerve and the common peroneal nerve. And they give out the genicular branches. Now, this particular table is extremely important to highlight the nerve divisions. There is a saphenous nerve roots, which is from L2 and L3 roots, and they provide the infrapatellar branch, that is the descending branch. And it supplies the antero-inferior part of the capsule of the knee joint. Now, which cutaneous supply it provides? It provides the anterior and the medial side of the leg, medial and dorsal side of the foot, right up to the great toe. Now, the muscle supplied is the sartorius muscle, and it supplies to the plexus in the form of peripatella, as well as a little part of the subsartorial plexus. Now, where do we, if there is PRF stimulation we are doing, we elicit the paresthesia, and there is pain on the infero-medial aspect of the patella, and we demonstrate the sartorius twitches. Now, there is a tibial nerve, which is having roots from L4, L5, as well as S1, S2, and S3, which provides the articular genicular branches in the form of three: medial superior, medial inferior, and middle capsular branches. They supply the medial part of the capsule, retinaculum, and the collateral ligaments of the knee joint, which is proximal to the tibiofibular joint, as well as it supplies to the cutaneous part of the lateral side of the sole of the foot and the plantar aspects of the toes. Muscle supplied are gastrocnemius, popliteus, hamstrings,
soleus. So this tibial nerve, along with the common peroneal nerve, and along with the nerve to the vastus medialis, which gives the genicular branches, actually are the main branches of the knee joint. Where do we demonstrate the motor twitches? That is the plantar flexus for the tibial nerve. For the common peroneal nerve, again, the branches are from L4 to S2, and they supply to the lateral superior, the lateral inferior, and the recurrent genicular nerves. They supply to the inferolateral capsule of the knee joint and proximal to the tibiofibular joint. Now, the cutaneous supply is from the anterior, posterior, and lateral surface of the leg and foot, the dorsum of the foot and toes, and first interdigital cleft. Muscle supplied short head of biceps femoris. And where do we see? Dorsiflexors of the foot and everters. Now, contributions to the plexus, like peripatellar plexus is an important plexus. It is contributed by the femoral nerve, medial, intermediate, and lateral femoral cutaneous nerves, saphenous nerves, reticular nerves, medial terminal branch, and the innervated area and nerve to vastus intermedius. Now, the innervated areas are, which are the skin anterior, superior, and lateral to the patella. Retinacular collateral ligaments. Subsartorial plexus, there is a saphenous nerve, infrapatellar branch. Obturator nerve, the anterior division of the obturator nerve supplies the subsartorial. There is medial femoral cutaneous nerve and nerve to the vastus medialis. Now, cutaneous supplies to the medial side of the knee retinaculum, collateral ligaments, and capsule of the knee joint. Popliteal nerve contributions to the plexus is via tibial nerve, dividing into sciatic nerve dividing into the tibial nerve and the common peroneal nerve. But there is another division, that is the obturator nerve, which divides and supplies the retinaculum, collateral ligaments, and capsule of the knee joint. Now, this is another diagram which features all these nerves. You can see over here saphenous nerve giving superior medial genicular nerves. There is the sciatic nerve, which divides into the tibial nerve as well as the common peroneal nerve behind. Over here, you can see laterally, just above the femoral condyle, it is dividing into two parts, and the common peroneal nerve is supplied with the help of a superficial peroneal nerve and the inferior lateral genicular nerve, superior lateral genicular nerves, the lateral aspect of the knee joint. The medial sural nerve, cutaneous nerve, which supplies the anterior aspect of the cutaneous part. Now, in short, again, the same branches are over here. The more important nerve that is prevalent is the recurrent common peroneal nerve, which applies just behind the knee joint and supplies it in front. Now, these are the 10 nerves which are to be remembered finally. Femoral nerve gives twigs from the nerves to the three vasti. Tibial nerve gives superior medial genicular nerve, inferior medial genicular nerve, and middle genicular nerve. Common peroneal nerve gives superior lateral genicular nerve, that is supplying the lateral aspect of the knee joint, inferior lateral genicular nerve, and there is a curved nerve, that is the recurrent genicular nerve. The obturator nerve in the medial compartment gives the genicular branch mostly from the posterior division. This is the posterior compartment, and you can see over here the division of the sciatic nerve into the tibial nerve as well as into the common peroneal, common fibular or peroneal nerve. And over here, we can see the adjoining structures. We can see the gastrocnemius lateral head, the lateral sural cutaneous nerve. There is a sural communicating nerve, and finally, there is a sural nerve B, medial and medial sural cutaneous nerve, lateral sural cutaneous nerve, joining to form finally the sural nerve. Again, the posterior division to be signified, sciatic nerve dividing into the tibial nerve and the peroneal nerve on the lateral aspect. The same thing, dividing which particular triangle you have to see. Over here, there is a popliteal fossa, there is a triangle. On the tip of the triangle,
Mayank, there is no point in discussing popliteal fossa for that.
Yes, sir. Yes, sorry, sir. Thank you, sir. Thank you. Sorry,
going
sir.
on and on popliteal. I think
Right,
you love
sir.
the popliteal fossa.
Sorry, sir. Sorry. Stop to share. Right. Thank you.
Now I'll request Dr. Anshuman to share his views on femoral nerve block for knee replacement.
Thank you, Dr. Divesh, for the final topics in the fag end of the day. We started with the thorax, then did the abdomen, hip, and then now we are at the knee point. So basically, my topic today right now would be to discuss about femoral nerve blocks for knee surgeries. Now, what is more important is to understand the morphology of the femoral nerve. So if you can just check it out, see if you can see there is a little circumflex femoral artery is there. Just above that, it is dividing into two parts, the femoral nerve, into anterior division and the posterior division. It is very important because the anterior division supplies to the sartorius and the posterior division supplies to rest of the muscles. So it is important that we know why and why we need to know that I'll be explaining it now. So this femoral nerve, this is the distribution of the femoral nerve. This is a very famous diagram from the Nisora. So a lot of people must have seen this, and this is a very good diagram. So I just put it over here. Usually when you do a nerve block where the landmark guided, we just palpate the artery, we palpate the vein, the artery, and then we have the nerve. And we just draw a line from the anterosuperior iliac spine to the pubic tubercle. That's a inguinal ligament. Go a little bit down. There is a needle point of insertion. Now, when we see the under ultrasound, when you see that, what we see is that there is a femoral artery, the femoral vein is there, corresponding to that thing. And then there is a tough fascia that is the fossa iliaca. The femoral nerve usually sits below this, and we need to go here. Whenever you do an ultrasound guided, probably the femoral nerve block is one of the easiest nerve block to start with, other than the facial sheath blocks like the tab blocks. So when you see an ultrasound image, this looks more promising rather than this as a nerve. So what is important that we need to understand that it sits below this fascia iliaca, and this is the femoral nerve. Now, why I spoke about the morphology of this thing. So if you can see in this video, this is the femoral artery, and this is the femoral nerve. So this is the arrangement of femoral nerve is in a double-decker pattern. So you have one part for sartorius and one part for the nerve proper. So what has happened is that when you do a nerve block, we're doing the same femoral nerve block. So we'll be showing here, and we'll get a twitch. This is an PNS guided thing, just to see exactly know where we are putting the local anesthetic. So if you can just see, you're just entering, and we can see, just appreciate the twitch over here. There is a sartorius twitch. The sartorius is twitching. It's not the patella, dancing patella that we need to see. So what has happened is that I'm just showing the same video in an ultrasound. We are depositing the local anesthetic here, and we are getting the femoral nerve is here. We're getting there. We're getting also twitch, but this is basically the nerve to sartorius. So if we block that, we won't get the distribution of the femoral nerve throughout. So that is, you need to understand that part. Now, next part that I'm showing is a patellar dancing, and that I am just trying to show you. So this is, if you observe, this is what the patellar dancing looks like. And when we see the same thing in an ultrasound image, you can see the nerve is here and we're coming here. So the whole idea is that we deposit the local anesthetic below the femoral nerve. And everybody, when they say you should try to deposit it, just don't try not to pierce this line. Deposit it over here, and this femoral nerve gets lifted up. So this is exactly what we need. So this is being shown through by when we do in PNS guided, you can really find out yes, exactly this has happened. Just because femoral nerve block is important, another point what I want to just touch upon is that the genicular nerve block for any knee surgeries. Now, what basically we do is that we mark these 5. See, suppose I have marked this. If you can see, I have marked the knee. This is the medial side of the knee. This is the lateral side of the knee. So we have got 4 genicular nerves, as rightly mentioned by Dr. Mayank. So we have 4 points. One is inferior-medial, superior-medial, and we have superior-lateral and inferior-lateral. And I have put one marker over here also. Let me just play the video and then I can explain it. So if you can see, I have put a marker over here also, and this I have crossed. So I have done this knowingly. So what happens is that what I have done is that when you play, so we will put the probe over here. It's a linear probe. These are the points where you enter the knee. You enter into the knee. You will hit the periosteum. So this is the periosteum, and we will see how the video is being shown for a genicular nerve block. what I'm trying to do is that this is also another thing. So we have got 4 genicular nerves, but I have also put one other point over here. So this is basically a sort of femoral capsule infiltration also that helps in our patients for when we do a knee replacement, knee arthroplasty. This is the something we I haven't. Let me go back. This is something we do not. I do not put. We do not put in the lateral side, lateral inferior genicular nerve block, because it is very common to the common peroneal nerve, and there is a chance that you may hit upon it and there will be a foot drop. So this is a video where we're just showing the superior lateral genicular nerve block, and you can appreciate the superior lateral genicular artery over here. So if you can appreciate the artery is over here, the needle is here. You just come from this side, from anterior capillary to caudal, hit the periosteum. It's very superficial block, something around 1 centimeter below. And you can do it landmark guided. No need to put the ultrasound. Just for the imaging purpose, I have put the ultrasound just to show how nicely it is being lifted up. And the volume spreads 10 mils roughly around that duration apart, and you are done. Okay. And this is what I was explaining beforehand for the femoral part, for that capsule infiltration. It's a sort of variation of some LI or something like that. We need to use a small needle, and you don't need to go very deep. Again, it's a small, very superficial thing. And here the needle is there. Just need to deposit 10 ml of local anesthetic over there. So what happens is that in this combination of blocks, when you give combination of block, the amount of drug used is less and the quality of block is much better. Now there are certain articles which tell the benefit of using a genicular nerve block along with in a total knee arthroplasty patient. And this is one good article which I went through. And this is a comparison of genicular nerve block in combination with adductor canal block in both primary and revision total knee arthroplasty. It's a fairly recent article. And this is also another for a total knee replacement. They did a preliminary case series, and there was a technical note. So thank you. It's a very small presentation, but I hope I did justice.
Dr. Anshuman, I have a couple of questions for you.
Yeah.
You showed the dual technique in a way. For my understanding, do you advocate PNS guided as well as ultrasound guided for doing femoral nerve block for each and every block we need to do? Or you want to say that it has to be done in a selective way, or for the purpose of this demonstration, you use dual technique? So I want a understanding from you regarding.
Actually, my purpose was that the anisotropy is very common in a femoral nerve block. It's the commonest nerve to have an anisotropy. It's very difficult to find the nerve and inject the local anesthetic where you want it. Once we start giving regional anesthesia to a trainee, the first block usually they start doing is the femoral nerve block, because it's a fairly thick block. Its position is very placed properly. And my only demonstration was to show there is a difference when you are getting a sartorius twitch and we're getting a patellar-the-quad twitch. So just to show this, maybe we should try to do it all the patients, maybe we may not be getting this, but we got in a good patient and I was expecting to show this, so I thought let me show it.
So next point which I have, but as a question or as a comment for you is, like, you have demonstrated that the femoral nerve is in a double-decker kind of appearance. So don't you think 10 to 15 ml drug deposited underneath the fascia lata should be sufficient for femoral block? We need not go for this kind of a sartorius or a quadriceps switch.
No, supposing there are 3 ways to block the femoral nerve. One is do a landmark guided, one will do a PNS guided, one will do a USG guided. So when we have a landmark guided, we do not know exactly where we're putting it. Just in the landmark base, yes, you are putting it here. We do not know whether we're putting it above the femoral nerve or putting it below the femoral nerve. When you're doing it a PNS guided, we have an option of finding out where we're doing. My only message was that if you are doing a PNS guided femoral nerve block and you get a sartorius twitch, it's better to do it like this rather than go with the sartorius twitch. It's not that you don't act, it's just that it may take more time and maybe some fibers will lose. If suppose you're doing something just to get that benefit. Suppose you have got an ultrasound guided, so there is no question about that one. So anything everybody, we know that we just put the nerve, it's a very thick nerve, we just deposit below it, that makes it easy.
So for my understanding, you are advocating that for ultrasound guidance underneath the nerve is a good option.
Yeah.
So can I ask the other panelists, do you believe that for femoral nerve block, we need to do a underneath deposition or on the surface or on the lateral angle or whatever you do in your regular practice? Dr. Atul, if you can comment on this.
Yeah, it's very interesting finding, Dr. Mishra, and then I'll try to see this, but then my understanding is that femoral nerve divides into 5 to 9 branches there. And then if you deposit local anesthetics, if it is in the plane, it is going to bathe the whole femoral nerve. But then if Dr. Mishra has observed this phenomenon, then I think probably I'll pay attention to it. Anyway, I've moved away from the femoral nerve block nowadays, and it's a long time now I put in a femoral nerve block.
Sir, actually, this was the first time we were doing it, and we thought of connecting the PNS, and by chance we saw this, and because the same patient, and it was not 2 videos, it's the same patient. I have just chopped up the in-between part where I was doing the twitch and the ultrasound image. So because we got such a beautiful thing, so I thought let me put it here because the discussion is there. Anyway, you can discuss it.
Dr. Ravish, if you have any comments regarding this, where to deposit if you are giving femoral for any indication, leave aside knee replacements or ACL.
Unfortunately, femoral nerve in the body is the one nerve which has got a lot of anatomical innervation anomalies, like lot of variations in the divisions. It can be sometimes the divisions happens above the inguinal ligament. We have seen that sometimes below the inguinal ligament, sometimes it branches anywhere and everywhere. So what Anshuman has observed might be one of the episode, or I have not seen that. So whenever I do femoral nerve block, I do femoral nerve block only in one indication. That is for a continuous passive machine, for CPM machine, for a post total knee replacement. When they go for severe stiffness, they go on those machines which will continuously move the patient's knee to a fixed range, in which the patient will have agonizing pain. In that situation, I put a catheter there. There's only one situation. So it doesn't matter whether it goes above or below, but I use ultrasound, create hydrodissection, create a space around the femoral nerve. I can't exactly see the branches of femoral nerve. I'll see as one big femoral nerve and create a space using hydrodissection, then thread the catheter and leave it there. That works. So that's my experience.
Dr. Atul, you want to say something?
Yeah, regarding femoral nerve block, one more thing is important. And then I take utmost care that I'm locating lateral circumflex artery and medial circumflex artery, because if we damage those, whether we use ultrasound, when we are using ultrasound especially, if we damage that, then that can lead to avascular necrosis of head and neck of femur. In long term, I don't have any evidence about that. That's a level 5 evidence. But then I take utmost care because I know that avascular necrosis is caused by the avulsion of lateral and medial circumflex artery during hip dislocations, and then we should make efforts to avoid that injury. So I keep away from that. So whenever they divide and then whenever they come out, I put in my block below that level.
So for the benefit of the audience, I would like to summarize as far as femoral nerve block discussion is there. A few tips have been given. First is always have a Doppler there to identify the circumflex artery, as Dr. Atul has mentioned. Otherwise, it can lead to avascular necrosis. Plus, as Dr. Anshuman has mentioned, we need to be aware that divisions are possible. So if you are using a PNS guided, then look for a patellar dancing rather than a sartorius stretch. If you are doing an ultrasound guidance, probably a lateral portion or anterior or posterior, whatever you are comfortable trying to envelop the nerve is a good guidance. So, Dr. Anshuman, if you place femoral nerve block for total knee replacement, will you place it prior to surgery, after to surgery? What is your current protocol you are following in your institution?
Yeah, actually, in our hospital, the protocol that we follow is we give a IPAC and the genicular nerve block before surgery, and post surgery we put the adductor catheter, which is pretty proximal to the mid thigh. I mean, it's more near to the femoral triangle rather than adductor canal per se. So that's how we do it. Femoral nerve block, most of common, as Dr. Ravish said, I mean, basically do it a catheter only when you will feel that you need to prolong this thing of physiotherapy, number one, and number two, there is no risk of falling down. See, if you're blocking the femoral nerve, then the muscle weakness will be there. It has got fantastic. It probably has the best amount of analgesia. The quality of analgesia is very nice in the femoral nerve block because it is blocking a lot of nerves. The problem is that it is a major nerve also. So it will also be difficult. So we do IPAC, genicular, pre-surgery, and adductor post-surgery.
So as I can understand, Dr. Mayank wants to come in. What is your view about femoral nerve for TKI?
I fully agree with Dr. Anshuman. The reason is that what happens is nowadays the surgeon wants the patient to be mobile in the evening of the surgery. So basically, if we are going ahead intraoperatively, even with spinal anesthesia to undergo the surgery, the best aspect is what Dr. Anshuman mentioned. We should give an adductor canal block, which is a more beneficial block because femoral nerve block will produce weakness of the quadriceps muscle as well. And it is although it provides good analgesia, but there is a risk of having less of physiotherapy as well as movement, what surgeons want, approximately 8 to 10 hours of surgery, and they want somebody to walk. So it is always better to go ahead with the adductor canal. Yes, Dr. Anshuman, please.
Actually, just I wanted to add, it also depends on what your orthopod is doing as a surgical incision. Lot of time there is what I understood from the orthopedic person, there are two ways to do it. One they do is the vastus medialis separating, and one they are doing vastus medialis cutting. So if your person is doing a vastus medialis separating, then you do not need to block the nerve to vastus medialis. If they are doing a vastus medialis cutting, then you also need to block the nerve to vastus medialis. And when you block the nerve to vastus medialis, there is a quad weakness. So my thing is that, as Guru said, somehow I don't know, and probably everyone must be accepting that thing. Hip pains are not that painful, but knee pains are extremely painful. And our policy in the hospital is that we do not do bilateral TKR. We have explained to the surgeon that if you do it in a stage process, it's better both for the patient, for the hospital, for everyone. So what happens is that we get the patient and we do just put an IPAC and the genicular nerve block, and then give them with underspinal, and then give an adductor canal after that.
So I'd like to summarize as far as femoral nerve block is concerned for total knee replacement. For the benefit of the audience is, like my all panelists agree that these days they are not performing femoral nerve blocks. So they have switched to other blocks. So let's hear about adductor canal block as well as femoral triangle block from Dr. Atul. Over to you, Dr. Atul, sir.
Thank you very much. It must be a very tiring day for you in going back to another session. How to do PowerPoint. Come on. Slideshow. Slideshow. Can someone educate me, please? Because I can't see slideshow here.
I think you need to press the play button.
Yeah, play button. Thank you very much. Well done. Thank you. That shows that you are a moderator all the time. So we are going to discuss about adductor canal block and femoral triangle block, as said by the previous speaker, that nowadays we hardly use femoral nerve block. In my learning curve, to begin with, I used to use femoral nerve block in every patient. Then I moved on to catheter for femoral nerve. And then there was a talk about that range of movement is more when we block the quadriceps as well. But then came the ambulation. And then now we want to move patient quickly. So therefore, we are now going away from the femoral nerve block. Adductor canal block, we have got amongst the listeners, Dr. Shiv Kumar, who has written a nice article. Anyway, adductor canal is a fibromuscular band. It lies beneath the sartorius, subsartorial, Wonderwall and colleagues. They described local anesthetic block in 1993. And then later on, USD block was described in 2009. And then Lande et al., they described continuous block in 2011. This picture is from the publication of Dr. Shiv Kumar Singh, and then he has nicely described a PNS technique to put in an adductor canal block, and then which can be very, very useful where we don't have a particular resources, and it is very easy to perform, to locate the Jobert's fossa and then put in a needle and then stimulate it, and then get a block. So very nice thing. Regarding ultrasound guided block, I normally use ultrasound, and then I never use femoral triangle block, but then I identify sartorius muscle. In case you want to understand about the femoral triangle block, then anything above here is the femoral triangle block, and below there is the adductor canal block. And to my understanding, adductor canal occupies 1/3 of the thigh. And then if we go very lower down where femoral vessels disappear, it is safe to perform the block. And then after that, you can even milk the local anesthetics towards the knee and can get a better relief. But then we talk about vastus medialis nerve block as well. And vastus medialis nerve comes off the nerve too early into the femoral triangle. So if you are interested in putting in vastus medialis nerve block, in case your surgical technique is like that, then you need to put in a block here, and then after that, I will milk the local anesthetics in that direction. I won't go further up to put in a block. So using ultrasound to direct your local anesthetics in a particular direction is also a very good trick of trade. So here we go about the boundaries of the adductor canal. Thank you, Shiv, for a very nice picture over there. So this is the bone, femur. Then you can see vastus medialis over there. And then when you move your probe from there, you can see sartorius muscle, and you can see beneath the sartorius, because there will be skin there, you can see sartorius, beneath the sartorius muscle, femoral vessels over there. And that's how you identify the adductor canal. The adductor canal has got few contents. Normally, it has got saphenous nerve to vastus medialis. The obturator, articular branch of posterior division of the obturator, and subsartorial plexus. And then, so it is of huge importance from knee pain point of view, because if we are putting in this block properly, that takes care of anteromedial and anterolateral aspect to a certain extent of the knee pain. Here you can see the anterior division of obturator nerve coming off, and you can see the posterior division of obturator. They lie into the adductor canal, and this posterior division gives articular branch to the knee, and therefore it is important nerve to be blocked. And the nerve to vastus medialis is over there in adductor canal, which also get blocked when we put in local anesthetics. Obviously, saphenous nerve is there, we all know that. So how I do it? Very simple. I find adductor canal block is the simplest block. You can identify bone, move your probe medially, you see a muscle which is leaf-like structure, and beneath that muscle, you can locate the vessels over there. So that leaf-like structure is sartorius. You can't miss it even when patient is very obese. So that's how you locate the adductor canal. So moving probe from lateral side to medial side and locate the sartorius and vessels over there. Here you can see, once you locate the sartorius and vessels, I go up and down onto the sartorius towards the hip joint and towards the ankle joint, proximal and distal, and I try to see where these vessels are disappearing, because there it is more safe to put in a block and canal is better defined over there. So you can see again, sartorius muscle, we are going towards the knee, and then these femoral vessels just start disappearing, and then there you can see these nerves over there. They may be nerve to vastus medialis or saphenous nerve or articular branch of the obturator nerve. Then, once you do that, we take needle inside, you watch a movement of the tissues, and then you take needle towards the adductor canal. Very cautiously, because there are femoral vessels over there. So either your needle can come in this direction, about 45 degrees or so, or your needle can come parallel. If you make a distance, if you keep a distance from the footprint of the ultrasound probe, your needle enters parallel to the probe, and then probably you can reach over there. But then just remember that if your needle goes inside the sartorius muscle, the local anesthetics will be deposited intramuscularly and then will not have any effect onto the nerves. Here you can see, once you take your needle over there in this area, then you feel a click kind of a thing over the artery and you start depositing local anesthetics. After depositing local anesthetics, if you move your probe up and down, you can see that local anesthetics is spread all over the adductor canal. And it is very well defined space. And then that bathes the nerves very well. You can spot few nerves over there if you see. You can't say which nerve they are in this image because we are not following them thoroughly. But then yes, you can see few nerves around the local anesthetics, which is in the adductor canal. So if I'm interested in going towards the femoral triangle block, then at this point, I will start moving my probe with a little pressure towards the femoral triangle. Or if I want to include more of the genicular nerves, which I do that, I don't go for the femoral triangle. I move my probe towards the knee and then try to spread it. Sometimes I use about 10 mils of local anesthetics, but then I would like to use about 20 mils of local anesthetics into the adductor canal because I've seen a better effect. So I put in more volume. So I would prefer to use, instead of 0.5% chirocaine 10 mils, I will prefer to use 0.25% 20 mils of chirocaine for adductor canal block. To complete the pain relief with adductor canal block in my patients, if I may be allowed to say, please, then if you see this knee joint, then I ask surgeons, I give them 10 mils of 0.25% chirocaine and ask them to infiltrate onto the skin incision, which they make after the operation. And then I ask them, when they open the knee, to deposit some local anesthetics behind the capsule, which takes care of tibial and popliteal nerve, and hence the branches, articular branches of those nerves. Because I've seen that posterior cutaneous nerve is very notorious. If even when your blocks are working very well, if you have not given spinal anesthetics to the patient, if you're conducting it in general anesthetics, they have severe pain behind their knee. And then that is very, very disturbing. So that requires loads of morphine or paracetamol along with other analgesics. So in nutshell, I put in adductor canal block. I give 20 mils of 0.25% chirocaine to my surgeons. They deposit 10 mils onto the skin when they close it after the closure, and they deposit 10 mils of local anesthetics when they open the knee. Before putting in implants, they deposit 10 mils of local anesthetics behind the posterior capsule. And that's how I manage a knee pain. Thank you very much, Divesh.
Thank you, sir. I have a couple of questions for you. You have shown the true anatomical picture, and in various anatomical textbooks, we have seen that the nerve to vastus medialis appears to lie inside the canal. But if we actually go by some of the dissection studies which have been done by the regional anesthetists, they say it travels separately above the vasorectal membrane in a bilayered sheath. So what is your take on it, and how do you think your anesthetic, local anesthetic deposited in the proper adductor canal would actually seep through that membrane and get onto the nerve to vastus medialis?
So when you asked me this question, I started looking at the vastus medialis and nerve to vastus medialis and nerve to vastus lateralis. Before that, I didn't pay any attention to that. But then, having heard the question, I think probably in my clinical experience, that didn't make any difference to my patients regarding analgesia. But then now I know that nerve to vastus medialis and nerve to vastus lateralis also gives articular branch, because there is a Hilton's law which says that any muscle supplying or moving a joint, the muscular branch gives the articular branch as well to that joint. So therefore we need to take care of it. And then honest answer to you is that I will now start looking into it and then try to explore that what needs to be done. But then till date, I think that the volume, about 15 to 20 mils of the local anesthetics into the adductor canal, where femoral vessels are disappearing. And then after that, if you milk it up and down slightly, then that takes care of most of the nerves which lies into the obturator adductor canal. So if any of the panelists, they have got any experience about nerve to vastus lateralis or medialis,
Dr. Ravish, I'll start with you. Any take on this?
There is an extensive description of the anatomy. I don't want to go to that. When it comes to the adductor canal block, it is like one of the block for the knee pain. It is not just the block. It is one of the block, one of the few other blocks along with other blocks is for the knee pain. As Atul mentioned, I would like to keep further away from the as distal as possible in the adductor canal as possible, because we have to do the adductor canal block after the innervation of the quadratus muscle, because the femoral nerve is there, femoral artery is there, femoral vein, obturator branch is there, then vastus medialis. As you mentioned, recently I studied an article about the nerve to vastus medialis, which has got a separate fascia or a small membrane sheet. So then I said there was a mention of another kind of block called Siri or something block to go to the intersection of that plane. I'm absolutely, I think it is too much. We are going too much deep into this block. So as long as you deposit the local anesthetic sub and the subsartorial plex area in the triangle defined by sartorius, vastus medialis, and the adductor magnus in a very safer area away from the artery. And I prefer to go less than 10 mils, Atul. That is my take. The reason is I had few patients in whom I have used more than 10 mils, ended up having motor block. Probably the local anesthetic would have creeped up to the cranial side and blocked the motor component. Ideally, the adductor canal block should be a motor sparing block. You should not get the motor block whatsoever. So if you get a motor block, like might as well do a femoral nerve block. Why you want to do a adductor canal block? Isn't it?
Yes, you're right. Sorry, my statement was incomplete. So if I can see the good spread of the local anesthetics, I stay to 8 mils or 10 mils. Otherwise, I can go up to 20 mils. So that is what I wanted to say. Definitely, we take care of the size of the thigh, not weight of the patient. The size of the thigh when I put in adductor canal block. But then it is very, very important to not to deviate from the motor sparing effect of the adductor canal by judiciously using the volume. Thanks for reminding that, Ravish. Thank you very much.
Yeah, and moreover, it's the height of the patient which determines then the weight of the patient, because a longer patient, higher patient, longer length of the femur, and longer the length of the adductor canal. Though adductor canal is a very tiny one, it's a very tight Hunter's canal, very, very tight canal. Radiologically, if they inject, it can easily spread like as if you have injected something through the vein or an artery. So we should be very, very careful the volume of the drug what we inject. That is a take-home message for the audience.
Dr. Anshuman, any comment on this?
Sir, actually, as Dr. Atul and Dr. Ravish said, rightly, they are much more senior, they are much more experienced than me. So my only input was that the proximal we go, the chances of motor blockade are more, but the quality of pain relief is excellent. The distal we go, probably at that hiatus level, the motor blockade is less and the pain relief is okay. So we need to take a call how much you want to give and at what level you want to give. That is, I think, is the best.
Dr. Mayank, can you unmute yourself?
Sir, just one point I wanted to add. Like the senior said that distal we go, then we get a better block which is motor sparing. Okay, but one more important thing I want to add is that once you have given a distal adductor canal block, as Atul sir said, we have to block the genicular nerves as well. We can't leave them because they will produce the posterior cutaneous nerve, and that sparing leads to severe pain as soon as the patient starts to walk, and that produces the stiffness and cause less amount of motion. So that can be actually misleading for the patient in order to abide to go for the physiotherapy part of it.
Dr. Atul, I have a further few questions for you, because adductor canal block, as we all agree that this is the block of choice for providing analgesia for total knee replacement. So do you give single shot blocks with some additives, or do you go for continuous adductor canal blocks?
So in my clinical practice, as I mentioned in a previous session, we use 0.75% carocaine for the spinal anesthetics. And that has got wonderful effect till next day or 24 hours as far as analgesic effect is concerned. And then patients start ambulating as well. So the motor block disappears, the analgesia remains over there, and in combination then with the adductor canal block, local infiltration of the skin onto the anterior aspect of the knee, and some deposition of local anesthetics behind the capsule. I've seen that patient ambulating next day, not same day. We don't move patients same day. So I don't have any experience of that. but then they move with oral morphine, just oral morphine, and other multimodal analgesia. They are very, very comfortable. So genicular nerve, now I know that probably I can put in genicular nerve block just by going toward the periosteum after listening to the sessions. Otherwise, I used to search for the arteries, and then 50% of the time I failed to locate the arteries, all arteries, which can locate the genicular nerves. So therefore, we moved on to the local infiltration of the skin and posterior capsule, and then that takes care of, along with paracetamol, multimodal analgesia, and a bit of Oramorph in case patient is in pain. That takes care of that thing. Having said that, we have got two different kinds of patients, white Caucasians and Asians. So their pain threshold and pain response is different. I find that Asian patients are more difficult to manage from pain point of view, and then they require loads of analgesia than when you compare to the white patients, because we presume before operation that we are going to have operation, therefore we are going to have pain. So even if there is a numbness or slight soreness, we say that it's painful. While in the other population, they are they expect that there will be pain, most of them, not all of them, and then they react to that accordingly. And then sometimes they feel as if they are losing their self-respect by letting you know their complaints. So sometimes it is like that. So anyway, whatever is the reason, but then I have found that in two different populations, pain threshold is different in my clinical practice.
Dr. Mayank, you wanted to say something?
Just one small word. Nowadays, the surgeons are adopting a technique where they retain the posterior cruciate ligament. Once they are retaining that posterior cruciate ligament, the experience and the papers say that it provides greater amount of stability. At the same time, it produces less amount of pain. As Atul sir said, if you retain the posterior cruciate ligament and then you make the surgeon infiltrate into the posterior part of it with the help of local anesthetist, it usually takes care of the pain of the lateral as well as the posterior aspect and produces a better pain relief. So this particular surgical technique, and as Anshuman also mentioned, you are cutting it or you are not cutting the Vastas approach. So these two things have been modified by the surgeons in order to basically reduce the knee pain by them.
Okay,
which we should keep in mind when we are giving the blocks.
So I'll now request Dr. Ravish Shetty to help us how to deal with the posterior knee pain. Up till now, we have dealt with the anterior knee pain. So over to you, Dr. Ravish Shetty.
Yeah, I'll share my screen now. So you can all see my screen?
Yes.
Yeah.
Need to go on slideshow.
Yeah, I'll go there. Right. So we have discussed so many blocks and so many things to deal with the knee, because every nerve which goes through the knee joint on either side, left or right or in the posterior, they're all having their say in the knee. So we all know that the knee joint is supplied by, again, all three nerves: femoral nerve, obturator nerve, and the sciatic nerve as well. They've got all their branches. They are defined as the articular branch or the genicular branch, we call them. So posterior knee pain, as Mayank has clearly explained and in an extensive way about the anatomy. So it is almost like the nerve fiber just dropping like the roots of the banyan tree in the behind the knee. It's almost like every nerve, like for example, nerves to the vastus medialis also gives genicular branch. The nerve to the posterior root of the obturator nerve gives the genicular branch, and the tibial nerve gives the genicular branch, and as well as the recurrent peroneal nerve also gives genicular branch. So there are two ways to deal with the pain. One is patient factor and the anesthetic factor. Now the third factor, as clearly mentioned, is a surgical factor. How are they going to cut the ligaments? Are they going to retain it, or are they going to fiddle around the posterior part of the capsule of the knee? So coming to the tackling the pain, posterior knee, it is not just pharmacological. It is not just by a regional block, or when it's always a multimodal. That is the priority on the top of the grade of the recommendation. That is the top or level A. Level 1 or A recommendation is multimodal approach. There is no single way whatsoever to tackle the posterior knee pain. First one is the patient education. What I explained to you before in the previous session about joint schools and giving some education. They're having a surgery, they're anticipating some amount of pain. They will be mobilized as early as they can for preventing stiffness and early ambulation. They will be expecting pain. Those comes the part of patient education. Second one is preemptive analgesia. So preemptive analgesia, we use powerful opioids like oxycodone, like oxynorm, oxycodone, and in intolerable patient. We also use morphine and a COX-2 inhibitors preoperatively. That will also desensitize the pain. It's general way. That's what I'm doing. There is no single way. Next one is neuraxial blocks. So subarachnoid block, that is the superior and the gold standard for analgesia. There is nothing else which can come as close as to that. Yeah, or the epidural if you are doing a revisions. Peripheral nerve block, just now we have heard femoral nerve block, adductor canal block, then coming to the IPAC block. IPAC is my quite favorite for posterior knee pain. I'll be coming back to that in a minute. Then one is periarticular injection, or what you call as local infiltration analgesia, which is not in our hand, unfortunately. We tell, okay, 100 mL, 120 mL. The surgeons will infiltrate. And we assume and presume that they inject in the proper place, not just empty the syringe and give it to the nurse there. So most of the time it happens. So inject. The assistance is there. They will inject all around the soft tissue and they hand it over to the nurse. I don't know. We want them to inject specifically around the capsule, especially the posterior capsule if they have gone there. Next one is patient-controlled analgesia and oral analgesics. So just I'm going to talk about IPAC. IPAC is something new block which has come in the last couple of years, I think. But that is infiltration in the interspace between the popliteal artery and the posterior capsule of the knee. That is the IPAC stands for. Infiltration or injection of the local anesthetic in the space between the interspace between the popliteal artery and the posterior capsule of the knee. So I do this quite a lot for the patients who refuse spinal anesthetic and they want to go general anesthetic. So my general anesthetic technique is an opioid sparing anesthetic. That's a different topic. So because I do a lot of bariatrics, so I don't use any opioids intraoperatively. So I use only ketamine as predominant analgesia intraoperatively. So they do extremely well. So to spare the opioid, I always do IPAC block after I put them off to sleep. So this is how I will show you the video now. Just you'll be able to.
Dr. Ravish, does this video have a background voice? We are not able to hear any if this video has a background.
Are you not able to hear the background? I don't know how to send that. It is telling, but by the way, I will tell it in the meanwhile, no worries. So this is the infiltration of the look. Yeah, this is the popliteal plexus behind the knee, where it is the branches are coming from the tibial branch and the peroneal branch. Yeah, actually when we see the ultrasound probe is put in the posterior part of the knee, in the popliteal fossa, we will see the popliteal artery. Then you scan caudally, then you'll see the femoral head like eminence on either side and a depression. Then once you go in somewhere in between that, we see the space between the artery and the posterior capsule of the knee. That is a place where we infiltrate the local anesthetic, put the local anesthetic, just keep injecting and come back under the ultrasound guidance. So it will bathe all the genicular branches which are just dipping into the posterior capsule of the knee. Sorry, lost it again.
Today we'll discuss the IPAC block, which is an acronym for interspace between the popliteal artery and the capsule of the knee. The goal of the IPAC block is to deposit local anesthetic in the fatty space that lies just posterior to the femur and enveloping joint capsule. You can see here the femur, the popliteal artery, and the vein beside it, and the tibial and peroneal nerves inside the circumferal sheath. This technique involves inserting a needle from either direction and filling the IPAC.
Usually the needle is passed in the lateral side and we just inject the local.
There's a point to this. Behind the knee joint is a fine meshwork of nerves called the popliteal plexus, originating largely from the tibial nerve, but with contributions from the peroneal and obturator nerves as well. Blocking the popliteal plexus aims to provide posterior knee analgesia without any corresponding motor block of the lower limb. This block is primarily performed for total knee arthroplasty, but has also been used for other painful knee procedures such as ACL repair. The patient can be positioned supine with the knee bent or frog-legged, and the transducer applied to the popliteal plasma.
I normally position the patient on the lateral side so that the access is much easier for the scanning, the ergonomics.
While a linear transducer can be used, a
so I use curvilinear probe for this thing because the depth is quite important.
In order to get the correct position on the back of the femur, the probe is positioned on the popliteal fossa and the artery and femur identified.
First identify the artery and then the lower end of the femur.
At this point, the probe should be slid proximally until the humps disappear and a flat metabolite.
Once the hump disappears when the scan, that is the time when we can inject the local anesthetic in that plane.
Okay, so here's the technique. We first find the condyles and then return to the metabolite.
Identify the medial and lateral condyle of the femur.
Ravish, the video is not moving, man.
Video is not coming.
No, it's just stuck at just an image, single image. Yeah.
Oh.
Oh, it's now. Yeah.
Yeah. Yeah, that's where the needle is passed between the artery and the medial side of the femur. Then we are just pulling out the needle while we are injecting the local anesthetic.
We use 0.2% pivocaine with 1 in 400,000.
So we normally use around 0.25% levobupivacaine, around 15 to 20 ml. It's a volume block. So we are not blocking any particular simple nerve. So instead, we are doing a volume block.
For one, calculate the distance from the probe to the IPAC space and insert the needle accordingly. For example, if you see that the space is 4 centimeters deep to the probe surface, insert the needle in the lateral thigh at a point that corresponds to 4 centimeters deep. That way.
Yeah, because I could not share the audio in that thing. So IPAC is the block which is gaining popularity for treating the posterior knee pain. So, but here there's a small slide I need to present, especially for the trainees. So what is a good evidence for practice? So it all depends upon what is recommended. The priority of the recommendation is level 1, level 2, level 3, level 4, level 5 studies are there. So level 5 is the least, that's a personal opinion or a case review or their own opinion. Whereas on the topmost is the meta-analysis. In the multicenter study, prospective, randomized, blind control, all those things are coming in the practice. So if you look at preemptive analgesia or priority 1 and 2. So it has got a role for controlling the posterior knee pain. Multimodal, always on the top. Preoperative patient education, still partly it is showing evidence and partly in some of the places it is a bit inconclusive. So use of regional anesthesia, it is always on the top of the thing. So we have to know multimodal analgesia for posterior knee pain. In that, again, the regional anesthesia take the priority. Then using all other adjuncts and other medications for tackling the posterior knee pain.
Thank you, Dr. Ravish, for enlightening us on this topic of posterior knee pain. So all of us agree that a ductal canal block plus an IPAC would do good for total knee replacement. Dr. Ravish, what is your choice if you are doing the ACL? What would be the regional anesthesia block of choice in case you are doing the anterior cruciate ligament reconstruction?
ACL, I always have done a straightforward general anesthetic with adductor canal block. I used to do, but I have not done an ACL for, to be honest, last couple of years, because we have stopped doing all those things. Like slowly we are getting back to those elective sessions because of the pandemic. So now I will start trying IPAC along with adductor canal. Might help. So definitely general anesthetic with adductor canal used to help the patient a lot with some local infiltration by the surgeon at the end of the procedure. So they do arthroscopically in our center. So,
Dr. Mayank, what is your take on ACL?
Sir, we are using general anesthesia, adductor canal block along with IPAC.
Okay, so I think that appears to be quite universal. Sir, Dr. Atul, sir, what is your take on anterior cruciate ligament reconstruction?
My surgeons are very good. They infiltrate locally, and then the patients are pain-free.
Okay. Anshuman, any comments from your side?
Yes, sir. It can be spinal or general anesthesia, and along with that, we give adductor canal single shot.
Single shot. So, for the benefit of the audience, for ACL, it can be GA or spinal. Plus, if you need to do you have to do a regional anesthesia technique. Then it has to be either a adductor canal with a IPAC or adductor canal, or a local infiltration anesthesia, as Dr. Atul said. Anshuman, you want to make some comments?
Yeah, actually, I wanted to say any pain per se, be it knee, be it hip, be it any surgery, regional anesthesia is part of a multimodal analgesia. So we should consider it not as the primary modality, but this is something which is going to, rather than sparing, if we can decrease the use, that is good enough. And as Atul sir was saying, that because of the racial, there's a difference in the Caucasian and the Asian population about the pain bearing capability. So if you are coming to a good hospital in our setup, and patients are demanding, the surgeon is demanding and the patient is demanding. Surgeon wants that patient should not have any motor blockade. He should be up and running the next day or the same day, and the patient doesn't want any pain. So there you have to make a balance of whatever is available, your expertise, and then get the thing done. It's always an evolving field, and maybe in the next panel meeting, we have some other, as Dr. Ravish said, he said there is something called Siri block, and probably I had also discussion with you regarding the same. I mean, a lot of things are coming up new, and probably some new will come up, but we need to see a balance between how much we're gaining for the pain part and the mobility. That's my
Dr. Mayank, your comments?
Just a small experience that I want to share. My father-in-law got operated for total knee replacement 14 days back. Since we are discussing total knee replacement, so the most important thing that played in his mind was pain. But we educated him very nicely about the extent of pain that he will be having post-operatively. So this protocol should be followed, that a person should come in a PAC clinic of yours and he should be guided by an anesthesiologist what we are going to do. We shouldn't keep them hiding that you won't have pain. Yes, you will have certain degree of pain, but we will take care of most of it. So it will be not a complete pain relief. So that particular mindset needs to be established. As Atul sir said, Caucasian and Asian, but these people need to have certain mindset actually, pre-handed, in order to prevent post-operative pain also. So education in the pre-operative part and PAC also plays a role.
Before I actually request Dr. Ravish Shetty to give his final take-home message, I would like to leave you with some points to think about. In 2007, there was a paper in Clinical Anatomy by Tubbs et al., where they showed that the vasoadductor membrane is penetrated in 70% of the cadaveric dissections. So there is a chance that once we deposit the drug inside the adductor canal proper, it's the volume of the drug can seep upwards towards the nerve to vastus medialis, as has been described in some of the recent papers by regional anesthetists. So that is what I was thinking. Even in my practice, I do the same. We just locate first the artery dipping, and almost 3 centimeters prior to that, we inject the drug. But the drug which I'm injecting is 20 ml. I'm not doing IPAC. The reason I have is there was an article in DJA where they showed that ED95 volume of the adductor canal, which is around 11 centimeters in majority of the individuals, is 20 ml. So if we are in the distal part of the canal and we inject 20 ml, my rationale is that it will seep through the adductor hiatus to the popliteal plexus, thereby avoiding the need for IPAC. In my practice, I never have faced posterior knee pain. So these are just some of the things which I leave you to think about. So final words from Dr. Ravish as regards the take-home message for PKRs and ACL.
Yeah, thank you. Thank you, Divesh. I think from our experience and reading the articles and everything, I think coming to the patient preparation, let's talk in the three sense: pre-operative, intraoperative, and post-operative. Yeah, pre-operative, we should always try to educate the patient as much as you can, even in the limited number of time. So like we used to run joint school or giving some information leaflets to the patient that can be done everywhere, either by the surgeon or by the anesthetic team in their local languages, whichever the part of the world it may be. Even if you come to our Liverpool, we have got the leaflets in 4 languages. We have got in Chinese, we have got in Hindi, we have got in Urdu, and we have got Tamil, and then English as well. So, and it's a small country and it can be implemented. I know it's very easy, but it is not that difficult either back home. I know. So patient education, patient preparation, mentally prepared by the patient and the surgeon. Surgeon cannot give a message and anesthetist another message. We should not give a mixed messages to the patient. A surgeon telling you will be able to walk tomorrow morning. Then we are coming and telling, no, you cannot walk tomorrow because you might have a motor block or anything like that. So whenever we convey the message to the patient, it should be a common message, not a mixed message. Okay. Number 3, there is always a role for preemptive analgesia. Never forget, we can use the locally available nice opioids, well tolerated by the patient. Again, I don't want to comment on the gabapentinoids. It will churn a lot of turbulence and a lot of discussion. So that is out of equation because according to my literature studies, its evidence is inconclusive. So not supporting, not throwing away. So preemptive analgesia still role for a non-steroidal anti-inflammatories or COX-2 inhibitors, whatever is available. In our place, we have got access for celecoxib and an injectable form of paracoxib. Probably it will be similarly available back home as well. So preemptive analgesia and intraoperatively, gold standard anesthesia, spinal. Adjuncts, my favorite is clonidine, and we can use clonidine without any other problems. And other than the hypotension, I have not seen any other complications. So intrathecal clonidine or intrathecal diamorphine is second choice. Smaller dose is ideally recommended for early ambulation. That is our motto. Lower dose, quick recovery of the motor block, early ambulation. Ambulatory arthroplasty, again, it is inconclusive. We can't comment on that thing now. So that's another different topic. And intraoperatively, adequate hydration, nice sedation is whatever is available, just for the comfort of the patient. Good antiemetics to avoid post-operative nausea, vomiting. Intraoperative paracetamol and non-steroidals if the patient has not taken preoperatively. Then post-operatively, early eating and drinking as soon as they can. That will make the patient psychologically more a step closer to the recovery. So regional anesthesia is always superior than general anesthetic. And then post-operatively continue for some strong opioids for maximum 24 hours. That's all they require. Then step down to weaker opioids, non-steroidals or selective COX-2 inhibitors, paracetamol, and discharge home early ambulation. And one more thing I wanted to tell was post-operative nausea, vomiting is another thing which limits the recovery. So adequate hydration, intraoperative antiemetics. That should be fine. And if you're using general anesthetic for the thing, my personal thing will be opioid-free anesthesia. I use intraoperative ketamine, which will reduce significantly post-operative requirement of the opioids as well. Small dose of ketamine up to 30 to 40 milligrams in an adult, and a tiny bit of midazolam to avoid the emergence. So hallucination and things like that. So that's all my take home.
Thank you, Dr. Ravish. We are almost coming to an end. Just last comments from each and every panelist. Dr. Atul, you want to say something before we actually close?
Thank you. Thank you very much, Divesh. No, my point is everything which other panelists have said, including you as a moderator, but then know yourself, know your limitations, know your qualities, know your patient very well, know your surgeon very well, take care of time constraints and workflow in the theaters, and you will be an excellent anesthetist.
Thank you, sir. And Dr. Mayank, any comments from your side before we actually close?
Thank you so much, sir. Sir, just one thing, as sir said, hydration is extremely important because the muscles can go into cramps if there is a dehydration part persistent. So that can prevent the further mobilization of the patient as well. So hydration is one of the components that has to be kept into mind, and that will help in better recovery of the patient. Rest. Thank you so much, everyone. And just be cautious. Whatever technique you are using, first be confident about it and then proceed with it. Because patient's life is important. And we are giving it as a pain relief, not for any other purpose.
Dr. Anshuman, your final comments?
Thank you. Thank you, everyone. Probably as panelists, we learned a lot more than what we, as Shiv sir used to say, as we teach, we learn. So we learn a lot more when you start teaching rather than learning. So it was an excellent learning experience for me. I learned a lot. And thank you, the option of that I was given a chance for. So thank you.
Thank you,
so
everyone.
just one more thing. Just one more thing. A small instruction, a small food of thought. See one, do one, teach one. I think this is a very good technique actually to improve yourself. My teacher used to say is that whatever technique you are using, see it once. Then you try it once and then you teach it. Once you teach it, you know what mistake you are committing and then you will try to improve upon it. So I think this could be a helpful thing for everyone to follow.
Thank you. I'd like to thank every one of you for contributing towards this panel discussion, and it has been a long day for all of us. So over to you, Dr. Shiv, for the closing comments for FARA.
Oh, thank you. Thank you to all the moderators, to all the faculty. Over the last 2 days, I think it's been an amazing experience for everyone. I think we had very good response as well. This is the first time we conducted in this way. I mean, this was a new way of, I'm not talking about the e-conference as such, but talking about the way we looked at the, procedure specific regional anesthesia. And maybe we will likely again learn from whatever mistakes we're making here today. We will try to rectify them in the next one and probably have a better conference next time. But by then, hopefully, we will likely have a face-to-face conference, which are always better. I think meeting everyone in person is always good. Good for the audience, good for our psychology as well. So thank you, Divesh, for actually taking the initiative and making this a success. And thank you, everyone, and have a nice weekend. There's not much left in India. We still have a few more hours to.
Thank you so much, sir. Thank you so much.
Okay. Bye.
Thank you.
Thank you very much.
Thank you all. Thank you, everyone.